Hello, Andrea Cusi. Andrea, with the you joined the group of Andrea. You joined the group of artificial intelligence. You need to put a picture up there.
Yeah.
Hello, Andrea. Are you there? Are you there, Andrea?
Can you hear me, John?
Is this Andrea?
Yes, I am.
Oh, good. How you doing, Andrea? You heard that, right? Yeah, Andrea, how you doing? I'm Dr. Bennett.
Hi, Dr. Bennett.
Yeah, let me get out. I'm on another. Okay, I turned the sound off on that. Yeah, Andrea, with the artificial intelligence, please put a picture there, okay?
Yeah.
In the doc social, let me show you here.
Yeah, understand.
I think that's going to be a really good group once it gets going. Right now, people don't really know what it is, but it's going to be the best. And I'll show you why. It's like WhatsApp, but it has video. Okay, even though WhatsApp is starting with video, this has a bulletin board built in, and it has some other tools. Okay, so what you need to do, let me get the members here. Okay, I go to the group. Okay, members. Oh, maybe you have your picture there already. Yeah.
Yeah.
Yeah, you see, yeah, it's not here. You see right here, right?
Yeah.
Okay, you should please put your picture because it's to identify you. This is not secret. No, not secret. As you're a doctor, you got to show your face. Okay, you understand. You understand.
Yes, I understand.
Okay, very good. Okay, we start in about 20 minutes.
Yes, I see. I am here to see the conference.
Yeah, you're. What part of Italy are you in?
Thank you, John.
What part of Italy are you at?
Bologna.
Oh, good, good. The center of anatomy, neuroanatomy.
Yes.
That's great. Okay, we'll see you in a while.
Thank you, John. Thank you.
Okay. Naran, how you doing? Are you there? There's Naran.
Hi, Professor John.
How you doing?
I'm doing very good. Thank you. How are you?
Good. Let me show you this website real quick. It's it'd be an excellent
Just a minute, Dr.
addition.
John. I'll log in from my computer. This is just my phone. I'll log in from my computer. Just a minute.
Okay. Hello, everybody. Oh my God. It's Superman. Hello, Young Hong.
John,
Hey, Young Hong, how are you?
good.
Where's your cape?
You may have.
No, you have the cape now.
Yes, yes.
You must send it to me. You must send it to me.
Sorry. Yesterday I have forgot the data. So when I come here, I have not prepared my PowerPoint.
You are crazy. You are crazy. Most people, when they have a paper and not ready, they don't come. They don't come. It's a secret. But you come and say, I don't have paper.
When you come here, you are happy.
I loved it. That was great.
Yeah.
That was great. Young Hong is here. Yeah, I'm here, but no paper.
No paper.
I have good
I
news.
think it is important to appear.
Yeah, well,
Yeah.
some people would disagree with that. They
paper
would
is
hide. They would
document.
hide. They would go hide. Hide. Maybe they don't see me. Forget about
How are
me.
you?
Good. Very good. Very busy. Very good.
Yes.
How about you? How about you? You do a lot of
Recently,
system.
I'm also very busy.
Yeah. You doing any webinars at all in China or no?
Because recently I have established a society of traumatic soldiers.
Wow.
So there is a lot of work to do. So a lot of things.
Okay. If ever you want a conference, if ever you want to do a conference, let me know. If you want.
Maybe in several months we have conference in China.
Yeah, and you can
Yeah.
have it in Chinese. In Chinese.
Yeah, maybe late half this year.
Okay, let me know. We can televise it.
I will invite you to come China.
Yeah, I would love to, because there's a lot going on in China.
Yeah.
You know why? A big news today. Let me show you. Let me show you big news. Really big news for Zoom. Let me show you. Hold on. I show you news because we are translating more now in Chinese.
Oh, yeah.
Okay, this is big news for everybody.
Oh.
You see this language interpretation and webinars at the same time. I think they send an interpreter, I think Zoom, to the meeting, and they are in the panel and they translate to different languages. You see this?
Great.
Isn't that wonderful?
Wonderful.
I cannot sleep.
You are exciting.
Well, now now you make a conference, everybody can watch it. Everybody, not now, but maybe in 6 months, a year, when the translation is better. But you make a conference in China, you can translate to anything.
Yeah, that's good.
It's good.
The conference makes you exciting.
Yes, I'm excited. It increases business and is better for business in the future.
In future, yes, very important.
Yeah. If you make a conference in neurosurgery in China, they can watch it in Africa and know what you say.
Like my neurosurgery department, a lot of the young neurosurgery doctors like to communicate with doctors all around the world.
Yeah, you're right. Now your conferences can apply to anybody. Not yet. Maybe in 6 months. Now they just have the major languages: English, French, Chinese, Japanese, probably Spanish.
Yeah.
Yeah, but later I think they do all languages. Because the computer technology moves fast.
Yes.
Moves fast, very fast.
Very fast.
Very fast. And so when they say it's going to happen, it's going to happen.
Faster than you and than me.
Yeah, it's great. I love it. It's the best time in history to be a doctor. I think. Well, after this is over,
Yeah,
It's
yeah.
it's
because
going to be,
like this year's doctor watch videos at the lectures, very easy, very convenient.
yeah, I want to be young again.
Yeah, yeah.
I want to go into machine that makes me young.
Come back to kids.
No, there's a place, I think in Taiwan where the people live very old, more than 100. It's some island off China where the diet is a lot of fish, but the people are unusual because of their long lifespan. And they're trying to figure out why they live longer.
Mhm.
So, okay.
Okay.
Okay, I'll be with you in a second. We start, I guess, a
Okay.
little late as usual. Oh, Naran, I'm sorry, Naran, I
Hi.
ignored you there. I ignored you. You're back.
Yeah, I'm back.
Yeah, you know Young Hung. Nice table. That's a nice table. Hey,
Yeah.
you know Young Hung, right? Young Hung.
Nice to meet you.
Hi, Professor Yang.
Hi,
How are you?
I'm Yang.
Yeah, I
Yeah.
can. Thank you. Thank you for inviting me, Professor John. Thank you.
Yeah, this is, I'm just going to have a dissection lab.
Yeah.
Yeah, it's physically, it looks good.
Good.
Looks good. Let me show you, and I'll show Young Hung. Oh, I already show Young Hung, but let me show you big news today, Naran.
Yep.
Zoom, they can translate into the major languages.
Wow.
And I don't know, I think what they do is you arrange for someone from Zoom to come to the meeting and they translate it in real time.
Wow. That's
So,
great.
that's big news.
Yeah.
Because your lectures now can go into Filipino or go into, Spanish.
Great. Great.
Yeah, but it's not ready yet. But I think within 6 months to a year, it'll be ready. Now it's just major languages. And to get a good interpreter, you need a neurosurgeon, obviously, or someone that knows, it'd be difficult if you were just a translator to know, skull-based surgery. So anyways, so
What
that's
we're doing right now, Professor John, is that we ask one of the participants who knows English and maybe Brazilian or something like that to actually translate inside the hall. So that's how we are doing right now.
Yeah, you can do it. You can improvise. Yeah, we do that too. We have someone else start another Zoom. Like, for example, you would have a laptop with you.
Absolutely.
And then start it in another language and run a Zoom.
Yeah, that's right.
Yeah, so it can be done now.
Yeah.
Well, let me show you this website that you've got to join for your ENT group because they're so active. It's a very active group. And you can just start a community here. Just look at this real quick, Naran. You see this Doc Social?
Uh-huh.
So when you create your community, you already have a community board. And the good thing about this is you're going to have like a Zoom that's built inside the platform. Hopefully it'll make it easier to make a Zoom within the platform. Do you see this?
Yep.
And now I'm making a meeting, but you make meetings with other people in the platform. And you don't have to leave and click 7 times. So anyways,
it's very interesting.
yeah, it's a good, check it out. Your community, I think, would love it.
Yeah, that's great.
So let's see here. We got we start and, we're past the starting time.
I think we're going to start at 9:30. The information which I got.
Oh, okay. There's a beach. There's a beach, Young Han. So you know what we're gonna do, Young Han? I live over here.
Yeah.
I live here. You see my arrow?
Very good. Very good.
Okay, soon we have a convention here at this hotel. But we only bring the speakers.
Mhm.
No, just the speakers come to Miami Beach. What do you think about that, Naran?
Mhm. Walk around this beach.
It's a very nice beach.
Yes, very nice. Miami's beach.
Miami, yeah, Miami. It's an island off Miami.
Miami, yeah.
Yeah, and there's Miami, but Miami Beach is an island.
Very beautiful beach in the wood.
What is what?
Very beautiful beach in the wood.
In the work,
In the wood.
in the woods. Oh, wait, I'm starting. Wait.
iPad is coming.
There's no microphone. Let me tell it's not hooked up there.
My time is
iPad setting up now. We'll try to get the sound.
more people treating doctors and all that.
I'm giving it to you, but this will just remind you to be experts.
Okay,
Right?
are you working on the sound?
Yep.
Yeah.
Okay, we have it. Okay, we have it.
We are
We
distributing.
have it.
Record.
Good morning, everyone. It was quite a nice experience coming here and experiencing all the teaching that sir has taught us. It was a novel opportunity for us since in our college we did not get any hands-on on any cadaveric dissection. So it was a good learning opportunity, and I hope to come again and continue for the journey. Thank you.
Dr. Rahul Srinivasan.
It was a wonderful experience. So thinking of cadaveric dissection, there's not much of cadaveric lab in India. I think other than names, we don't have any other cadaveric dissection work. So it's great that sir has come to India and started one such center. We see much more sessions. Only thing we had lack of this microscope, so that we would adjust in next sessions, coming sessions. Would definitely recommend the juniors to attend this and take benefit of it. Thank you, sir. Thank you so much. Yes.
We are just starting now. We will take the upper equipment soon. The next time you come, we will have a world-class lab. Dr. Karthik Manoj Nutan.
It was a great experience here. Like, we just got our insight to skull base for the first time in our careers now, and we hope to improve on this basic skills later, like become skull base surgeons later in life. Yeah, thank you, sir. Thank you for the opportunity.
Dr. Pradeep Kumar Gupta.
I want to thank Professor Charin sir for this wonderful opportunity, and it is a wonderful program, and we learned a lot, especially skull base dissection. We as a beginner we don't know how to proceed to intraventricular cleaner to extraordinarily, and we learned a lot. Thank you, sir.
Okay. Dr. Sparsh Pandey.
Today, 1 second. Today, whoever is going to do the endoscopic dissections, let me know who wants to start the endoscopic dissections. We will guide you. That's no problem. Trishan has been with me for a bit. So maybe you can also guide.
Dr. Ganesh will be coming.
Ganesh also will be coming. So we will go on the sagittal plane. And if you guys are interested, we'll go on the coronal plane as well. Okay. We'll, today, unless I go very fast, jugular foramen will be a problem, but definitely CPI angle and all that can be achieved. But if you want to do the Dawlings along with that, so that we can have a correlation of 360-degree anatomy, that also can be done. Okay, according to you. Right.
Dr. Hari Singh Parmar. Dr. Dhruv Kumar Baru.
we all know that how good the class was, but I would like to make a few special mentions. First suggestion would, I think we can do a 3-day course, Friday, Saturday, Sunday. So we can go at ease. Secondly, I feel neurosurgery, sometime or the other, we can learn from sir, but the life lessons he teaches us. And his attitude to be not be small-minded. Like most of the people who teach, they tend to keep the things to themselves. But the best thing about sir is, as now also he said, that teach and impart it to your juniors. So I think that is more important. So
Grow above that, and then you will be happy. All right.
Dr. Saurav Dubey. Dr. Jayan Gaur.
JMC.
Dr. Jatin.
And any anatomy is the soul of any surgery, and sir is providing a platform to look into anatomy of neurosurgery, and this is the excellent platform sir has created. Thanks for giving this opportunity, sir. Thank you.
Dr. Jatin Kumar Umawani. Dr. Rahul Sharma. Rahul Sharma.
It's nice to be here, and it's an honor to learn great things from Professor Akcharian. There are few surgeons who taught their skills, and they want all other neurosurgeons to become like this. And I'm very grateful to their respective team members also. They're working very hard. Congratulations, and I hope you can continue this kind of academic fest in the future also.
You guys want to do some anastomosis today? Would you like to have your hand? If anybody is interested in anastomosis, we have a 3D Bytome. You can watch in 3D and also do it in 3D. Okay, 3D Bytome tab for anastomosis. She will be teaching, and I will also be teaching anastomosis. Manuel also can help with 3D anastomosis. Nilesh, if he has the time. Nilesh is the busiest man. So if you guys are interested, come down, because anastomosis again is skill which is highly, highly overestimated. About 40 years back, even residents used to do anastomosis. Even in Europe, everywhere, residents used to do anastomosis. But now what has happened is only a few centers, especially in Japan and then India, now it's starting to do. They're starting to do. And believe me, you do anastomosis, your surgical skills will go 10 times more, because you will learn how to be gentle. If you are not gentle, the needle will break, that string suture will break. You have to be gentle. So that is anastomosis would be a good platform for you to learn proper tenets of surgery. You start doing this primitive, terrible things like decompressive hemicraniectomy and all that. You can do anything with brain, and you panic at the first instance. These are all not good things to do. Okay, then when things don't go well, then the easiest way out is to write and get glory. Okay, it's not. This is how the direction is. The direction is going these days. So don't do that. If you have the chance to today, go get some. Let's do some anastomosis. I'll also come. Okay.
Dr. Subba Reddy.
You can do one now. No problems, no doubts.
Good morning, everyone. It's like a wonderful experience. When I was coming here, and I felt maybe cadaveric dissection, what I can do, maybe I can learn. I thought, but not this much as I thought actually. So it was excellent experience here, and also Acharyan sir, how we explains, it's like a how we tell some 6 years kid how you explain. That part actually definitely not expected. So I think all of you, I think everybody learned this approach and reaching the skullways. It is really beautiful, I felt. And also the way he teaches, I think everybody should learn that. And most of us hear the saying and people saying that, oh, there is no spoon feeding, you have to learn your own self, and then there comes mistakes, and we'll go on doing some problems outside, and then we'll lack of confidence. But I think these kind of courses and teachers definitely society needs and people needs, then we can grow as a humans, and we can reach at higher levels, I feel. So thank you, sir.
Dr. Aniruddha.
Being from a private institute, we rarely get a chance to see any cadaveric dissections. I used to see videos of skull-based surgeries and cadaveric dissections, but since last 6 months or 7 months, I've been searching for such courses. So I was lucky that I found the registration form online on the WhatsApp group, and I immediately registered for it. So that I'm thankful for that thing. And the second thing, I will definitely come back again for the next course. If all of us do all the surgeries, then it would be beneficial for the patients, that the patients won't need to go for a higher center for every small surgery or be it a higher surgeries.
I have a problem with virtual learning. I don't believe there is obviously concepts can be learned virtually, but if you want to learn what the feel of each surgery is, cadaver labs have been important for the last 800 years. Okay, starting all the way back to Leonardo. Have you seen David? You should go see David, the sculpture by Michelangelo, right? Leonardo da Vinci's paintings, sculptures, these things are so realistic, and it's only possible because they would do extensive cadaver dissections and make drawings. The same way, can you make love virtually? It's impossible, right? Making love virtually and making love in truth, in reality is different, right? There's a huge difference. It's exactly the same thing that if you learn virtually, cadaver lab, if people make 3D and all that, and then they show this is how you cut and this is the feeling. No, you go to the lab, okay? Go to the lab, spend your time there. Maybe you will be having formalin fumes, but sit there, learn. That's the only way you will excel in surgery. Every single master you see, Louis Borba, Ali Krish, Yasagil. Yasagil did his first surgery when he was 42. When he was 42, okay? I was with Yasagil in Turkey 2 years, 3 years back, and I had the good fortune to spend a lot of time with him, okay? And he was telling me his first surgery he did was 42. Not before that. But he was a master. In 4 years, he was like known all over Europe because he was so good. Because he had the lab training. So you guys worship the lab. Huh? It will be like an extension of your OR room. Get a lab in your place. I don't want, you told me you come back, I would prefer that you have a lab in your own place. Okay, each one of you make a lab in your own place. Call me, I'll be happy to come. All right?
Dr. Rushabh Chadda.
Come here, man.
You can speak now. Dr. Nikhil Talati. Dr. Dheeraj Pant.
It was such a wonderful experience coming in here and learning basics and a lot about the skull-based dissection. I was not aware that this much can be learned in a single session, and I'm very much thankful to sir for providing us this much opportunity and providing such learning in just a period of 2 days. Thank you, sir.
Dr. Anup Shastri.
Okay, well.
Yeah.
It was a great experience working here. Actually, a lot of doubts about the skull base got cleared yesterday, and today sir will clear some more doubts also. And I want to tell that when we were residents and our sir will be doing all these cases, at that time we will be not be understanding anything. And when we start doing independently the cases, then there will be no platform to go and see what is there, who is doing, uh, and I think we can't ask any questions to anyone because everyone will think that we are already surgeons. So whenever I was sitting in my hospital and when any skull base case used to come, I used to refer it to higher center. I means thinking that I think we were trying to escape from that one because we were thinking that it's only for big boys and not for us. So yesterday, many of the doubts got cleared, and I think we can start in our hospital only from now. Slowly, it may take more hours, but I think definitely we can start doing it. Thanks a lot, sir, for teaching.
You should, everybody should. Huh? Big boys is in the mind. Huh? There's nothing, no big boys. Huh?
Dr. Aryan Patil, Dr. Srikant Kalbagwa,
It's been pleasure to be here, and thank you, sir, for teaching us these things. And we hope that we will get this opportunity again in the future.
Dr. Mutuza Dadla,
I would like to thank sir and your entire team for this wonderful experience of 2 days. We learned a lot yesterday. We plan to learn a lot today also. And we hope this will help to build our careers in the future for us and for our entire, my colleagues, my juniors and everybody else. Thank you so much.
Dr. Devdatta Patil, Dr. Sushil Boga,
It was a very excellent session. We do so many craniotomies, and in that we do usually do sphenoid drilling and all, but we were afraid to go ahead of that, filling the cavernous sinus, and that door was never opened, and we were afraid to open that door. So yesterday, sir explained it very well. Now we are very much confident to do that. And sir, I will definitely come back with my own cases and my own experience. Thank you, sir.
Dr. K. Sudhakar, Dr. Rahul Singh, Dr. Manda Patil,
We had a wonderful academic session yesterday. Thank you, Cherin sir, for it. And after I had my first cadaveric dissection yesterday, and after it, I'm thinking like why it's not done in India routinely. So it was a wonderful opportunity, and looking forward for more. Thank you, sir.
Dr. Narendra Mutala, yours was the last entry, your name is not there. You have to write it down. I'm really impressed with your cysternostomy results, sir. There is so much to do in trauma. I realized after seeing those videos, and definitely will try in actual practice. This is a great initiative, and I would like to thank you and the whole team. Thank you so much, sir. We will felicitate our faculty members also. Dr. Chaitanya Godbole.
Actually, I come here on Fridays, once a week. And the way they are treating me like a family and involving me in everything, I'd like to thank everyone for that. And I'll try to be a team member and extend my support as much as possible. And hopefully we will trouble you on every Friday to do more case dissections and for more teachings. Thank you. Thank you, Nilesh. He has done a wonderful job for last 1 month. Every week I'm with him and his phone used to ring continuously. I thought of throwing it out once or twice when he was besides me, but he has a great temperament to deal with it. Along with, I'd like to thank Trishant and Nikunj, plus both associates, also the fellows. And it's a good team, sir. Thank you.
Thank
Nothing
you,
is
sir.
possible without a team, huh? Nothing.
It's always pleasure to have you, sir, here. Dr. Krishna Chotai.
It's very hard to find a mentor. Like it takes 5 years, 10 years, sometimes 15 years for somebody to find who is the right man. So I have found my mentor. Probably every one of us will also find, and I've found my mentor with Dr. Right. Thank you, sir.
Dr. Nikunj Mittal. Dr. Nargiza.
Thank you very much, my foreign doctor, for this experience that I get here, and I hope I will improve my skills, my knowledges, and it's like you are one part of my family, and I'm really impressed by your by your skills.
He's waited 1 month to come here during the corona pandemic, and so did Manuel. So that just shows how much will they have. Huh.
Dr. Manuel.
Manuel. Manuel is a really hard worker, and so is Nargiza. Like all these guys, I must learn from them how hard they work, each one of them. If it is Nigunj taking care of the wards when we are, stuck here, Trishant organizing things, this guy is, I wonder how he doesn't go crazy, okay? Manuel troubling me I get out of my room, Manuel is there with something, okay? Nargiza, we'll have to tell her to go back from the wards, do something else. So this is the kind of attitude, and so we are really blessed to have a team. And I hope in future you are also incorporated to the team all over India, slowly all over the world. It should be a global neurosurgical teaching experience. We learn and then we expand. We get better and better. Okay.
Thank you so much, Professor Cherian. Thank you to everybody. I came from Moscow. I met Professor Cherian in a skull-based training 3 years ago. And so somebody asked me yesterday, you've been in Moscow, in Burdenko, with a lot of technology. Why you are here? Why you can get here? And I say, well, if you know Professor Cherian, you know it's an honor to be here, because when you're training with him, you're trained directly with him, and the kind of knowledge you're gonna get, not only in neurosurgery, not only cystonostomy, because cystonostomy you need to learn with him, and the technique, the skull base and vascular. It's also about life, something like in the book you don't gonna find it. And believe me, if I fly more than 40,000 kilometers, it's for something. So I hope, and I know it's gonna be like that. I'm gonna be a long time here. I'm gonna learn much more. And all of you, training with Professor Cherry, are gonna explore your potential. Thank you so much.
Dr. Nikunj Mittal. Yeah.
I've seen this fellow from the time he was an intern. I was the head of the department at Pokhara at that time. He worked with me at that time, from that time. Then later on, he went to Vellore and did his neurosurgery, and then he was in Delhi. Now he's come and joined us as faculty.
Hi guys, good morning everybody. Only one word. The success in neurosurgery is hard work, nothing else. Take my words, you operate, but if you don't work hard with your patients full stop, nothing is going to come to your way. Only one word. Work hard. There is no shortcut. There is no key to success without hard work. I have my friend, Dr. Abhinav. I was working with him in Meerut and Delhi. In Delhi, I have worked with the best of the people, all the instruments. You name out the instruments, I have it. But the success was not there because there is no hard work from the other people. When I was in Meerut, you won't believe it, we have done 45 aneurysms. Few died, few survived, but the patients who survived, or what I was able to do it, is just because there was a hard work. There was a persistence to do things. There are other people to pull you down. We are all young neurosurgeons. We are all young. When we are young, we are afraid to do things. But when you have somebody, you will not afraid. You will have the actually courage to do things. Now, what is happening these days is everybody wants to establish their own practice. My name, my fame. Please don't get into that league or the race. Make groups, do group practice, or go under a teacher who can teach you. Then you will progress in life. Progress is not money. I understand money is important. You can understand me that I have left my 3 years of private practice and I've come to this place just because of one reason, that I felt that I'm not progressing. I can do actually practically everything, but there's not fineness in my thing, which I've come. I told him before coming here that, sir, I need to improve. I need to progress in life. I'm not progressing. Money is not everything. Take my words. After when you will be 45, 46, no? If you have not improved, if you have not gained the skill, you will get bored out of your profession. And once you're bored out of your profession, you will not like doing it. The zeal, the fire to do it, unless you have a, in your heart that I have to progress, something new has to be done. If that is died in you, you will not progress. You will earn money. Money will come definitely. Fame will also come. But the, the zeal, the fire to work, you like your profession. Today also, if somebody calls me in the night 2 o'clock and says, because you have to operate, I'll go happily and operate. There is not that, oh, I'm sleeping, I'm tired. I love being in theater. He is my friend. He has come from Meerut. He was not well for 2 days. Second day, we had a theater in the night. He came and he was very up. He was like, fresh. So that should be there in you. All of you, my young friends, in the thing also I told you, when you're doing this dissection course, try to learn new things. Try to learn why this is there. Follow somebody. I am not against don't follow. Follow somebody. But always ask a question to you. Why? Why are you doing this? Okay, for what? If I do this way, what is it? How will I do it? Then you're going to improve. Okay, this is only one thing. And thank you all of you for coming here and making this dissection course a good one where we all enjoyed having you. Thank you, sir.
Sunil, be ready for the anastomosis today. Okay. Whenever, make sure the chicken wings are there, the instruments are there. Which you have to coordinate.
Next one is myself.
Myself and Nilesh. Cannot thank this fellow enough. Huh? So.
I want to thank everyone for coming here. Actually, we started this all the preparations 2 months back, and that time the cases, corona cases were not that much. So we thought we will have full audience. But in between, we had doubts. In between, we also thought of canceling this. But many people contacted. We contacted them. They said they are willing to come. We got permissions from all the permissions, and with the sir's guidance, we do so. I feel we are very lucky to have sir here. Actually, this is my hometown, but when Goel sir recommended me to go to and join Karate, I was very excited because I know what are the cases initially what was going on here, so I was not very keen to join here. But I met sir, and he inspired me. He showed me the vision what this institute can achieve. We are slowly progressing towards that. I remember sir always tells us when we want to reach the Everest, we don't have to look at the Everest, but we only look at our next step only. But also we don't lose the sight where we want to go. Otherwise, we will lose our path. I think if you follow that, you will reach the peak anyone. Thank you, sir.
So we go into the dissection hall today, and we will anterolateral craniotomies, FOCs. I'm sure all of you can do it. So without damaging the dura, go ahead and do it. And I'll show you the opening of the orbitomeningeal band and the cavernous, transcavernous dissection. And if the brain is not so tense, we can go all the way up to the Kawase. Yesterday I showed somebody Kawase's drilling also and how to drill out the petrous carotid. So we will see all that with the endoscope also from the coronal plane. Okay.
Is anyone remaining? I think so. Is remaining.
So that's the plan for today. Abhinav, you've been with us for an extended stay.
I got an opportunity to personally see sir operating a case of cystonostomy. So I've come all the way from Meerut. My friend Dr. Nikunj has already introduced me. I would like to thank Krishna, it's my parent MBBS college, and also all faculty members, including Nilesh, Trishant, and other juniors, Kuldeep as well. It was a pleasant stay over here. Coming back to Karat is, you can see it's all green around, especially in monsoons. It's a lovely weather over here. It's a great learning experience. Probably I have come over here so that I can offer something better to my patients. Maybe I'm living in a place where there are many scope to really improve upon things. So I think by adding a simple procedure of cystonostomy, it looks to be simple now after seeing sir. Maybe I will be helping many more patients whom I am dealing right now. So it's a great inductment for me to come back to Karat. Probably I will move further and would definitely give a good feedback to sir in a month or so.
Sure. After this, we will move to the dissection hall. The Dr. Jankinam is ready with his lecture, and we will continue the dissections.
I believe we're going to the lab, correct? Hey, you guys with me? I believe we're going to the lab. I'm the last one to know.
John?
Where are we going, Young Hung? I don't know where we're going.
What time the conference will begin?
Yeah, a few minutes. The lab for 3 hours. The lab, and then the lectures.
The lab for 3 hours.
Yeah.
What time?
Let me ask. What time is your presentation? Okay.
So what time I will give
Okay.
presentation? Let me
Okay,
know.
1 minute. let me put my cape on. I fly. Okay.
Yeah.
I fly.
Be glad to fly.
I'll be right back.
Hey.
Let me check with what's up. Dr. Nisula, you know him, right? Okay, I let you know. I asked him. Okay, I let you know. Okay.
Okay. No problem.
Okay.
Okay.
Hello, John.
Yes, yes, I can hear you. Hello?
Hello, John. Can you
Yes,
hear us?
yes, I can hear you. Can you hear me?
Is Dr. Janakiraman here?
Is Dr. who?
Janakram. Yeah, I'm here.
So can you? Hello.
Yes.
So are you ready with the lecture? You're talking about endoscopic skull
Yeah,
base.
that's right.
Okay. So we are ready, sir. We can all ears and stage
Okay.
viewers now.
Okay, you want me to introduce them or let's have some kind of introduction, okay?
Doctor.
Yeah, okay. I'll introduce them, okay? You're gonna do some dissection of what part of the brain neuron, the Dolan's approach, or?
Yes,
No,
yes. That will go simultaneously.
Okay, I'll just introduce you, okay? 10, 9, 8, 7, 6, 5, 4, 3. Good evening from Miami Beach. It's Dr. John Bennett. We're dropping in with Ipsharian's webcast, a 2-day webcast with the cadaver lab. It's an exciting time. He's setting up a lab, or actually there's a lab there, but he's going to put some life into it and get it going for some workshops like this. I'd like to introduce a old friend, Naran,
Stores.
and I'll let him take it away. Hello, good evening, Naran.
Stores, people, stores.
Hi, good evening and good morning to all of you. I first of
Narayan.
all, yeah.
Narayan, good morning. Great to have you here.
Good morning, Professor Ipsharian. So first of all, I thank my brother, Professor Ipsharian.
Excuse me, Naran. Do you want Naran to present now?
Narayan is going to be presenting now. And
Okay.
after that, we will be presenting.
Okay, take it away, Naran.
Okay, so good morning, ladies and gentlemen. It's an honor and pleasure to be here. And first of all, I thank Professor Ipsharian, who is my brother, and I've been associated with him for a long time now. I just want to tell a few words about Professor Ipsharian. One person who really wants to transfer knowledge throughout the world, and he's been traveling so widely to teach and propagate the science of neurosurgery, and his landmark on cystonostomy approach is really world renowned now. And I just want to apologize for not being there. I was supposed to come there, but because of the present COVID situation, I was not able to travel. But however, I thought I could share my experience on the Zoom. So as Professor Ipsharian always says, the virtual learning is always there, but it's nothing like the hands-on experience. Once you do the hands-on on the cadaver, then it's completely different. So without much ado, I will start sharing my screen. I just want to tell a few words. I went to Nepal, actually to Bharatnagar, to demonstrate skull-based surgery. And I'm really thankful to Professor Iyer for having me here again. So I just want to, I can see a lot of young neurosurgeons here and who are going to be aspiring and very good skull-based surgeons. I just want to tell you one small thing. Before I started doing my skull-based work, I did around 80 cadavers. So before I even did my first case, I did 80 cadaver dissections. And the most important thing you'll have to try to do on a cadaver is try to practice what you're going to do in a live patient. This is something which I want to tell all the young neurosurgeons out there, because some of them actually pluck and pull, and they do not do it as you do it on the inside the OR. But honestly, if you try to replicate whatever you are doing in this cadaver, the same thing you're going to do in the live, then I think you will be far ahead. The first thing I want to tell about endoscopic skull-based surgery is that it is already an evolved field. It's not an evolving field. There are several centers in the world doing a lot of good endoscopic skull-based. And I'm sure that in India also, there are so many centers doing that. I'm going to start. Can I share my screen, Professor John?
Yes, go ahead.
Okay. This is it. You are. You are.
There you go. You're on the way.
Okay. Okay. So I just want to tell a few salient features before you get started on doing your cadavers. So I am basically doing skull base. We do a lot of skull base work, primarily both on the sagittal and the coronal planes, maybe around 10 cases a month or so. Basically, I want to tell you that most of our neurosurgeons are microscopic neurosurgeons, and to convert themselves into an endoscope is a little difficult because you're already well versed with the microscope. The only problem with the microscope when you do endoscopic skull base surgery is that it gives tubular vision. It gives very tubular vision, and so you're not going to get a panoramic view. But when you use an endoscope, you're going to have a principle of divergence. So that's a principle of convergence from the microscope gone on to the principle of divergence, and you can just take your eye right into the skull base, and so you can see the structures better. But only problem is some people complain that you have a 2D effect rather than getting the depth perception. But I'm sure that with practice, you will start developing that. The most important part of this learning would be try to release the cuffing effect. So what's the cuffing effect? When you're operating with a narrow corridor, then it becomes very difficult for you to operate inside when there is a complication like, a bleed from the carotid or the cavernous sinus. So try to increase your exposure. So I always say when you practice skull-based surgery, you have to, endoscopic skull-based surgery, you have to open up and spend a lot of time for exposure. Never have bottlenecks during surgery, and that's going to be the primary goal of your surgery. But what is the real bottleneck for a neurosurgeon? To handle the endoscope and to have a hand-eye coordination. What's the bottleneck for an ENT surgeon doing it? It's actually the knowledge of anatomy, intracranial anatomy. So basically, we should understand that endoscopic skull-based surgery is a teamwork. It's not one person. So please, my dear friends, when you're doing skull-based surgery, cadaver dissection, please, two of you combine and do it. Never do it like hold the scope and use the instrument. If you do that, you can never progress on in doing a lot of complicated cases. So, of course, I'm just going on to how to start doing endoscopic skull-based surgery. I formed a checklist. So basically, this is how you get started. When you start operating, you have three positions of the head. So try to have what's called the neutral position. So that's a neutral position. Try to have a neutral. Of course, in the cadaver you can't do that, but while doing surgery, if you want to do the odontoid, so this is what is called the dynamic head positions. So if you put it on a frame, you can't do that. So if you want to do the odontoid, if you want to do an odontoidectomy, then you can put the neck in the flex position. If you want to do anterior craniofacial resection on the frontal lobe, then you have to extend the head. So you can actually keep changing the head position, and that is little difficult when you put it on a frame. That's why we don't fix the head when we do skull-based surgery. And second is important thing is that many people hold the scope in a different way. This is how I generally hold the scope when I do endoscopic skull-based surgery. See, it's held like a flute. It's held like a flute, and this is the position you have to adopt when you do four-handed surgery. Just have a look at it. You try to do the same thing in the cadaver. Please do not a single person do not do it. If you do that, there's no use in doing this cadaver at all. So one person should hold the scope, and the other person should enter through both the nostrils. So it's the binostril technique, and have the camera cable. So I generally use the Spice camera. Now, of course, the 4K and the Rubina have come out. So use the best camera possible, and then put the cable on the left of your patient. And whenever you introduce the endoscope, introduce it using the flexibility of the ala. So you have to pull the ala up, and that's how you introduce the endoscope. And the instrument should always be on the floor. That's very important. So never try to, these two should not cross over. If it crosses over, then you will have what is called the crossover effect. And see, that's a crossover effect. When you do that, you will have a problem during surgery. And the instrument should be never above the endoscope. The instrument should not be over the endoscope. If you're having the instrument above the endoscope, then you're doing something wrong in endoscopic skull-based surgery. And when you use angle, of course, in skull-based surgery, I try to avoid angle telescopes. But when you want to look at the suprasellar cistern or, cavernous sinus or things like that, I might be using a 30-degree, but they are all only for visualization, not for operating. Why? Because we don't have instruments. If it starts bleeding there, we don't have instruments to go laterally or superiorly to, control the bleeding there. So these are basic things I want to tell you. And of course, you should never, suppose you move the left hand and the right hand, the left and the right should move simultaneously. This is very important. The scope and the instrument, you should have only a distance of around 2.5 centimeters. So how do you measure it? You have in Karl Storz, you have a suction which is calibrated. Have that in your hand, and then you can actually visualize. So this is a craniopharyngioma. I'm just operating. Use the same instrument. Don't try to change instruments. I have a set of instruments which I use for a particular step. And always try to have an aerial view. This is called the aerial view of the surgery. Try to have an aerial view. And when you're operating near the perforators, this is very important. I've seen many people pulling at a craniopharyngioma. This is actually dangerous. Skull-based surgery is all about micro dissection. Whatever you do from outside, it's exactly the same. So don't ever try to pull any structure inside. For example, a tumor like a pituitary. I never use curettes. Curettes to me are not the great instruments to do pituitary surgery, even if you do an extracapsular dissection. So here we are. Then if you go for the suprasellar, never use the instrument above the endoscope. This is again and again, I tell you, just keep seeing that. And in the nasal cavity, many people have a problem with bleeding. Many people say, I have bleeding, so much of bleeding when I do the nose. So try to use adrenaline soaked gauze piece. So I use 1 in 1,000. 1 in 1,000 adrenaline soaked gauze piece just to control the bleeding. That's very important. And then try to remove all that bone. See, this is a cavernous, transcavernous approach. And I remove all that bone in the pterygoid wedge, in the transpterygoid approach. See, when the tumor is going lateral to the carotid, you have to remove all this bone to expose the cavernous sinus. So your boundary should be the V2 and the median. And here you can see the internal carotid artery right there. So you can actually transpose this carotid all around to get the tumor out. So again, the most important thing I want to tell you, my dear friends, never have a camera tilt. If you have a camera tilt, it gives a false sense of perception. So this is all the basics I want to talk to you. And of course, I can show you any number of cases like the cranio, which we are operating. And then you never try to pull that. And then you can, there are two kinds of dissections, which I always say. One is a blunt and the second is a sharp dissection. Previously, we were actually doing the blunt, but now we have changed to sharp dissections, especially near the cranial nerves and the perforators. And then you can do all these, you can see how the optic chiasm is seen, and you can go just above to see the anterior circulation. And of course, a pituitary like this, if you want to remove, then you have to give a good exposure. So proximal bone exposure, try to expose the bone very nicely, and then you can actually manipulate the carotid. You see the carotid is being hooked here and moved and transposed. And of course, you can get beautiful views of the cavernous triangles. Of course, the Kawase, yesterday, I think Professor Cherian showed you all the dissections of the triangles. We can do it endoscopic as well. And you can see here the third ventricle, and you can see such tumors, huge tumors being removed. But I honestly believe that all this boils down to cadaver dissections. So unless you do a lot of cadaver dissections, which Dr. Ayap, this is a dissection I did in Pakistan. I just want to show you that only if you do a lot of cadaver dissections, I think you will get a finish. You have a book by Karl Storz. You can ask that book from Sunil. I just want to brief you on to how to get started. I'm sure that all of you are very enthusiastic. I'm sorry I couldn't make it there because of the corona. I'm sure that you're all going to, I don't want to waste your time, stand between you and the cadavers. You can get started, and all the very best. And thank you for this opportunity, my dear Professor Cherian. And I really congratulate you for this institute which you have created. We are all so lucky to have you. And I'm sure that I'll be associated with you in the days to come and months to come. Thank you very much. And I also thank Professor John Bennett from Miami. He's always like my friend, always there. I don't know when he sleeps. That's the only problem. And so nice of you to transmit, to the whole world. So that was just a brief introduction onto endoscopic skull base. Over to you, Professor Cherian. In case you have any doubts, my dear participants, you can ask me. So
Okay.
Mr. Sunil Verma of Karl Stores has all my videos of cadaver dissections and so many surgeries. If you want, he can play it for you as well, and you can ask for the videos from him. Any participants have any questions to me? It'll be a pleasure for me to answer the questions.
Okay, the floor is open. Anyone that has a question for the panel or wants to comment or just say hello to Duran? Everyone's shy, Duran, today. Okay, go ahead. Go ahead.
John, can we unmute? Can you unmute us, please?
Yeah, go ahead. Go ahead.
Narayan, thank you very much for your lecture today. I know it was at a short notice. We would have expected you here, but then probably next time, once the corona is better, we would like you to be here and demonstrate your beautiful dissections to us.
Thank you, Professor Cherian. It's always an honor to be with you.
Narayan is a really world-famous skull-based surgeon, and he sets the bar so high that catching up is really difficult. But we have to always catch up and do well. Right? Can you show me? Can you play the other video, please? Today I'm just going to show you. No, not that video. Just the previous one, please. Okay, can we? Yeah, so just to show you what we did yesterday, it's a paraclinoidal aneurysm that we had done some time back. And let me show you this video so that you have an idea of what is extradural drilling. So you see, the aneurysm there and the clinoid. Clinoid was just next to it. You remember that? The clinoid was just next to the aneurysm. That's the aneurysm. Okay, it's a transitional aneurysm. It's not purely paraclinoidal. So yesterday, the same thing what you did, orbitomeningeal band cutting. That is what we are going to do with. This is a diamond knife. So that is a frontal lobe. The orbit is towards there. And we are going to cut the orbitomeningeal band. Can you see me sectioning the orbitomeningeal band? Yesterday, what the same thing that we did. Okay, anybody? Can you see that we are going right on top of the? Somebody was asking, if you go transcavernous, will you have bleeding? We won't have any bleeding. You see, you are taking that layer, just that layer. The temporal lobe, I am pushing back posteriorly. By going at high magnification, I am going to see the highest magnification now. I am dissecting the orbitomeningeal band, and that's a cavernous sinus. That is the cavernous sinus. I'm uncovering it. Okay. Yesterday, just like the cranial nerves will be seen there. Okay. And see, while I'm uncovering, you will also see the clinoid there. Okay. So this is extradural pericavernous clinoidectomy. Okay, pericavernous dissection and clinoidectomy. So this is a ruptured aneurysm. Okay, it's a ruptured aneurysm. So we are making space there now. Everybody is understanding? Is there anybody who's not understanding? So this, can you see the clinoid there? Can you see the third nerve in the arachnoid, within the arachnoid there? The third nerve being overtaken by the fourth nerve is what is seen. That is a superior orbital fissure. Are you understanding the anatomy or not clearly? Everybody? So that is at the highest magnification. That is the thing that you have to notice. It's at the highest magnification, and I'm putting stitches here. So we are Like yesterday, whatever you did, where was those guys who did that dissection? Put your hands up. Yeah. So you guys, what you did is exactly what I'm doing right now. Only difference is there's a small aneurysm sticking next to that clinoid. So I'm drilling the clinoid now using a 2 millimeter drill. And that's the optic nerve there, extradural optic nerve there. Okay. You guys are understanding much better now? Now, there is the extradural optic nerve there. That is the cavernous sinus and that is the clinoid. You getting it clearly? Is there any doubt? The orbitomeningeal band is between the frontal lobe, temporal lobe, and orbit. The frontal lobe, temporal lobe, and orbit comes together at one point, and the dural condensation there is called orbitomeningeal band. Okay, so that's the cavernous sinus. Okay, and I'm drilling there is a dura of the cavernous sinus, and I'm drilling the clinoid without any retraction, no retraction at all. Cavernous sinus, you see that dura is the cavernous sinus dura going into the superior orbital fissure. That's the optic nerve, and that's the clinoid, and there is the aneurysm. I will show you. I am dissecting further and further the clinoid without any traction. Any traction on an extradural approach will result in rupture. You don't want that. Okay, it's a ruptured aneurysm. It's not like in United States or Japan we have the you have the freedom of doing unruptured aneurysms. Unruptured aneurysms almost never come to us. So now you're using a 2 millimeter drill to further thin down the clinoid. I wanted you to see the entire thing while they are setting up things here, because this will be an excellent recap of what we did yesterday. So can you see the extradural optic nerve is almost uncovered there, and I am going, that is the extradural optic nerve. Can you see that? Now that's a clinoid. Carotid aneurysm is right down there. The aneurysm and the carotid is right there. So I'm drilling over the aneurysm. Okay. Under very high zoom, keep on thinning down. We're not using any force there. So going into the cavity of the clinoid. So that is the optic nerve. The aneurysm is right there. When you see intradurally, you will see that that's the optic nerve, and the aneurysm will be right there. So the aneurysm is actually compressed down by this structure, and after that, after you remove the clinoid, the aneurysm neck will be seen. The sunrise, I call it. So that is the optic nerve. That is a clinoid. That's a clinoid. That's a cavernous sinus. Very clear? All extradurally. So optic nerve, clinoid, and that is where the carotid is going to be, and the aneurysm. So I'm eggshell thinned it slowly, and you can see the black of the aneurysm there. Can you see that? So now I am going under even high zoom. There is almost 40 zoom, not usually available on normal microscopes, and I'm now using a 1 millimeter drill. It's like a needle. Okay, so I am drilling, and you can see the aneurysm black. Can you see that? You will see now very clearly. That is under very high zoom, and I am drilling off the eggshelling off and then removing off the clinoid. That is the aneurysm. That is the optic nerve. That is the aneurysm. So 1 millimeter drill now. Okay, that is a 1 millimeter. Sorry, that's a 1 millimeter. It's like a needle. It can easily go through the dura if you're not careful. Okay, so that is the aneurysm. That red thing is the aneurysm. So you are drilling the bone, and this entire thing is around 2 millimeter. No retraction, nothing, no force at all. Okay, and you are drilling now. That's the optic nerve, beautifully seen. Can you see that? Extradural optic nerve. Can you understand? The extradural optic nerve, that's the carotid is turning, aneurysm is there. When you open the dura, you'll suddenly understand everything. And yesterday, exactly what we were doing. Today also, I want you to see this anatomy so that you can start doing your paraclinoid next, okay? And don't think that we came to this level without screwing up, okay? We came to this level after a lot of dissections, after a lot of ruptures, after a lot of heartbreaks, and then we came to this level. So if you have a rupture, don't think that, oh, that fellow is doing that like that, and I am doing like this. So we had our growth phase, we had our heartbreaks, okay? So the important thing is to start doing. See, now we are using a 1 millimeter drill again to take off the strut, shave off the strut. See, now only little bits of bone remain there. And see, I'm using the water continuously. Salona handles the water part. So, she knows that I need the water all the time. See that water flowing all the time? Can you see? So that I can see where the aneurysm is. There's not even a hint of bone dust. Hint of bone dust will whiten up my field and I will not see. That's what I was telling you. See? Now I can see the aneurysm clearly. Underneath the dura, I know that I am there on the aneurysm. Okay? That dural thickness is what? That is the optic nerve. And that's the aneurysm. That's the strut there. That's the strut. Between the optic nerve and the carotid is the strut. You guys enjoying this? Now we are opening. It's a ruptured aneurysm. Yes, we do it. Yeah, we we open the neck and get the control. In this kind of aneurysms, it will be suicidal not to do that. I see always, never common carotid. Okay. Well, you can have common carotid also, but I prefer ICA. If common carotid is much more easier. So,
Hi, John.
Yeah. So you can see the optic nerve there. Can you see? And that's the aneurysm. That is where we were drilling. You remember? We were drilling from outside extradurally. And this is cystonostomy. I'm doing the cisterns opening, opticocarotid cistern, and that is the aneurysm. Can you see the aneurysm? What ligament is that over the optic nerve? Falciform. So now I just have to cut the falciform all like that, and I'll get the aneurysm neck. Before that, the clinoid was here. Can you see that? And I would never be able to get into the neck with the clinoid sitting there. Are you understanding me? That's the optic nerve, and I'm releasing all the arachnoid, just like a cystonostomy. There's a lot of blood there. Again, so much irrigation. I like operating underwater, So that is where I'm releasing my falciform ligament. Okay? I'm releasing my falciform ligament there. People may think that you need balls of iron to do this. Okay? But no, just focus on the next step and there will be no more worry. Only when you focus 2 steps ahead, that is when you're worried. In life, anything that you have to do, focus on the next step. Nothing else, just the next step. If you walked high wire, if you walk on a rope without any support, if you're thinking about the end, then you're going to fall. If you're thinking that you're going to fall, you will fall. You just see the next step and then do it. That is the secret of all these surgeries. Okay, not because somebody is very courageous or anything. Okay, next step, that is all it is. Okay, Focus on the next step, be in the present, not in the future or the past. All right. So that's an aneurysm. That's a carotid coming up from the cavernous sinus. C3 carotid is bending there down. There. That is C3 carotid. C2 carotid will be here. That's the optic nerve. I've defined this aneurysm beautifully now. It's a transitional aneurysm. It is going into the carotid cave. Okay. That is the distal dural ring which I have divided. That's the proximal dural ring, which is the roof of the cavernous sinus. And from there, the carotid is coming up. Okay. Clear? Everything is clear? And now we are going to slowly apply this clip after finding out where is the carotid. Okay. That's a frontal lobe. After releasing the CSF, frontal lobe has fallen back beautifully. There's no need for even Sylvian dissection in this case. Okay. That is the interoptic system. That is the optic nerve. And you can see the carotid there. Can you see? You can see a glimpse of the carotid there. Can you see? Normal carotid. And then you can see the aneurysm. Now, all of you can clip this. At this stage, everybody can clip this. Yes or no? Yes. So clipping is not the important thing. Also remember that. Clipping is not the important thing. So I'm going to put a clip parallel to that C3 carotid. Okay. Parallel, so that I can see that C3 carotid, and parallel to the C3 carotid, I'm putting in a clip. See the C3 carotid there going into the cavernous sinus? That's the cavernous carotid. Put a clip there. There is a small neck there. So we don't have a smaller clip there. So we put a larger clip which is standing out a little bit more. Okay. So come back.
Just
and then
the Gore sir has just
Professor Gore, honor to see you.
please have
Yeah. So that's aneurysm clipped. All of you understood? Everybody? Any doubts? Anything that you wanted to? Any comments or anything? Yes, please. You guys can do this? Yes or no? Don't laugh. Don't laugh. You guys can do this. I'm not asking you. Okay. I'm telling you that you guys can do this. Whatever, because you understood. Right? Understanding is the first key. Second key is be in the present, and that is it. All right? So now we go into dissection again today. Professor Gore, who is a world famous spine surgeon, has arrived. So like Rohidas yesterday, Dr. Gore, we are blessed to have so many world famous people in this region. So we would like to ask Professor Gore to speak something. Please, Professor Gore, can we get a mic to him, please?
Good morning. I'm happy that Dr. Cherian could accommodate me in your program. I would be probably showing you and talking a bit about transforaminal lumbar spine endoscopy, which I've been doing for the last 20 years. And I would show you the new concepts and philosophy which we are now promoting, which is for lumbar canal stenosis. So let's see. As and when you finish, then maybe I'll take over.
Today also, there are a few interesting things. Dr. Gore will be talking on his technique. We have been collaborating with Austrian company, BHS, and we'll be showing you a robotic scope which we have developed with them. So this scope will not need any, you don't need to, hold the scope and move. You just have to look where you want and the scope will focus there. So Lars, the CEO, will be online to Nilesh. Will you give Lars 20 minutes to show the scope to, we haven't yet got the patent. So if you guys want to go ahead and copy it, you're welcome. Okay. As usual, we haven't got the patent yet, but of course we have to get the patent. We are bringing it to India for another 3 months. We will have that scope here. And we are trying to improve it further and further. Now we start up with the dissection.
Yes, we can start. We'll start with the dissection.
When is Dr. Gore speaking?
Right now, Professor Wang is there. He wants to speak now.
Okay.
So he can, Gore sir will continue after this.
Yes, all right. So we keep on with the dissection. And when the important phases in dissections comes, we're going to show you, and then you're going to get your chances doing that. Don't worry, you're not going to miss anything. With me around, none of you are not going to miss anything, okay? Don't worry about that. Yes.
Is Professor Wang here?
Yeah,
John?
he wants to ask something. Yes, Shubha Reddy.
Opening of proximal and distal dural rings
Yeah.
while exposing the carotid. Can you explain it, sir, once again? Because I'm.
You don't have to worry about. See, all these classifications is what makes things difficult, you know?
Yeah.
Distal dural ring, proximal dural ring. You tend to think these are two different rings. Okay.
Yeah.
It is just the separation of the cavernous sinus. You know, the carotid has to come from the extradural space to the intradural space, isn't it?
Yeah.
So when the carotid has to come, the cavernous sinus needs to be blocked off, right? So if you are operating from intradural, the cavernous carotid and the intradural space has to have some separation, right?
Yes.
Isn't it?
Yes.
So what happens is the falciform ligament of the optic nerve comes and goes around the carotid. Imagine like that.
Okay.
The falciform ligament, that is the dura over the optic nerve, comes and condenses around the carotid. That is your
Rings.
distal dural
Distal
ring.
dural.
Okay, that's a much more complete structure. Below that, there is one more ring which is incomplete, and that's a proximal dural ring. And if you cut the proximal dural ring, this is a beautiful approach medial to the third nerve, lateral to the carotid, into the cavernous sinus. So supposing if I have my pituitaries which are going into the cavernous, Narayan will do it endoscopically. I could take it out. I also now do it endoscopically. But if I want, I can always enter into the cavernous sinus medial to the third nerve, cutting the distal dural ring and then cutting lateral to the carotid to get into that compartment. Okay. So don't classify it as distal and proximal dural ring. Just understand that you cut the falciform, come laterally, cut furthermore. Yesterday I was showing you cutting the ring. Did you see it? All of you? Did you see cutting the ring?
Yeah.
It's not a big thing. It's a small thing, okay? Unless you have to figure out that is a ring, that is all. Okay? Today again, I hope we will be able to see it. Okay? Right then. Who's going to come for the endoscopy? Okay, right. Yeah, you can come.
So Dr. Ganesh from ENT is also here.
Okay,
Also
where is Ganesh?
Yeah.
Come, Ganesh. Ganesh, come. You guys also come. Yeah. Ganesh, you can raise the HUD and all that with these guys. Okay, go ahead. I want very wide. So what we will do is, can somebody get the scope holding? Come. One of you guys
Advait.
come, and then
Advait,
you can take
you help
turns.
with the mic, gloves,
Okay.
mask?
Can somebody hold the scope for me? Come, Ganesh. Yeah. So very simple. Those who are not clear about this is a disturbance, you know. I'm sorry, but yeah. You can get the anastomosis ready by that time. Both of you can get the anastomosis ready. Now, I'm going to simplify things for you. You know the nose is a pyramidal cavity. What is in the center? Septum. What is laterally? Huh? The turbinates. There are 3 turbinates. You have a septum, you have 3 turbinates. Above the turbinates, what do you have? Well, lateral and above to the turbinates, what do you have? The ethmoids. Yes? So these are simple concepts. So if you want to widen your surgical cavity, you can either take off one of the turbinates or down fracture them and then displace them laterally. Your place that you need is a sphenoid sinus, and the sphenoid sinus, to increase the space around the sphenoid sinus, you have to take off the ethmoid. Okay, so it's very important that you remove the ethmoid completely, and even sometimes on the other side if you want a wide corridor. Okay, so this is what you're going to see today. I mean, Vihapure, Dr. Vihapure has done cases with us, so he knows how we go ahead and do it. So we use the ethmoidectomy. We take off the ethmoids, and then we see what, once we take off the ethmoids, you're going to see the two optic nerves. And you see the two optic nerves, and you always see the carotid, right? So medial to the carotid is the MOCR, lateral to the carotid is the LOCR. Opticocarotid recess. OCR stands for opticocarotid recess. So it's very simple, isn't it? Pyramidal nose, septum in between, 3 turbinates. Okay, ethmoids above, 2 optic nerves, LOCR, MOCR, and between the 2 carotids is your sella. Lateral to the carotid is your cavernous sinus. The carotid is already in the cavernous sinus. Okay, below the sella is your clivus. Very simple, isn't it? You don't have to get worried about all the complications. Now you have to arrange these things in 3-dimensional space. Now it's not so simple like a line diagram. So you need to arrange these things in 3 dimensions around the space that you get. And then you will be able to reach everywhere. Clear? No confusions? Okay, Ganesh, you and one of the other guys can come start dissecting here. Come, go ahead. You're okay? If you got any difficulties, I'll drop in. Otherwise, you guys will have to do it yourself. It's a cadaver dissection for you, not for me. I didn't pay.
Okay.
So when they do, you will understand if there is any mistakes like yesterday. And we are going to start the dissections there. And we're going to, when the orbitomeningeal band is going to come, I'm going to show you how we are going to bypass, I mean, how we're going to cut it and then how we're going to dissect it, okay? Can I dissect on that cadaver? You guys start on this one. I will start on that one, and I'll, since you've seen it yesterday, there's no need to see it today again. And here, once the sagittal plane is seen, I will be able to demonstrate things to you. And there, once the orbitomeningeal band comes, again, you guys, I want you guys to come, and then we will demonstrate things, okay? Oh, it's this cadaver itself, huh? Right. So, well, if I do that, you... Can I put the microscope here itself? Huh? That'll be bipod surgery. It'll be hybrid. We have done that a few times for cranios. But yes, it can be done. It'll be bipod. Okay. So you push that down to the nose. Okay. It's beautiful. And you will see both the I think in 2014, me and Satish Jain, Satish is a fantastic, like Narayan, he's a skull-based surgeon, a fantastic skull-based surgeon. And we, I think 2014 skull-based, national skull-based, we did together from top and bottom. It was really, I mean, it's a big learning experience for us. So you think, you guys come on to this side. You guys go on to this side, and then you start your stuff from that side. And I am going to, I don't want to resect this skin flap. That will be not elegant. So we will fix it here. Can I have a suture, please? Can somebody give me a suture, please, with a... Yeah. Anything, whatever you're comfortable with, don't worry. We'll be there. And this patient is not going to die again. So be very careful, just like Narayan said, as you are doing in the real. Can somebody assist me also? Somebody, yeah. I mean, somebody who's not done yesterday. Yeah, come. Yeah. Jayant, after I will have only space for one. So after this guy, then you can come ahead.
Even for the aneurysms.
Yeah.
Even MC maybe ऐसे जैसे ओपन करना तो मुझको दिखेगा A1 दिखेगी ऐसे तो MC आकर बाइफर्केशन की तरह तो दिख जाए फॉलो कर
Hold that there. Yeah. No, I just tie this like that, so that. Thank you. Yeah. Let Wang speak.
Hello, John. Is Professor Wang here?
It's my rubber band.
Hello.
Wang is around.
Are you looking for Naran?
No. Wang.
Oh, okay. Okay, hold on. Let me check the panel. No, he was here, but no longer here. Let me try to get a hold of him. Oh, there he is. Young Hung.
You found him from China.
Yeah. There he is.
Wang.
There he is.
Two rubber bands. We should not obstruct them in any way.
Hello, Professor Wang. Are you ready with the presentation? We can continue yesterday's talk.
Okay, I will present my topic is cystostomy physiology.
We are not able to see your screen.
Picture is small, please.
Yeah, please share, Young Hung. Share your screen.
Yeah, okay. Okay. And now I watch the lamp anatomy.
Okay.
Do you see?
Yes. Perfect. Okay. Ready.
Okay.
Not a great thing to do, but. So patient can move a little bit to on this side.
Let's begin.
Yes, excellent.
Yes, sir.
You're okay, guys.
Okay. I am honored for this opportunity that IP invited me to introduce the cystostomy, and so I'm very glad, and I have many experience about cystostomy. At the beginning, I learned from the Professor Cherry, and we have communicated many times. So recently, I will establish a society of traumatic neurosurgeries. So I have a lot to say. maybe in the future, we will have some conference and invite all of my brothers to China and have conference. This time I will introduce pathophysiology of cystostomy. Actually, the cystostomy has a long history. This is last century. This paper from America, and this use unilateral inferior temporal lobotomy with hemocapectomy for relief of incisional herniation. And this procedure is simple than cystostomy. Actually, they use cystostomy idea. They open the skull and cut temporal lobe and open the incisional system, ambient system. And at this time, a lot of CSF come out. This method is very, very good. I use this method to do several patients. At this time, when we open the ambient system, a lot of CSF come out, and the ICP is lower, so we can clear the pre-laceration and hematoma. So it's good and lower the ICP. This paper is about from Japan. Is about aneurysm, ruptured aneurysm, and use basal cyst drainage and lumbar subbackground drainage. It's also use cystostomy technique, so it's have a good result. This paper is from China at 1995. This is also used cystostomy in brain trauma. They have severe brain trauma, 22 cases, use cystostomy and have a good result. They can reduce brain stem compression and reduce traumatic hypocephalus and reduce ICP. And use this drainage about 5 days to 7 days at this basal drainage tube height is 10 millimeter high. So it's a very good result. This is Professor Iper's paper about cystostomy for traumatic brain injury. At this paper, they tell the procedure how to do this surgery at some pathophysiological mechanism and surgical technique. It's very good paper. And cystostomy also use stroke-tomy and brain infarction, especially malignant middle cerebral artery infarction. I also use cystostomy to do this surgery, middle cerebral artery infarction. It's also have good result. From 2012, the pathology of cystostomy at Dr. Elif Nedgard identified glymphatic pathway. This is very important for our understand the cystostomy theory. This is glymphatic pathway. From this paper, we identified brain-wide pathway for fluid transport, which includes arterial influx of a subarachnoid CSF into the pre-interstitium, and also interstitial bulk flow between this influx and the efflux pathway depend on extracellular water movement. This pathway is called the glymphatic pathway. When we find this pathway, we will also better understand that the cystostomy is a good method of surgery. This paper is very important for our understand because before there's a lot of paper about animal results. This paper is research from animal translated to humans. This paper write about provide glymphatic enhancement and clearance in humans access with MRI. And this is different time, 2 to 4 hours, 4 to 6 hours. The glymphatic system in different phase, and we can understand the human brain also has glymphatic pathway. And this, the current pathways recognized for the exchange of fluid within the intracranial compartment. This is a new hypothesis. The fluid exchange between the system and the parenchyma through the perivascular virtual Robotic space may be greater importance than the traditional recognized fluid within the ventricular system. So we should understand this glymphatic pathway system. This is Tyrese theory about CSF shift edema. When brain injury and subarachnoid hemorrhage in trauma raise the pressure in the system, and the intracerebral pressure remains lower than the system compartment. This results in the shift of CS driven by the pressure gradient through the virtual Robotic space into brain. And this is principle of cystostomy. So we can, by the cystostomy, we can reduce brain edema. Actually, why we put the drainage tube into the basal system? This is people wrote the research in the animal. The perivascular pathway for influx of cerebral spinal fluid are the most efficient in the middle brain. So actually, this is a different phase. Use PET, different time the metabolism of the MRI. This is a time active curve of the middle brain at the front lobe. So the middle brain is very concentrated, is high concentrated in the middle brain compared with the front lobe. So we use basal system drainage is a very good effect. This is about biomarks of traumatic injury are transported from brain to blood via the glymphatic system. And now there's 4 unique approach to suppress glymphatic associated clearance. One is compound for deletion. 2 is system magnocytotomy, and sleep deprivation and actazolomide treatment. And the suppression of glymphatic clearance prohibits the delivery of TBI by marks to the serum. And cerebral influx. This is a new paper of last year. Cerebral spinal fluid influx drives acute ischemic tissue swelling. And so when the middle cerebral artery infraction, the the space, Robert space is enlarged at now became edema. So when we use cystostomy, we can reduce the Robert space by drainage CSF. We can reduce the space vascular space pressure, then reduce the edema. This is about the depression effect about the glymphatic flow. When depression decreased artery pulsatility after craniectomy lead to impaired glymphatic flow. Craniectomy lead to bilateral decreased cerebral penetrating arterial pulsatility. So when we depression, so the bilateral cerebral pulsatility is low. So this results in immediate impairment of a glymphatic CSF influx into brain, and prolonged failure of a glymphatic CSF into brain, and craniectomy result prolonged failure of a glymphatic CSF influx into brain until this is about 40 days, 28 days, 56 days. Actually, there is impaired glymphatic CSF influx immediate following decreasing craniectomy and lasting out to a point between 40 and 80, 28 days following depression, regardless of whether cranioplasty is performed. And so at this time, we can place the ball about 1 month. And so only cranioplasty is good for glymphatic pathway and good for brain function. Also, craniectomy induces extraglial activation. So also induce craniectomy also induce microglia activation, increase the CD 6 to 8% area. So they can, when cranioplasty, we can put the forward the date about glymphatic effect. Also, craniectomy impairs object memory and coordinate movement. When we cranioplasty, we can improve the brain function and novel object recognition. This is microcirculation about CSF. So this is the lymphatic drainage and the connective influx glymphatic system of the brain. So when the brain trauma, and also there is immune complex disrupt the perivascular drainage of the throat. So there's a lot of immunocomplexes. So when we do the cystostomy, we can reduce the immune reflection. this is a perivascular space. By reduce by drainage CSF, we can get a lot of blood CSF come out and reduce reduce immune reflection. So thus we can get a better function. So this is my understand about the glymphatic system and the cystostomy pathophysiology. So this is my my introduce this problem. Thank you all of you and thank you for your attention. John? John? John?
Hello, Professor. Can you hear us?
Yeah, I finished my presentation.
Okay, thank you, sir.
you.
Cherian sir wants to say something.
Yeah, so
Saranta mic.
Yes.
can you hear me, John?
Yes.
Hello, Professor.
So here we have already done the Dollings, and I can
Yeah, I finished my presentation.
Okay, thank you, sir. Thank you, sir. Cherian sir wants to say something.
Wang, thank you very much for that. I mean,
Thank you, brother.
They call him Superman in China.
Superman.
Can you hear me, John? Wang
Yes.
is Superman. I mean,
So here we've
Wang
already
has
done the
been
Dollings, and I can
so instrumental in spreading system of China.
Okay, thank you, sir. Thank you, sir. Cherian sir wants to say something.
Wang, thank you very much for that. I mean,
Thank you, brother. Thank you. Welcome to China.
we are hoping to come there and also host you in India sometime very soon, Wang. Our vehicles, eh? The dira is so thin. Okay, no problem. No problem. Okay, give me a gauze piece with the spatula. No, just the dissector is fine. Okay, all of you guys who wants to see the Dollings again, please come down. Can we air this to the bigger screen, please? We have opened the dura also so that you see what we can see. Now this position is not right actually, but I'll try to whatever is possible with this position, I'll try to show you guys. Okay, are you seeing everybody? Are you seeing? Guys, are you seeing it? I need some answer. All of you? So here you can see the optic nerve. Can you see the optic nerve?
Can the panel see that? Can the panel see that?
Can the panel see the optic nerve? This is the optic nerve. Can you see that? Yes or no?
Don't be afraid to say.
Can you see the optic nerve and the contralateral optic nerve even? Yes or no? Yes. I
The
will zoom.
panel is being mute.
Okay, we've zoomed in. Now, that's the optic nerve and the contralateral optic nerve. This is one optic nerve. And the contralateral optic nerve is there. You can see the carotid here. This is the opticocarotid space, and you can see the third nerve here and the third nerve intradurally in the tentorial lateral carotid space. You can see the third nerve also. That is here. Can you see the third nerve there? Yes or no? And you can see the basilar and the P1 there. So I have just opened the membrane of Lilliquest. And you can see the basilar there. So I want you guys to see this entire anatomy. That is the clinoid. That is the clinoid which I have partially removed. So I'm going to remove this clinoid and then I'm going to connect. Can I have the scissors, please? Scissors, please. Yeah, any scissors is fine. I don't need the micro scissors as such. I'm now used to. Oh my God, I mean, this is crazy, but. Somebody was asking me about the distal and the proximal dural ring. Oh, this is really crazy, using this scissor here. Okay. So you see the third nerve, complete course of this third nerve. It's not good, huh? This is not good. I would have preferred. Are you seeing the entire anatomy, guys, here? Give me a. We need a micro scissor, actually. Yeah, okay, fine. So that is the A1. Can you see the A1? All of you, can you see the A1? I would need the micro scissors at this point. I mean, can you ask her to? That's a third nerve entering the oculomotor trigone, okay? To become extradural, intradural third nerve going into the extradural cavernous sinus. And this is the clinoid dura, okay, which I'm going to cut. And then once I'm going to cut it, give me a drill or give me something which punch or give me something that, come, give me that. This should not be used in the real surgery unless you have nothing else, but this proves that you can do these surgeries with this also. Very gently. No, maybe something straight punch, this is not possible. Thank you so much. So I'm focused there. Can you focus there, please? That's the membrane of Lilliquest. Focus there. Yeah, I'm done. So focus there. Can you see the basilar? Very clearly. Everybody? Can you see the P1 and the superior cerebellar? Yes or no? Can you see the third nerve going into the space between the superior cerebellar and the P1. Dekho, you can see this superior cerebellar beneath. Yes or no? That's a basilar. Okay. And the superior and the PCOM will join the P1. So you are seeing the P1 in the and the third nerve going into the interpedunculaire cistern. I'm going to cut off some of these arachnoid bands, the membrane of Lilliquist. Can you see the entire basilar tree now? See, P1 contralateral third nerve. Contralateral third nerve, you can see. That's a contralateral third nerve, okay? That's a carotid. That's a P1. I mean, that's a superior cerebellar. That is a contralateral third nerve. And that's a P1. That's a contralateral P1. Can you see that? Everybody? This is the ipsilateral superior cerebellar, okay? That's a MCA. That's a A1. All the perforators there. That's a basilar top. This is the basilar top. Okay. Now you come extradurally. That's a third nerve joining the oculomotor trigon. So that's the oculomotor trigon, and that is where the third nerve. That's the fourth nerve. V1 there. Okay. We will further get into that, but I want all of you to look into this. Can you see the anatomy? All of you, entire basilar tree. And please don't damage it, because these are very, very small triangles. And if you put force, the third nerve will go, fourth nerve will go. Okay. So be very gentle. That is the only thing I ask of you. Okay. Because the other people also should see it, right? Yeah. Yeah. So entire basilar tree, entire posterior circulation has been laid out for you. So you can see the ipsilateral third nerve, ipsilateral superior cerebellar, ipsilateral PCA, basilar trunk, contralateral third nerve, contralateral PCA, contralateral superior cerebellar, all the perforators arising from the top of the basilar, everything you can see. Membrane of Lilliquist I have removed. It really doesn't take too much time. Okay, with this kind of a dissection is easy. Okay, it's a tight brain actually, very, very tight brain. Otherwise, if it's lax, it's much more easier. Be very gentle. Whoever is doing it, be very, very gentle, please. So now you guys are getting to understand skull base, real skull base. This is skull base. Okay, getting into the interpedunculaire cistern is skull base. That's a MCA that you are seeing. That is the MCA. Be very careful on that brain, please. That's MC. That's IC bifurcation that you're seeing. Okay, IC bifurcation. Put a glycerol gauze piece. That's a third nerve. Intradural third nerve coming into the oculomotor trigon and entering the oculomotor trigon. Yes, yes, yes. Can we have the endoscope piece inside this? Let me show you 1 second. Can I show you with the endoscope? Can I show you a 1 second? Yeah. Give me a dissector. No. Yeah. Okay. Can you see the cavernous sinus there? That is the cavernous sinus. And once you come, that's a third nerve. That's a carotid. And that's the entire basilar tree. Okay? That's the entire basilar tree. Can you see the contralateral third now? Periocerebellar artery dividing into two. Posterior cerebral artery there. That is the basilar tree. Okay, that's the entire basilar there. Can you see? Basilar trunk. Contralateral third now. Can you see the contralateral third now? Can you see the contralateral third now arising there? That's the basilar trunk. Ipsilateral third now, and we are going down the basilar now. That is the interpeduncular cistern. That's the basilar top. And those are the perforators. Okay, so it is not only the endoscopic guys who can see all this. We can also see if you have the right access. And you see that now, P1, can you see the P1 coming towards you? And see the third nerve, it's beautiful. See the third nerve this side. Oh, I have some band of arachnoid between me, so that's okay. But you can see everything, right? So can you see the encephalic membrane of umbilicus there? It's almost pulsating, you see that? See that? And see all the perforators, the thalamoperforators, the thalamogeniculates. Can you see that? Okay, so looks like there is a small dilatation on the basilar top actually. That's the basilar top. Okay. So the PCOM, you are seeing the PCOM going and joining from the carotid. Can you see that? What I'm touching is the PCOM going and joining the P1, P2 junction. That's a third now. That's a third now. Okay. Beautiful. Right. It's entire basilar tree. Okay. Nilesh's idea to put in the endoscope. Okay. Good. Excellent. So now without damaging anything, you guys, you want to put in the endoscope or exoscope or microscope, please go ahead. You see how the entire anatomy is now? So very clear. Now, once you see the intradural, then we will go into the cavernous sinus again. We'll go this time deep into the cavernous sinus. We will go every single step of I will open the cavernous sinus and show C4, C5, C6, everything. C6 is intrapetus. C3, C4, C5 I'll show. Meningohypophyseal, 6 now, all the cranial nerves I'll show. Okay? Yeah. Petrus drilling will show. Like yesterday. Yesterday, you guys took off all the bone. I didn't have anything to stay. You guys took everything out. But that is good. That is how you have to do it in the beginning. Okay. Yeah. Dr. Gore can do his. Professor Gore is here. Yeah. Let him do his lecture. And while these guys.
I request all the delegates to be seated. Only one person will be there in the microscope, and that will change by one. Please be seated. Professor Gore will be talking now.
Take your turns at the microscope now. Don't damage anything. See by yourself gently. Let Professor Gore talk at the other time. Keep one by one, you keep on looking. Okay. So you'll see the entire anatomy of the basilar up to the mid basilar. Okay. That you can get through this approach. Be very gentle, extremely gentle. Don't damage that brain. Professor Gore is here. Okay. Go to the anastomosis place.
कालस्टोरचे कुठे गेले माणसं गोरेचं कुठे गेले बोलवा की त्यांना लेक्चरसाठी गोरे सर हां लेक्चर Each one will have 1 minute only. Please be kind to other delegates also. 30 delegates 30 delegates है एक एक मिनट में तो 30 मिनट में तो लेक्चर भी खत्म हो जाएगा
नहीं ठीक है
can you can talk
It's like so let's नहीं ठीक है कोई nothing we can do on this we just have to zoom it थोड़ा zoom कर सकता है पूरा maximum zoom में जाना yeah yes
So you want me to start my talk, or you are going to be busy with that?
Did you hear that? Yeah, I don't think I've heard that.
Yeah, you tell me once you finish. No, once you say okay, go ahead. Yes.
Yeah, hold on. Let me try to contact Dr. Rilesh.
Hi John, can you hear us? John?
Yes.
Dr. Satish Gore is here. He is one of the renowned endoscopic spine surgeon. He is here. John? Hello, John.
Yes.
Dr. Satish Gore is here. He wants to deliver a lecture.
Okay, let me just get the instructions of what to do from IPE or Dr. Nisula.
We are using the same instrument, the same login ID. You don't have to worry about anything. We are just
Okay, Dr. Nisla, who do you want to be the next speaker? Who's running the show there?
Dr. Satish Gore. Hello, John, can you hear us?
I still haven't heard from the IPE or Dr. Nisla.
Hello, this is Nilesh here.
Okay, what do you want to do?
Yeah, Dr. Satish Gore is here. He's an endoscopic spine surgeon. He wants to demonstrate his technique of the endoscopic spine surgery. So could we proceed now?
Thank you.
Okay. Now Gore will talk, sir. So please.
Okay, good morning. I am Dr. Satish Gore. I'm in practice for the last 37 years, out of which 20 years I have devoted to transforaminal endoscopy of the lumbar spine. Now, how many of you have seen, read, or assisted transforaminal spinal endoscopy? Yeah, probably very few, maybe. Okay, so I thought that I'll just give you a basic introductory thing and also the advanced thing. So you would know what exactly we are doing, why we are doing it that way. Okay. And there are a couple of questions which I always find that during our conferences are never answered. Why do you do this way? Or at the last day of the conference, every person would say that you should do this and you will get the best results when you choose your cases properly. And nobody tells you how to choose your case, correct? That has been my experience all these years. So what I thought is I'll just make you oriented to our thinking. The basic difference in what I do and what you people probably do is I do all my surgeries under local anesthesia through the foramen, and the cut on the skin is about 8 millimeters. So I don't have to stitch it back. So I call it as a stitchless surgery under local anesthesia. And I've been doing it for the last 20 years, out of which last 5 years we have been doing stenosis. And we have just, last year we have started talking about it because there were a lot of concepts to be developed and a lot of ideas to be clarified. So now I'm going to tell you basically everything about why, how, where, when, etc. Now, basically, what is degeneration? Because my talk is primarily related to degenerative lumbar spine. I'm not going to talk about red flags and yellow flags and brown flags and all that, because that is what is basically taken as understood. So we are looking at a phenomenon where the lumbar spine is changing. Now, commonly in our day-to-day practice, we mix this word degeneration with aging. And we say that, you know, your spine is aging, which in a way is a correct statement. But if you go academically and go at the cellular level, there is a difference. What is the difference if you see a healthy spine, aging spine and degeneration? The main difference is in a degeneration, there is a structural failure. That is, there is a change in the structure, which is not normal change. It's a failure of that structure. And this structural failure gives rise to symptoms, whereas aging is asymptomatic. So that is the main difference. And why are we concerned about this change or this structural failure? Because that is what gets a neurovascular reaction or an inflammatory response, and that is what gives the symptoms. So theoretically, when a patient comes to you and says that I have pain in the back, you must immediately conclude that there is a structure in the back which has failed as compared to normal, and the body is reacting to that failure and giving rise to symptoms. So as a clinician, then it is your duty to find out where is this structural change, okay? And the second thing is, it basically is a combination of inflammation and compression. Not only compression, because all these years we have been talking about compression and decompression. It's not true. It also has an element of inflammation. And I can go to the extent of saying that about 80% of our patients who come to us in the OPD, who don't need surgery probably, are all having inflammatory part in their symptomatology. How do we detect that, etc.? I'll be talking a little bit about it. So please remember that the main distinction which we have between aging and degeneration is there is a structural failure which is absent in aging. What is the main feature of aging? It is reduced diffusion or reduced nutrition of the tissue. So it's like you have a plant in a pot and you forget to water it every day for say a month or so. At the end of the month, the plant will all shrivel up and will die. So same thing happens with the biological system. There is no nutrition, so the whole thing slowly stops. There are no symptoms. Now, this is a very simple diagram where on the left, you're looking at a coronal image of a functional spinal unit where you have a vertebral body, another vertebral body, dural sac, and the roots. And this is what you're looking at as a sagittal image, conceptually, schematically. Now here, please remember that when we are talking of this functional segment, let's say this is L4, this is L5. So these are pedicles of L4, these are pedicles of L5. This is the exiting nerve L4 going out below the pedicle. And then this is a disc between 4 and 5. This is the L5 root, which here is called as traversing nerve. It goes down and goes out of this pedicle. Now, what we have done is conceptually, we say that in a functional spinal unit, there are two vertebral bodies with a soft tissue ring in between. And what is a soft tissue ring? In the front, it is the disc here, and at the back, it is a facet joint and the ligamentum flavum, which is interlaminar. So this is a scheme of the thing. And for all practical purposes, to make things more easy to understand, everything which lies above this end plate or the superior end plate of the disc is called as the upper zone. That is this blue thing between the lower part or the lower border of the pedicle to the end plate is upper, above the disc. The red thing or the orange thing is the middle, and the green thing, which is below the disc, infradiscal, that is the end plate of the disc up to mid pedicle, is lower zone. And between this mid pedicle to lower border of the pedicle is a complete bony zone. That is, all the walls are bony. So there are no changes occurring in that area. Now, what is the importance of knowing this? The importance is you will find that the only change which occurs with degeneration is occurring in this middle area, or the borders of middle area with the upper zone and middle zone and the lower zone, okay? There are no primary changes in the bones as such. This is a very, very simple fact which we have forgotten. All the clinicians have forgotten that things do not happen in the bone, especially after the age of skeletal maturity, the bones do not change, okay? They have the same shape, size, etc. Maybe because of porosis, it will change. Maybe because of fractures, it will change. But mechanically, they do not change. So this is a very important, simple concept to be understood. Now, we have published this in 2011, what we call as in vivo endoscopic visualization of pathoanatomy. Now, I'll just tell you simply what this is. In the past, we used to depend, and even today, most of us who do not do endoscopy depend on the images entirely. You depend on the images to make a decision about thinking of what I should do, whether I should do this, whether I should do it here, etc. What we did is we stopped depending on the images and we started putting our scope through the foramen at the pathology or the changed anatomy. For example, I put my scope through the foramen and I may put it on the disc, on the annulus. I may go through the annulus. I may go inside the disc. I may put it at the annular tear. I may put it above the disc, but towards the head, that is the upper zone, and look at the dorsal root ganglion. I may put it in the lower zone and look at the lateral races, etc. So when we started looking at it, and when you have the patient who is completely awake and aware, the whole world changes. I mean, you must remember that if a patient is awake and you are looking at this structure, for example, here, and you press this structure. When you press the structure, the patient tells you that the pain is going down my leg and it is on my shin. Okay. If you press here, he will say that the pain is going down my leg and going to my big toe. If I use laser around that area, the patient tells me that my big toe is becoming warm. I mean, patient is awake, completely awake. The patient is aware of all those changes. So what we have highlighted here is that in vivo, that is when the patient is awake and aware, we have put the scope and we have understood what it means to have that altered anatomy and what symptom generates from that. Okay, there is no doubt about it. There is no conjecture. There is no guessing. It's not like a traditional thinking where you imagine that this herniation must be giving pain on the right side because it is on the right side. But you will find many times that a patient will come with the pain on the left side. Correct? Many times we see this. Or you will find a patient who will have a central herniation which is down migrated, and patient says, I have no pain at all, but the whole seat area is numb. And I have a problem with urination. You know, it's a Kodak vena syndrome. So what we are trying to say here, what we have done is we have understood the anatomy which had changed, and we have correlated that with the symptoms which arise from that change. There is no guesswork. Completely, we are aware what is happening. And there are two things which we have understood. First thing is that in cases of disc herniation, there is a concept called as pain generator. What it means is that is the area where the thing had changed and the body is reacting in the form of inflammation. So when you touch that area, patient says, it's painful. So you say, where? So he says, same what I told you. Understood? Same pain, what I told you, is being generated when you touch that. That is one part of it. Second part is, again, going back here, you will find that if you watch it very closely, this part of the nerve, what we call the root canal, I'm sure all of us know that, root canal, where the root is around the pedicle, there's a groove in the bone, and the root is traveling from the lower part of the disc, that is this end plate, right up to this end plate, or this is called the exiting nerve. This is the traversing nerve, which is entering the root canal. So here is a model in case you want to have a look at it, I can show. So what you're looking at coming out of the foramen is the exiting nerve. And if you look from above, you will find that the nerve is entering the root canal. Now what we have found is, if you look at the nerve and its origin, all of us know that the conus is around L1, right? After that, it's all cauda. And then these roots, right from the conus up to the big toe, for example, if you're talking about L5 root, the L5 root is relatively fixed, relatively immobile only in the root canal. Please understand this. This is a very simple anatomical fact, and this is very important. What is important? Have you ever heard a surgeon saying that I will operate the patient here and mobilize the nerve? Have you ever heard that? No, we don't mobilize the nerve. We decompress the nerve. The nerve remains there. The path of the nerve, the way the nerve is lying, etc., is all immobilized in that part. So the nerve is immobile there. And this is very important with respect to stenosis. The symptoms in stenosis, which are more of numbness, more related to venous congestion, more related to arterial ischemia, etc., is related to the immobile part of the nerve. And all of you know that in the upper part of the foramen, we have the segmental artery, which is below the pedicle and which is ventral to the root. And generally, in the lower part of the foramen, we have the venous system or the venous drainage of that segment, which is joining the ascending lumbar vein outside the foramen. Okay, so with these basic things, we'll go ahead. Now, quickly, I'm going to tell you, I'm sure all of you know, but I'll just highlight what this is, our thinking of the thing. Now, a patient comes to me with back pain, which could be like this, vertical, or like this, horizontal. Commonly, I've seen this vertical is because of L4-5 lesion, horizontal is by L5-S1, and this is commonly because of posterior annular tear. Now, don't ask me how do I know. I already told you. I put my scope in the tear and I probe it and I ask the patient, okay, tell me what's happening. Patient says, I'm getting pain in the back. Where? So he says vertical. Okay, confirmed 100%. There's no question about it. Then if you ask the patient to do this test, McKenzie's test, that is this moment, you ask the patient to lie on the belly and raise the chest. Okay, when you raise the chest, when you're extending the spine, what we have done is we have seen this happening in a intra-op MRI. You put the patient inside the MRI machine. You stand inside the MRI machine, which has got two donuts. Patient is awake. You ask the patient to extend the back. What you actually find is the nucleus moves ventrally and you decompress the posterior annulus naturally. The same thing you can see during endoscopy when your scope is inside the disc and you're asking the patient to cough or sneeze or raise the shoulder, you find the annulus falls down, the nucleus moves in the front. So what happens with this McKenzie's test is there is a centralization of the pain. What it means is the pain is in the periphery, in the leg. Patient does this and says the pain is coming in the center. Or the patient has pain like this or like this. And when you do this, the patient says the pain is coming to one spot in the center at lumbosacral junction. When he says there is a centralization, it means that there is a tear which can heal on its own. You don't really have to meddle with it. So what you do is you give medical treatment, these exercises, and you do give an intradiscal injection of any anti-inflammatory substance, which could be steroid, could be platelet-rich plasma, could be ozone, whatever you like. Now, if the pain is not centralizing, then you do a MRI nowadays, or in the past we used to do a discogram, or you can say a checkscopy, for example. You put the scope and see, and you will find there is a fragment in the tear, which you remove. There is no fragment, then you treat it conservatively without surgery. So this is for the back pain. This is a very simple algorithm. Ask the patient to lie on the belly, extend the back, look for centralization. If yes, go for non-operative care. If no, think of imaging, then decide depending on the finding in the imaging. Now on the side, if the pain is like this, on the side, which is spot pain, bilateral, and commonly if you ask the patient to show me the pain, the patient will show with the thumb like this. He will not show with the palm of the hand. He will not say the pain is like this. Okay, you understand? He will show like this. Not like this. So the facet pain is commonly on the side of the spine. It is well localized, and this pain increases with extension. Okay, with McKenzie's, you do this movement, and the patient is, the pain is increasing. So you say, where? So he says, going down, coming in the front, whatever. It moves, increases in its extent. So pain increasing with extension, pain increasing with rotation. Many patients will tell you, my pain increases when I turn in bed. That again facet pain. So in that case, you give an injection around the facet or you do a facet denervation. So I'll tell you what exactly we mean by that. Now, in case of back pain, we know that this is the sinovertebral nerve, which is supplying the posterior annulus. There is the dura mater. This is the exiting nerve. This is the dorsal root ganglion. This is the traversing nerve going below the lower pedicle. This is upper pedicle. The same like the previous diagram, which I showed you. And this area where the sinovertebral nerves are there, this has a dual innervation. It has a sympathetic part of it. It always also has a somatic part of it. So what happens is there is an inside out annular tear. That is a tear of the annulus starting inside the disc coming out. Now, what is the importance of that? In a traumatic tear of the annulus, it is outside in. A tear which is from outside can heal because the disc has a blood supply outside, whereas there is no blood supply inside, so the tear does not heal. It continues to progress and the patient continues to have back pain. So annular tear gives inflammation, then gives chronic dysfunctional healing, granulation, etc. And what we have found is two important things. Pay attention. Number one, in younger people aged around 30, 35, this is a very, very common problem. People have severe back pain, chronic. Most of the people are unable to diagnose them and they have a chronic annular tear with trapped nuclear fragments in the tear giving chronic inflammation. Now, in case of facet pain, as I've shown here, the patient will show by finger. This is the medial branch of the dorsal ramus. You can see this is the dorsal ramus, which has got three branches, the medial branch, the intermediate branch, and the lateral branch. And the medial branch lies in this groove outside the pedicle, and the medial branch continues here on the medial aspect of the facet. So when you're treating the facet by innervation, we are supposed to treat at two levels, because one nerve will cover the medial part of the facet, one will cover the lateral part. So if I want to treat this level, I treat it here on the lateral side, and this nerve will come here. So I treat this level here. So two levels, and commonly facet problem is bilateral. So you treat 4 points, but this is done at the local, under vision, and you can easily do it in about 10 minutes per level. So it takes about 40 minutes to relieve the back pain completely, which is coming from facet pain. Now, leg pain. Leg pain could be patchy, could be full. What I mean by patchy is we have found that lateral aspect of the knee here, parapatellar, infrapatellar, posterolateral of the knee is very, very common complaint in our country. And the commonest problem is the patient says, I cannot sit like this for more than few minutes. The moment I sit like this for more than 5 minutes, I must make my knee straight. Otherwise, it is terrible. Very, very painful here. So this pain, which is on the lateral aspect of the knee or leg, is commonly from L5. In fact, the first indication of L5 pain is the lateral aspect of the knee pain. This pain, if centralizes, that is, the patient does extension and this stops and the pain comes here in the back, and you give a distal block, I'll tell you what this means, and the pain goes away immediately, then you know that this can be conserved. Pain centralizing on extension and getting relieved by injection distally. What it means, I'll explain within a minute. So this you treat conservatively. Now, if the pain is at the back of the leg or the heel, it is commonest is S1. Now, all the heel pains which we have been talking in the past of plantar fasciitis, etc., is all bakwas, nonsense. It is always S1 related pain. You start looking for it, you'll realize what it is. If it is not centralizing and the distal block is not helping, the SLR is positive, there is a neurodeficit, and the MRI or the discogram shows a fragment, go for this transforaminal surgery where you have a stitchless access and there is no fragment, then you think of treating it conservatively. Now, this distal block I have published under this name, sciatica detection and confirmation by new method. Now, what is it? What we have found is when we started seeing patients of sciatic pain, we started feeling the sciatic nerve from the greater sciatic notch right up to the ankle. Feel it, palpate it. And you will find there are 3 areas of the nerve which are extremely painful when the patient is symptomatic. One would be maybe around the ischial tuberosity or behind the trochanter. Second is around the head of the fibula, common peroneal nerve. But important is these 2 points. Point number 1, point number 2. This point is the end of the end of lateral terminal branch of deep peroneal nerve. This is here. I can show, I don't know, maybe difficult to show, somewhere here. You can see it here actually. There is the left foot, there is the anterolateral aspect of the ankle, and that is where the end of lateral terminal branch of deep peroneal nerve is. If that spot is very, very painful, then rest assured that a patient has L5 nerve, L5 root, which is inflamed. And this part is the sural nerve, which is on the lateral wall of calcaneus, just at the upper edge of the calcaneus between the tendo-achilles and the fibula. Now, I can tell you that if this is tender, it is 100% because of S1. If this is tender, most probably it is because of L5. So what I'm going to say is, if a patient comes to you and says that I have pain in the knee, not here, but here, you feel the nerve here, and the moment you push this nerve, the patient will say, this is painful, but this pain has stopped. Then what we do is we have found that this pain because of disc herniation is because of nucleus pulposus acting on the nerve, giving rise to upregulated sodium channels in the nerve. And you know that local anesthetic is a sodium channel blocker. So if you inject sodium channel blocker here, now this structure is called as sinus tarsi. This is the tunnel between talus and calcaneus. You inject 3 cc of 2% plain lignocaine without adrenaline, or you inject lignocaine here, the pain will immediately stop. You have to do this to believe me. I've been doing it for the last 24 years, so I know exactly what I'm talking. In fact, I've published this multiple times. So this is something which will confirm that the pain is inflammatory because it is a tender nerve. You can relieve it by injection of lignocaine, plain simple. And if the pain is relieved and on extension, the pain is centralizing, this big group is to be conserved. These people do not need surgery. They almost always get relieved with non-operative care. Now, what is the use of this? The use is, there is a stage first called as mechanosensitization of the nerve, where the nerve has increased sodium channel proportion, which is detected by my sign. This is my sign. Number 2 is compression, which is because of disc herniation, the mass of herniation, which we commonly have been detecting by straight leg raising. And number 3 is a deficit, which we detect by neurological examination, sensory and motor reflexes, etc. In addition, of course, in case of stenosis, we also do post-void residue of urine on ultrasound to find out whether the bladder is involved. Now, here I must also tell you that when you get a disc herniation, how do you decide whether you would operate that? Is it only on the size? No, you must remember that the disc herniation, the herniation is of 3 types. Type number 1 is pure nuclear herniation, where the piece of nucleus comes out. How do you know that it is pure nucleus? You see the texture on MRI of the center of the disc and the piece. It will be similar. Okay, exactly similar looking, which means it's pure nucleus. Second would be a darker thing, that is a piece of nucleus with dark around, which is a nucleus plus annulus. And the third type is there is nucleus plus annulus plus a fractured piece of end plate. Now, so these are the 3 types of herniations. And the free nuclear piece almost always dissolves in about 2 months' time. You don't have to operate it. I can tell you, you leave it and it just goes away. Macrophages eat it away. Type 2 will take about 6 to 8 months. Commonly, it may not go away. And type 3 will take about 2 years, may not go away. Now, see, there is a very fallacious argument in the society, which we all of us commonly come across with the patient. Patients say, but I heard that this can go away. So you should say, yes, completely. But it may take 2 years, okay, the type 3. And you should say that if you want to wait, there is no problem, but it is uncertain. Now, there are some people who are clinicians who would say, but you know, at the end of 2 years, everything is same. I say, no. What you achieve in 2 years, I can achieve in 1 day. Okay, so that's the thinking about it. Why do we operate? We operate because the biological process, the natural resolution of inflammation may not be predictable. It may happen, it may not happen. There are so many factors. So you tell the patient, if you're improving over the last couple of days, weeks, you wait. If you're not improving, consider why, because this looks like a type 3 herniation or a type 2 herniation, which is not going to go away. It may be longer. And if your activities are important, if your earning is important, etc., you think of surgery. We can relieve you almost immediately on table. Now, in case of stenosis, what we do is this is a 10-question questionnaire, which is administered to the patient. The patient fills up this thing. The first 2 answers, yes, is indicative of a mild stenosis. First 6 answers is a moderate, and all 10 answers being yes is a severe stenosis. And you can see the last question, that walking nearly causes urination. This is a very important question, and the patient will volunteer this. I can tell you, I had a patient, male aged 21. He says, sir, I go to the college, but it's so embarrassing. I said, what? He said, you know, if I walk about 50 steps, I must go to the toilet. Otherwise, I'll wet my pants. I cannot bear this. So things do happen that way. You have to be aware of that. And in all these patients, you must do a post-void residue. Now, what is this idea of doing post-void residue? You must be aware that all of us who operate on spine, in the past, it used to happen that you see a patient, you advise surgery, you operate the patient, and unfortunately, the evening of the surgery, patient says, I cannot pass urine. So you say, okay, no problem, I'll pass a catheter. But in your own mind, you're worried whether you have damaged something, whether something is done which should not have been done, etc. More so when you're operating the patient under general anesthesia. You don't really know, you're pulling, pushing. So here you do a post-void residue. I can tell you in my practice, 18% patients have a high post-void residue in males above 100 cc, in females above 60 cc. So if a patient comes to you with a high post-void residue, you tell the patient, you already have a neurogenic bladder. I mean, in males, you also know that there could be prostate, but after ruling out the other thing, you say that this could be because of detrusor underactivity, and this may worsen for a short time after surgery. You better be prepared. And I always tell all my colleagues that what you speak before surgery is taken as science. What you speak after surgery is taken as defense. Okay, you say the same thing after surgery. You are going to say like that because you have damaged my bladder. Now you compensate me. It's a terrible situation, completely avoidable if you do this test. Now, in case of stenosis, you have to remember what is actually happening is happening in this area, the axilla. Okay, the nerve which is going out, the nerve which is inside, and this area is compressed. There are multiple theories, but I can tell you after going through multiple papers, the conclusion is very simple. It is venous congestion more than arterial ischemia. And this venous congestion, you must be aware in our patients, for example, almost all patients will tell you that they are little better in the morning when they have stenotic claudication after evacuating. When the bowel is empty, they feel, oh, I'm much better. My legs are much better. That is because the Batson's plexus and intestinal venous drainage is connected. So when the pressure there is less, the patient is naturally better. Now, this is a matrix which I have published. I'll tell you what it exactly means. There are 6 symptom groups. Okay. I'll quickly tell you what has happened is when I was a student in 1980, when I started my residency about 40 years back, I was told by my teachers that, you cannot diagnose 65% of the patients. And we used to believe that. I mean, there was no MRI in those days. We only used to do a myelography. And we used to ask the patient, what is your problem? He's here, whatever. There was no correlation of pain or symptom, image, pathology. So everything was all guesswork. And it was a complete mess in those days. So we were told that you cannot diagnose more than 65%. Now today, I can tell you that I can diagnose almost all of them. And the symptoms are only finite 6 groups, nothing out of it. Okay. The first is knee pain, heel pain, groin pain, and coccygeal pain. Now, groin pain and coccygeal pain are S1 related pains. Please mark my word. I have seen hundreds of them. Almost all who come to you with groin, of course, I'm not saying it can't be because of hernia, inguinal hernia, but I'm saying you have ruled out the standard causes. Then the patient has groin pain. Or the patient says, you know what, when I sit erect, there's no pain. But when I slouch, I get pain here, the coccygeal area. That is classic L5S1 related pain. So that is the first group. The second group is low back pain because of facet, which I told you is paraspinal, well localized, increases with extension or rotation. You can treat it simply by anti-inflammatory injections or denervation of the facet. The third is low back pain, which is axial, either vertical or horizontal, discogenic because of chronic posterior annular tear with trapped nuclear fragments in the tear, giving rise to chronic inflammation. And I can tell you that if somebody of you decides to entirely concentrate his career on this, number 3, back pain in younger people aged around 30, I can guarantee you within 5 years, you will be a billionaire. The number of patients suffering is so huge, unimaginable numbers are there. And what is happening today is because most of us are all fascinated with the images, and the dumb image people tell us that, the outline of the disc is normal, except that the disc is black. They don't know anything. Okay, please do not believe the image. They have never ever examined a single patient in their life. They have never treated a single patient in their life. What right do they have to talk like this when they don't know anything about it? So please remember, a low back pain in a young person, 30s, whereas the first complaint which I told you generally in the 20s. You must have seen a lot of young people, adolescents coming with pain around the patella here. It is not chondromalacia, okay? It is sciatic pain. It has started, L5 has started. Please remember this. I mean, look for it. You will find it is there. Number 4 is plain simple sciatic pain of L5 or S1, classic side of the thigh, here, and going up to the big toe, back of the thigh, back of the calf, in the heel, going to the lateral 2 toes, etc. Then 5th is claudication, which is because of a stable spine. That is, the spine is stable. There is no instability whatsoever. Maybe there's a micro instability. And point number 6 is claudication in the unstable spine. That is where you have a listhesis, which may be degenerative, which may be lytic listhesis, whatever. So apart from this, there is nothing. Okay. Now, how this will help you is that when the patient comes to you, don't get overwhelmed by what the patient is talking. You must remember that you already have a plan in your mind where to fit him. He cannot be outside this. He has to be knee, heel, groin, coccygeal pain, back pain, paraspinal well localized, back pain, vertical, horizontal, sciatic pain, where you feel the nerve and confirm L5 or S1 or SLR or whatever, or claudication, where the patient says my pain increases when I stand or walk. I cannot walk beyond this. I cannot stand beyond this time. And there may be bladder affection in that case. And you do an X-ray and you find that the spine is stable or the spine is unstable. So now you know there are 6 categories of patients to be treated. So what we have done is we have achieved this. From this surgery, this is my surgery. In this patient who had a recurrence, I operated through this incision. Now, if somebody tells you that I have done an endoscopic disc surgery from this incision, you won't believe it. I mean, commonly, you know, now you're a surgeon, so you would know it. But we have had a lot of fights with the insurance people where they say, how can you operate? I say, are you asking me a question or are you showing your ignorance? I mean, you don't know anything. You please come and have a look what we do. So this is what we do. Now, when I started in 1999, I used to call this surgery as minimally invasive spine surgery. But what happened is everyone said that I am also minimally invasive, and they just made their incision little smaller. So when they were cutting 70 millimeters, they started cutting 69 millimeters. And see, I'm minimally invasive because yesterday it was 70, today it is 69. So I say, okay, I have no quarrel with you. But I changed the name of my surgery into stitchless surgery under local anesthesia. Now, these 2 features nobody can match. Okay. So this is open surgery, open discectomy or micro-lumbar discectomy, where you would agree that there is a big incision on the skin and comparatively the working area is smaller. So this is like a cone. Now here, this is a micro endoscopic discectomy, whatever. I mean, I call it a pseudo minimally invasive surgery where the skin cut is smaller, but everything under the skin is as big as open surgery. Let us be honest about it. I'm not criticizing. I'm not saying this is bad. I'm saying this is the reality. You are just fooling the patient by saying the skin cut is smaller. Okay, no problem. So this is like a tent. This is like a cone. This is our surgery where we cut the skin and we cut the annulus. In between, we just dilate the muscles. I mean, there is no cut, nothing. So the moment I remove my instrument, it just heals. So 24 hours later, you will find the skin is sticking. You don't need a dressing. You don't need a stitch. And the muscle has just been dilated. So the moment you remove the instrument, it's all fine. The patient can be up and about. So this is the true non-morbid transforaminal endoscopy, which is the real minimally invasive. Now, just to orient you, this is a dissection where you see this is a laminotomy. This is the midline. This is the right side. This is the pars intraarticularis. This is the facet joint. This is the exiting nerve. This is the traversing nerve, which goes down and comes out of the lower foramen. Okay, this is the dural sac. Now, if we look at it, this is our surgery where we put the scope below the pars or below the facet, which is always in the axilla of the exiting nerve. Okay, let me say this again. This is the exiting nerve. So I land here. I am always in the axilla of the exiting nerve. There is no confusion in my mind whether I'm on the shoulder or in the axilla, etc. And when I teach my colleagues, I tell them that when you're operating on the left side, look at your own left hand like this. The thumb is the exiting nerve, the index finger is the traversing nerve. You're always here in the first web space. And the metacarpophalangeal joint of the thumb is the dorsal ganglion. Okay, so it's always like this here in the first web space. For the right side, you see like this. Very easy to remember, very easy to visualize. Now, why do you need to visualize? Because you're not cutting anything. Okay, you're putting your scope more or less blindly, more or less. And then when you put the scope, you start seeing the whole world. So till you put the scope, everything is by guess, by now that is there is a method in it. Let me tell you one more thing, that all our teaching all these years have been by trial and error. I don't like that. I say that why should there be a trial and error? Have you ever seen a jet or a bomber going to the enemy territory and saying, okay, let me try whether I can hit this target? No, I mean, it is foolish. So like that, our surgery is extremely precise. My surgery has a precision of 1.2 millimeters. That is the width of the needle. Okay, so I can put the needle exactly where I want it to be. That is the key to the whole success in this surgery. After I put my needle, then I do certain maneuvers, which I'll show you within the next couple of minutes. Then this is the way we come. So we are paraspinal, about 12 centimeters from the midline. We are intramuscular, we are retroperitoneal, and we are below the.
They call him Superman in China.
So this is a. So this is a transforaminal surgery. This is under local anesthesia. Patient is completely awake and aware. And I have just put in a clip here, which you can see. On the left is a microdiscectomy, and on the right is a endoscopic surgery of the same patient recorded at the same time. Now I would like you to concentrate on the left. There is a little delay. Okay. So what will happen is you see something on the left. Now this instrument going in and trying to get a piece of the disc. Then you will see it on the right there. Okay, here. Now this is what was happening here. On the left is a view from posterior midline, a microdiscectomy. This is a view through my scope. Now here I'm not irrigating my scope at present. So this will look bloody. As you know, the disc is avascular and aneural. So there's no pain, there's no bleeding ever. But here, now see, I have started irrigating. Now this probe, which I put through the annulus, is seen here through the scope. This is seen through the endoscope, where the dorsum is 12 o'clock, ventral 6 o'clock. This is toward the leg, toward the head. Here, this toward the head. This is midline, this is lateral. Now you can see the irrigation, which I'm putting through the scope coming out from here. Now here, what I'm going to do is I'm going to put this probe. You can see this. This is above the annulus here. And now see here, this is above the annulus. That's the tip of the instrument there. Now I'm going to use a cautery here to shrink the annulus. I'm going to use an annular cutter to cut the annulus and have a look. See, now I'm withdrawing my cannula so that I can have a better look. Now see, this is an annular cutter, and you will see the tip of that instrument there when I cut. Okay, can you see that? So what I'm trying to show you here is I'm doing the same surgery which you do as a microdiscectomy, but I do it under local. I do it under irrigation. It is bloodless, it is painless, and the patient is talking with me throughout the surgery. And there is nothing like this, no charring, no cautery, no nothing. So, I mean, this is not a sales pitch, but there is a simple comparison that you see this and you see this. I'm using the bipolar cautery under irrigation on the edges of the annulus, etc., etc. So this is the distinction. And there are many more comparative sort of videos which we have. So this is a hook which I put there epidurally, which you'll see here now. You see the tip of the hook there, which is a blunt instrument, and I can mobilize the fragment, etc., etc. Now here, this is a good indication to me. The oozing which comes from outside, inside the disc, means that I've cleaned that whole thing from inside. And please understand that all disc herniations start from inside. Okay, there should be no argument on that. I mean, herniation will start from inside and go out. It will never come from outside. So our surgery is more physiological. We are at the place where it has started. We are working on the base of the herniation, which could be like an iceberg, where the tip may be small, the base may be big. So in short, this is a comparison. Now, what we found is, like as I said, we do the post-void residue. That started with a question in one of our conferences where somebody said, you know, sir, we have so many people who have post-op retention. Can we not predict something? Can we not do something? So we started doing post-op residue and we found that correlation. Here, what we thought is most of us, when we operate the disc, we do an annulectomy or we take a cruciate incision, etc., and we leave that open. Correct? We don't close it. So we close it. Now this is a platelet-rich fibrin plug. How this is made is very simple. You take 15 cc of blood from the patient, put it in an AP tube, autoclaved plain tube without anticoagulant, put it in a centrifuge. The centrifuge is called a doctor's centrifuge. It costs about 6,700 rupees. Centrifuge is at 3,000 RPM for 10 minutes. At the end of 10 minutes, leave it for 10 more minutes. At the end of 20 minutes, this is what you get. Now here, if you watch carefully, all this yellow is platelets. All that red is RBCs, and there is a line in between called as a buffy coat. That is where the WBCs, etc., are situated. So remove the RBCs and put that whole yellow thing down the tube inside the disc and plug it. So what we do is we close the opening which we have made in the disc for the surgery, and we also close the tear, which is the original tear which is causing the symptoms. And this changes the post-op pain drastically. I mean, after this patient hardly needs any painkiller post-op. And this also stimulates healing because the platelets carry a lot of growth factors. And we are doing a lot of work in Pune in National Center for Cell Sciences and a tissue culture lab where we would probably come out with a biological solution for healing of the annulus very soon. Now, this is the skin cut which I have, which is around 8 millimeters. Now, I'll quickly tell you about stenosis because there is a lot to talk, but I'll just quickly tell you. Now, you look at this picture. What is this? This is, in short, image where I have removed the body of L5. Okay. So what we are looking at is looking from ventral aspect. And this is the pedicle. This is the body of S1. This is the superior articular process. This is the inferior articular process of L5. This is the superior articular process of L5. This is the lamina. This is the lamina. This is the interlaminar area, etc. Now, you must remember that the nerve is coming down and going out of the foramen below the pedicle here. Correct? So that upper zone, which I told you, is actually above the tip of the SAP. So you draw a line from here to here. Whatever lies proximal or cephalad is upper zone. Now here, please remember that in the upper zone, this lamina is not in touch with the dural sac. It is away, correct? It's sloping away. And here it is complete bone. You must be aware that the interlaminar ligamentum flavum is attached to the ventral surface of the upper lamina, correct? So when we do open surgery, we find that the ligamentum flavum will start somewhere here and go down, go distally or caudal. So this area, there is no cause which can cause a compression of the dural sac. Nothing. Here what happens is there is something which all of us have ignored, which I'm going to show you, is a new finding multiple times, and we have seen it hundreds of times, is the lateral part of the ligamentum flavum. Now let me tell you that we classify it like this. There are 3 zones which I told you. The upper zone, supradiscal, middle is the discal zone, infradiscal is the lower zone. There are 3 causes only. First cause is disc and its margins. Second cause is facet and its margin. And the third cause is ligamentum flavum. Apart from this, there is nothing. Nothing changes. Only these 3 things change. And there are 3 walls to be looked at. The anterior wall, the body, the posterior wall, commonly the lamina, and the lateral wall, which is ignored by the open surgeon, that is the foramen, where we land. Okay, the axilla, and we land under the root, etc. So we are dealing with 3 zones and 3 walls, and we do a lateral decompression in case of stenosis. Now, please mind this point that this bone and the bone below, or let's say this bone and this bone, we actually have no business to cut it. There's no reason why it should be cut. It is cut because traditionally, as a legacy, we have been told that interlaminar access is the standardized access. If you ask me as an academic question, oh, I'm sorry.
addition another 15 minutes, and then we can go ahead and see the endoscopic and lattice base anatomy. I hope every one of you saw the basilar and everything. Everyone saw? So we will see the MOCR, LOCR, everything is ready right now. We'll go down to the paraclavian region also. Dr. Gore, you can take another 15 minutes more. And I'm so fascinated by the things that you are saying. I mean, I don't do any spine at all, but you are doing. Yeah. No, but it's amazing how you made that that Buffy that fibrin rich. We've been trying to do that so much time for. We have published about it. We have been doing it for almost 7 years now. It's amazing, what we are really blessed with is these chaps yesterday, those guys who came in. This is a land of innovation. It looks like, So, you have people like us. Like Professor Gore, who comes and innovates so much. I mean, we would like to definitely learn this from you, how you have done this thing. We can use it in skull base.
Yeah, definitely.
Because we are using seal and things, very costly things, fibrin glue and all that.
Yeah.
So if we can use it in skull base as a sealant.
Definitely you can use it, and it doesn't cost. Actually, we did the costing. It costs 8 rupees.
Yeah, so we
really
would
nothing.
definitely like to learn this from you. How Nilesh and Trishant, will you please take notice that we will go to Pune and then we will learn how this is done. Okay, so that we understand how we can start it in skull base. Okay, thank you so much for coming down. And I mean, I just came in and I was listening. It's fascinating.
Very good.
Yeah,
Thank you.
Thank you so much.
Okay. Welcome.
If you can announce that in a batches of 5 they can come and see the anastomosis and have a look at the existence. Okay, after that, in batches of 5.
So what I was telling you is we are looking at the ventral perspective. So for a second, just forget that you do interlaminar surgery. Okay, you are just a beginner and you have never done any spine surgery and you are just going to start it tomorrow. So I'm telling you that you're looking at the ventral perspective. And now here, this is a plane which is at the lower end plate of the upper vertebra or the upper end plate of the disc. So everything above this will be the upper zone. Everything between this and the end plate will be the middle, etc. Now here I have done some cadaver dissection, which I have a long video, but I'm just going to tell you something very simple. What I'm holding is the upper part of the annulus, and this is the superior foraminal ligament between the tip of the SAP and the pedicle above. And this is a very important structure when stenosis is being treated. I'll show you a couple of more things now. So what we have done is we have extended our system into what we call as channelplasty, and where we go for the roof of the canal. Okay, please remember, we are not operating the disc now, we are operating the roof of the canal. And I'll show you a thing or two within 2 minutes. This is what we have as a perspective when we do open surgery. We have the root going out, the second root going out is the axilla, and then this is the pedicle, the disc, etc. And this image is very clearly understood by everyone. But please remember, we are not looking from dorsal side, we are looking from the ventral aspect. Now here the upper zone is marked, the middle and the lower. And for the foraminal perspective, this is the upper, this is the middle, this is the lower. Now this is the upper zone, that is here. Okay, this is the model which has been pictured there. So you can see here the lower vertebra, the upper zone is being seen from below, correct? So we see the dural sac, we see the exiting nerve here, we see the dorsal ganglion, and the only thing which can give stenosis in this zone is a change which occurs here under the pars, which could be a lysis, which will give rise to reparative tissue at the pars or the spondylolytic defect. Second is the ligamentum flavum, which is lying there, which I'll show very soon. The third is the osteophyte, which comes up here, very common. Osteophyte at the lower end plate of the vertebral body, which will push the nerve up. So these are the 3 causes in the upper zone. There is nothing here, no cause in the center at the posterior aspect. There is no cause here because posterior longitudinal ligament is there. Now here, this is the upper zone. Of course, this is our upper lumbar spine, but you can see there is the lamina, there is the ligamentum flavum, this is the posterolateral corner of the annulus. This is the inferior articular process. This is the dorsal root ganglion. And these two margins are actually the foraminal area. So what we are trying to convey to you is that you can easily treat the causes of stenosis in the upper zone through the foramen. Now this is the lower zone. Lower zone is below the, this orange thing which you see is the disc. There is a herniated part in the model here. And what we are looking at is below the disc. Now this is a very difficult zone to tackle. And what we have been doing in open surgery is we have always been doing for all patients, we have been doing a medial facetectomy and probably removing the part of the facet, etc. And unfortunately it breaks down and then you justify putting screws and all that. Now that is not very correct. It is academically not correct because you don't even know where the cause is. And many times the causes are ventral to the nerve. So this is same, this is the lower zone that is inside the pedicle here where the nerve is going out. And this is what it is. This is the pedicle just below the pedicle. So ligamentum flavum comes up here, and these are some venous channels there, spinal nerve here, etc. There is no nerve in the lower zone. Okay, the lower zone, the foramen, there is no nerve, but there is a nerve which is medial to the pedicle. Now, please look at this. This is something very important. This is a 3D fusion imaging of the ligamentum flavum. And what you're looking at, this yellow thing, is the ligamentum flavum. So naturally, it's not something which is horizontal and interlaminar. There's a horn-like thing which is going up. And please look at this. This horn-like thing goes and compresses the nerve. And this black circle is the pedicle. So in the upper zone, this is the lateral part of the ligamentum flavum. Now, how do you know that this is involved? What you could do is you could ask your MRI specialist to do this image. This is my publication on coronal oblique imaging. It is very simple. You tell the MRI specialist that you want a coronal oblique protocol which is used for sacroiliac joint. It is already there in that MRI machine. Coronal oblique protocol SI joint for lower lumbar spine. And then you will find this image, this black thing with that blue arrow is the ligamentum flavum, which goes from the midline right up to the pedicle above, which is what we are talking about, this. Okay, and the blue arrow shows you the portion which is below the facet joint, and everything between the blue arrow and the pedicle is the one which we need to remove if it is causing stenosis of the exiting nerve pathway. Now this is anatomy of the true anatomy of ligamentum flavum when seen from ventral aspect. You can imagine that the ligamentum flavum is not only from here to here, it is going out in the foramen. Okay, as I say, it is not this, it is like this, going up. So this lateral ligamentum flavum, which is here, which is below the pedicle, is what causes the stenosis in the upper part of the foramen. And remember, this part in the middle is quite deep. It is not in one plane. It's a deeper structure, the midline. And in the midline, you know, the ligamentum flavum is not combined. It is separate. There are two different slips. The other important point is at the lower attachment to the ligamentum flavum, it is on the edge of the lamina. And on the upper attachment to the ligamentum flavum, it is below the upper lamina, ventral to the upper lamina. That is why in open surgery, you do a little laminotomy of the upper lamina, expose the ligamentum flavum, then come down, then go to the medial facetectomy, etc. So here what we are saying is, this part is important in the upper part of the foramen where the root is going out. Now, I'm going to make a very important statement. Please pay attention carefully. There has been a lot of talk of central canal stenosis. Okay, there is nothing. We have been made to believe that central canal stenosis is pressure from behind. Completely untrue. It is always pressure from both sides. So I call it, there is a pincer. These are two facets which are compressing the ligamentum flavum. I'm sorry, compressing the dural sac. I'll show a couple of images here. Now, there is another paper which talks about the ligamentum flavum. It is like this, commonly believed to be, but this is what is seen in only 2%. And this is type B and type C, where it goes under the facet, goes up to the pedicle. And this is the only paper in the literature which talks about ventral dissection of the ligamentum flavum. Please read this. This is in European Spine Journal, published by an author named Okuda, O-K-U-D-A. Ventral dissection. So here, what happens is there is a central, there is a subarticular part, there is a foraminal part, there is an extraforaminal part. So this is the ligamentum flavum, this, not in the center. Now this red thing which I have marked is the ligamentum flavum, the one which is above the SAP. Now this is a ventral dissection. Remember, we are not looking from behind, we are looking from the front. So this is the dural sac, and there is a hypertrophy of ligament here and here. This is what causes the central stenosis. The ligamentum flavum growing on the medial face of the facet, not the posterior midline. So here again, in the upper zone, this is the SAP which we cut. And the important thing is, after cutting this SAP, we go around it. That is, we cut the SAP and we go around it like this to the central part of the canal, and we remove that ligamentum flavum. So you must be wondering, how can it be done under local? How can you do it? I mean, we are doing it every day. So this is what it is. Now, this is a patient, as you can see marked here. This is upper zone hypertrophy. This is both middle zone, and we have these curettes. This is the curette below the facet or the tip of the facet here. And this is the way we remove. Now, this is a cadaver dissection. This instrument is in the facet joint. This probe is in the foramen from outside. We are looking at the foramen from inside. That is from medial side towards the lateral side. And this is the way I look at in my endoscopy. This is the nerve, exiting nerve. This is a laser probe. I use laser here and remove this ligamentum flavum. And here I remove the tip of the SAP so as to go around it for the central canal. This is the ligamentum flavum which is inside. And this space is normally occupied by the bone here. On the left is the axilla. Okay, on the left side is the head of the patient and the axilla of the patient. So now I'll repeat that statement. You see, this is the facet, the V of the facet, and just see the gradation. Now here, tell me, do you think that this image is showing you a compression from behind? It's not compression from behind, it's from the sides. Okay, so posterolateral compression of this V like this and not like this. So this can be treated from both the foramina. Okay, we can go biportal, and I can treat central canal stenosis very well by going biportal. So this is what I've done in one of my patients, where I've done this undercutting of the facet, where I've seen that there is a gross increase in the volume of the foramen. And this is final one or two slides maybe. This is the lower zone, which is below the disc inside the pedicle. So this is where it is. This is the lower end plate of the disc, and we work here. Now, let me tell you that this particular structure is how many millimeters from my landing there, you think? It's probably less than 6 millimeters. Okay, it is just there next to me. So don't imagine that you're operating in a football field or something and it's so much away from you. It's just there. The only thing is you have to visualize it better. Otherwise, you won't understand. So here, what I've done is I put my scope here, and very simply, I'll tell you, this white arrow is showing the nerve going inside the lower zone or the lateral recess. This is the pedicle below, which is climbing up this superior articular process. So this is the nerve which I decompress, and this is the decompression for the lower zone. So what I do is, this is a coronal perspective. I work inside the pedicle here, or I work inside the pedicle here. I put my scope here in the foramen at the lower end plate, and then I start from the lower pedicle, go up SAP, cut this, make this big. I may do a medial oblique pediculectomy and decompress this nerve so that this nerve which is coming in this lower zone is completely decompressed. This surgery is here, as we see from inside the canal. It is here on the shoulder of the nerve, and if you remove the upper bone here, you will find it is here where the nerve is entering the root canal. So in short, this is the gist of what I do, and I think I've tried to convey to you what exactly is possible. Now, I am doing it for the last 20 years. Stenosis specifically, I'm doing for the last 5 years. We have all the equipment to do all that. And as per your time permitting, once you finish that, or now for another 5 minutes, if organizers allow me, I'll just show you the instruments and then you can go for your surgery. Okay. So quickly, you just sit here. I'll bring the instruments here and show one by one. That blue tray, yeah. And there is a white model in that red bag. Yeah, so I just want that.
Meanwhile, if anybody has any questions to ask to Dr.
Yeah, please.
Satish Chandra Gore,
Yeah,
please.
please. I'm sorry, I should have. Yeah, thank you.
Sir, nice presentation. As you're talking, you're doing surgeries in local. So I want to know what position and how you give the position and how.
Sorry?
How you give positions.
How we give?
Position.
The
the
position
patient.
is prone.
Yeah.
And the patient is explained before the surgery what we are going to do. So he is not, I know patients are anxious. They feel terrible. They feel that you do something and something may go wrong, etc. So I tell them, don't worry, we are capable of handling everything. Okay. So what we do is the patient is awake. If he is very anxious, then my anesthetist gives IV midazolam or fentanyl or tramadol or anything of that sort. They also give glycopyrrolate prior to the surgery. I can tell you that patients are anxious, but when you explain to them, they are quite okay. I mean, they can tolerate it. And well, we have done it for the last 20 years, so you can believe me. It's not a big deal. Initially, yes. Initially, I actually put it this way, that surgeon is more anxious rather than the patient, because we feel, oh my God, if patient jumps from table, what will happen?
Do you put bolster?
Yeah, I use bolster. There are latex bolsters, and patient is actually, I'll tell you, I start the surgery. The moment you remove that herniation, takes me about 20 minutes. Patient starts snoring. Patient goes to sleep. You have to shake him. Hello, how are you? Okay, yeah. Okay, I'm fine. That sort of thing happens many times.
Thank you, sir. Sorry to just interrupt. Meanwhile, you can show the instruments. Guys can go gather. We'll start displaying our dissections.
You can go
meanwhile.
ahead.
So interested candidates go and see the instruments what sir is showing, and meanwhile we also move forward with the dissections. Yeah. So the sharp vision guys can probably have a view over here as well for the cadaveric dissections. Okay.
Position is like this. I put my scope inside, I put it like this. Camera and the scope in my hand. I use my instrument. What I do is initially, you remember, you find the first case, for example. These are my I'll tell you one by one as a sequence. You just fix it away. Let me see it again. The first instrument which I use is a needle. Okay, there are two needles. One is this, which is 10 inches long. There's another one which is 8 inches long. And the initial part when I start, I know that I will go about 5, 10, 12. I go around 12 and then I have to push a bit long. And to find, let's say, the patient. You told that even Cavernous to touch and so if the patient is awake, first thing I have to do I remove the imagining that you move this line towards the head to accommodate the lower vessel. Okay. Line number one. Third line is in the Let's say you put this in, let's put the food in the patient. And I'm going to put the needle first of the annulus. The first thing I do is slide the then you do little local there. This field, you take an injection syringe. Put a needle through that. Okay, what is it? This inside is complete. And I put my scope inside, right? That's what I will discuss. It is put there. In the next experiment, what I do is this time. This instrument is made as per the this in today last 20 years never happened. Here, if you observe, the dilator and then use that needle. And where is inside to this? The needle is also inside to this. Yeah, the empty we go right up to this. I told you I'm already.
Takashi, are you there? I don't seem to be hearing well. Are you guys hearing okay? Manas, could someone tell me?
Yeah, I can hear Prab.
It's okay?
No, we can't hear anything.
You can't hear well or you can hear well?
No, we can't. We can't.
Okay, let me check. Okay, Nisela, can you hear me? Okay, let me try to get a hold of it. Can someone tell me?
No, you can't.
It's okay.
Dr. John.
Yes, yeah, hold on.
We can't hear.
Okay, thank you. Hold on, let me try to track him down.
Okay.
Nisela, can you hear me?
Dr. John.
Okay, let me try to get a hold of it. Okay.
No, you can't.
It's okay.
Dr. John.
Yes, hold on.
I can't hear.
Okay, thank you. Hold on, let me try to track him down. I'm trying to get a hold of Nisela right now. Nisela, can you hear me?
Yeah, I am here, Dr. John.
Is this Dr. Nisela? Okay, we can't hear.
We can't hear, yes.
Yes, I can't hear the commenting. Okay, thank you. Hold on, I'm trying to track him down. Hello, Dr. Nisela. Nisela, can you hear me?
Yeah, I am here, Dr. John.
Is this Dr. Nisela? Is anybody from Krishna here?
Yeah, hello, John.
Okay, we can't hear.
Yes, sir.
Can't hear the comment. We cannot hear.
We only sounds, echo sounds we see. Echo sounds.
Okay, Krishna, we cannot hear. Can you? Is anybody from Krishna here?
Yeah, hello, John.
Okay, we can't hear.
Echo sounds only. Echo sounds.
Yeah, I can hear it. It's distant. It's distant though. It's not good. Hello, Krishna. Come in, Krishna.
No connection. No connection. Good.
No, I can hear a distant speaking, and there's a Krishna on the panel.
We speak.
Hello, Krishna.
एक रिक्वेस्ट आहे त्यांना मेघना मॅडम मला त्या लेक्चरसाठी वेट करतात त्यांना बसून Can you have please sit? In case we need videos, etc., everything is there with me. So step by step, I have developed teaching videos, anatomy, everything is there. What is the average operating time, sir? Average operating time as a beginner would be 1 hour. After the website.
Hello. Is anybody
Hi, John.
listening? Yes.
Yeah.
We can't hear anything.
Can you hear us? Yes.
Now we can.
Because
yeah.
nobody is talking here.
Oh, okay. Okay, so I'm looking for direction and there isn't any direction.
Right now, Dr. Meghna is here. She is a neuropathologist. She is about to deliver the lectures.
Oh, okay.
Can I request all the delegates to have a seat? And I request Dr. Ayub Cherian, sir, to felicitate Dr. Gore, sir.
Okay, Ayub. Are you there, Ayub? He's going to introduce the speaker. I thought that name looked familiar.
So he's refusing.
Yeah, I talked to Dr. Well a long time ago about doing some webcasts on neuropathology.
Give a hand to Professor Gore, please, guys.
Still no sound.
उसका रेडी कौन है क्या होता है देखने के लिए प्लग देने के लिए प्लग देने के लिए कोई रेडी है क्या होता है कोई
Professor Gore is again a big innovator, and there are people called trailblazers. They're not accepted in the beginning because they are cutting a new path. Okay. Now, when you cut a new path, what happens is for years and years, you will not be accepted. People will underestimate you. It is a big pain, but trailblazers are special because people start following them slowly, and then by that time they'll be forgotten. Their paths will not be. Okay, so this is what you have to understand. It is important to identify a trailblazer. Okay, somebody who cuts a new path. Okay, I'm sure he is one of them. Okay, from whatever I've seen, he's definitely one of them. And I have had my small struggles with a few things. So I know how it is. So it's an honor to have you here, Professor Gore. We look forward to having you here much more often. Small.
Thank you.
This is certificate. Thank you, sir. Thank you for your nice lecture and demonstrations. We are lucky to have you.
I would like to see some. Trying to combine the exoscope and the endoscope together. So we have some ideas. We're trying to do it the exoscope. You can see the endoscope going in from the exoscope. We are trying to do simple things. These discussions are going to be very, very valuable. So please remember, this may be outside the scope of the conference, but these are going to be extremely valuable because
Why not I start using this cannula?
Yeah.
Plastic cannula.
Yeah.
This accommodates my scope.
I see.
As I remove this coating, this very, very, this crystal clear, you can see inside. Remove this before you use.
It's like a sheath for you.
Now, I can put my scope inside. You don't have any limit anywhere. You can see everything around.
So we do that for brain bleeds inside.
Now, there's one more thing. We also have included something in the wall, consuming neuromonitoring. So, something
Now, this is something that you
No,
mentioned
for the IC bleeds.
IC bleeds.
We're waiting for my mic. Is that what we're waiting for? Okay.
Yeah, we can try it for the next IC bleed. Okay, we can cut it probably a bit. Then you
We
can.
will need a bigger diameter because we will the endoscope and suction.
We need a trailblazer to give us audio.
Yeah.
This is a 3D
Okay, yeah, right now we are just
L34.
Yeah.
Thinking about something developing.
This is actual patient data. What we have done is we have put magnets in the pedicle.
Yeah.
And removed it. The point which I'm emphasizing is very simple. This blue thing is ligament observer. And this is not causing any symptom. Only one which causes here. This. You can easily go here.
one more patent which I recently got Indian patent. I have a fulcrum here. On the transverse process. Let's say I put something here, and then I put this above that, so I can easily maneuver. I can remain extraforaminal. Anchoring is outside.
So you go through the muscle.
We always go through the muscle. I always go like this, but here I can go like this. With this fulcrum here, I can go above it. I can maneuver. I can go for the roof. So that becomes very, very easy.
We will try these out.
Yeah.
We will try transfer. When we have a case, maybe we can, whenever it is convenience, we can post it that day so that you can come and teach. We should, we will prefer that you come here so that we will get everything ready for you. And then
We also have a lot of things which may not be available at your place initially. We also have a flexible drill, tip bends.
Metronic
After
one.
this, yeah, I can go like this and I can drill this without even looking at it. We have a plasma.
we have that.
Yeah.
The plasma knife.
There's a,
Is this audio making sense?
Okay. Yeah. Thank you very much, Professor Gore. I mean,
Okay, here we go. Here we go.
Now we will just show the endoscopy and endoscopic as well as the lateral scalp here. You keep this with you so that we can use it for intraventricular. Yeah, I don't know when we will get the time for all this. Yeah, sure. I will just show them the.
I will just complete the Meghna Madam's lecture, then we can shift there.
Sure.
I request all the delegates to please be seated. Yes, sir.
Dr. Meghna is around?
Yes.
Yeah, she's coming.
Dr. Meghna, ma'am.
Dr. Meghna ma'am is here. Yeah. Let me just introduce you guys to Dr. Meghna Chogule. She's a neuropathologist who is interested in neuro all the time. So she's dedicated pathologist for neurosurgery. She has her book publication. She is from Kolhapur. So I request Professor Ayub Cherian sir to felicitate Dr. Meghna Chogule ma'am.
Okay, we need to change the screen.
लॅपटॉप मध्ये मला पीपीटी स्क्रीन होती पाहिजे ना आता पीपीटी प्रोजेक्ट करते तिथे त्यांना यांना त्यांचं पीपीटी घ्यायचं आहे दिलंय ना त्यांनी
Meghna is a neuropathologist. She's a rare breed. Huh? So if you want to have a good neurosciences center, there's no way you can skip neuropathology. And like neurosurgery, general pathology and neurosurgery, like general surgery and neurosurgery is different. Pathology, general pathology and neuropathology is very different. So we are fortunate to have her around in Kolhapur. We are having her to join here as faculty. So the next time you guys come, we will have interesting cases with her expertise. We are hoping to move forward. Thank you, Meghna.
Slide changer.
ये कौन सा लेक्चर है सर?
I request all the delegates to please be seated. Madam is starting her lecture.
Should I start?
Yes, ma'am.
Good afternoon, everybody. At the outset, I would like to thank Dr. Cherian sir and the organizing team for giving me this opportunity to present some of the cases which I have reported. Let me start with case 1. A 65-year-old woman presented with convulsions and hemiplegia. MRI revealed a well-defined heterogeneous, predominantly extraaxial right parietal mass measuring 3.9 into 5.1 into 3.5 centimeters, abutting the underlying cortices. It appeared hypointense on T1 and hyperintense with multiple intralesional cystic foci within on T2. Patchy areas of intralesional blooming noted in gradient images. The post-contrast study revealed marked heterogeneous lesional enhancement with non-enhancing cystic component and enhancing dural-based solid component within. The radiologist suggested possibility of cystic meningioma. Let us have a look at the anatomical distribution of the major brain tumors. So in this case, what we thought was it could be meningioma, solitary fibrous tumor oblique hemangiopericytoma, and remotely a metastatic tumor. So we received this specimen in our lab, Shanti Pathology lab. It was a single oval, well-circumscribed, gray-white to gray-brown soft tissue tumor along with a dural flap. The tumor measured 4.8 into 4 into 3 centimeters, and cut section of the tumor revealed gray-white to yellowish areas. Now we did frozen and squash in this case, and taking into consideration the extraaxial location, we suggested this to be a high-grade spindle cell tumor with increased vascularity, and we gave differential diagnosis of solitary fibrous tumor, HPC high-grade, and anaplastic meningioma. Again, we couldn't come to a very great diagnosis on histology. I again could see a high-grade spindle cell tumor, but favoring the diagnosis of SFT, that is solitary fibrous tumor oblique HPC. On microscopy, brisk mitotic activity, microvascular proliferation, and necrosis was also noted. Immunohistochemistry was an eye-opener in this case. So what we found was these tumor cells expressed GFAP and S100 strong positivity, indicating it a glial tumor. It was IDH negative, that is, we call it IDH wild type. CD99 and FLI1 were focally expressed, suggesting mesenchymal component. EMA was negative, so the possibility of meningioma was ruled out. CD34 and STAT6 were negative. Solitary fibrous tumor oblique HPC was ruled out, and the MIP1 was high. It was 18 to 20%. So the diagnosis is very clear now. It is glioblastoma with mesenchymal differentiation, IDH wild type, WHO grade 4. So the extraaxial location and the spindle cells is glioblastomas are IDH wild type, which account for 90% of tumors. Glioblastoma IDH mutant, which account for 10%, and glioblastoma NOS, that is not otherwise specified. Now, glioblastoma IDH wild type will show all the features of glioblastoma, but it lacks mutation in the IDH gene. It has 3 variants: giant cell glioblastoma, gliosarcoma, and epithelioid glioblastoma. Now, the giant cell glioblastoma and epithelioid glioblastoma, they occur in the younger age group, and they show little better prognosis when compared with the conventional glioblastoma. Now, this IDH mutant glioblastomas, definition is similar to IDH wild type, but there is mutation either in the IDH1 or the IDH2 gene. And glioblastoma NOS is again same as above, but the tumors in which the IDH status has not been fully assessed. Let's have a look at the immunohistochemistry of glioblastomas. So these are GFAP, S100 and OLIC2 positive tumors, which indicate its glial origin. As already discussed earlier, if it is IDH1 positive, then we call it IDH1, or IDH2 positive, we call it IDH mutant glioblastoma. If the IDH status comes negative, then we call it wild type, and the MIB1 is high. It goes to 15 to 20%, but in some cases, the proliferation index may even go up to 50%. The other markers which are also expressed are ATRX, P53, Nestin, EGFR, WT1, and cytokeratins. Now let us have a look at the epidemiology, radiology, histology, IHC, and the molecular features of the IDH wild type and the IDH mutant glioblastomas. So the IDH wild type glioblastomas, they arise de novo, so they are also called as primary glioblastomas, whereas the IDH mutant glioblastomas, they arise from a pre-existing low-grade tumor. Now, wild type are most commonly found. They are 90% as compared to the IDH mutant. The median age is 62 in the wild type, and in IDH mutant, it is around 44 years. Now, if you see the radiology, IDH wild type are enhancing tumors, and they show large areas of central necrosis, whereas IDH mutant are mostly non-enhancing tumors, and they will show lesser areas of central necrosis as compared to the wild type. Similarly, it will project on histology. Extensive areas of palisading necrosis will be found in the wild type as compared to the mutant. Now the molecular study is important. The IDH wild type, they will show third promoter mutations in almost 72% of cases as compared to the IDH mutant, 26%. The P53 mutations are more common in IDH mutant than the wild type, and ATRX is rare in the wild type, whereas it is found in approximately 71% cases of the IDH mutant. Now, EGFR and P10 mutations are commonly found in the wild type and rarely found in the IDH mutant glioblastomas. Now, what is this IDH1? It is the isocitrate dehydrogenase enzyme, which is found in the Krebs cycle, which catalyzes conversion of isocitrate to alpha glutarate. IDH1 mutations are much more common as compared to the IDH2 type. Now, how do we interpret it? We interpret it on immunohistochemistry. If we get negative results on immunohistochemistry, then confirmation should be done on DNA genotyping, and before calling it IDH non-mutant or wild type. Now, what is this NOS category? If the IDH testing is not available, or it cannot be fully performed, or is inconclusive, then we label the tumor as NOS type. Now, the upcoming WHO 2021 is also coming with another category, that is NEC, that is not otherwise classified, where the histological and the molecular features are mismatched. Now, how this IDH1 helps us? Why do we do it? So it will basically help us in typing and grading of the tumor. The gliomas are positive for IDH, whereas the reactive gliosis will not exhibit IDH mutation. All the oligodendrogliomas are positive, whereas the other clear cell tumors, that is metastatic renal cell or atypical neurocytomas or clear cell ependymomas, they are negative for IDH. Then astrocytomas and oligos are positive, whereas other non-glial tumors are negative. Now, in grading, how does it help? Pilocytic astrocytomas, which are WHO grade 1 tumors, are negative for IDH, whereas grade 2 and 3 gliomas exhibit IDH mutation. So we do this because it has effect on prognosis. The IDH mutant tumors, they have better survival compared to the wild type. The predictive response to radiation and or alkylating therapy. And also, as I told you, survival is better in the IDH mutant tumors. Now, ATRX, it is alpha thalassemia mental retardation syndrome, X-linked. This is a common mutation which is found in the IDH mutant astrocytic tumors, WHO grade 2, 3, and 4, and it is rarely found in the oligodendrogliomas. Now, in adult gliomas, ATRX, P53, and IDH1 or 2 co-occur, whereas in pediatric gliomas, ATRX and the histone monomers co-occur. Now, you must be seeing in our reports P53. So P53 is a tumor suppressor gene located on a short arm of chromosome 17. Loss of P53 is found in medulloblastomas, glioblastomas, and IDH mutant astrocytomas. Let me give you information about the upcoming WHO 2021. So the astrocytic tumors, according to 2021, will be IDH mutant and IDH wild type. Now the IDH1 mutant tumors which show moderate cellularity, atypia, and less mitosis, no mitosis rather, no necrosis and no microvascular proliferation, and the MIP1 index is less than 4%, and on molecular, there is absence of CDKN2A homozygous deletion. That is, then the astrocytoma will be grade 2 astrocytoma. IDH mutant grade 2 astrocytoma. Now, when the tumor shows increased cellularity, atypia, mitosis, but no necrosis and no microvascular proliferation, and the Ki67 index is between 4 to 10%, and again there is absence of CDKN2A homozygous deletion, then we'll label it as astrocytoma IDH mutant grade 3. And when the tumor is highly cellular, highly anaplastic, brisk mitotic activity noted, along with necrosis, microvascular proliferation, and homozygous deletion of CDKN2A, then we call it as astrocytoma IDH mutant grade 4. I think you must be seeing that the grades 2, 3, and 4, they are written in Arabic. Initially, we had these grade 1, 2, 3, 4 written in the Roman. So this is going to be the new WHO, as well as what has happened for the grade 2 tumors. We used to say it's a diffuse astrocytoma. For grade 3, we called anaplastic astrocytoma. And grade 4, we say glioblastoma, WHO grade 4, either IDH mutant or wild type. So we are just going to call it as astrocytoma IDH mutant grade 4. If it's IDH negative, then we will call it IDH wild type. So we have to get accustomed to this grading 2, 3, and 4 in. Yes, yes. Exactly. That will be gone and we'll be just calling it grade 2, grade 3, and grade 4. Yeah, oligo will be separate. Yeah, yeah. And initially, to call it astrocytoma, we used to check 1p19q co-deletion. If it came co-deleted, then we call it oligo. But now that criteria for calling it astrocytoma when the 1p19q co-deletion is absent, so that is not mandatory. Okay. So now these IDH wild type tumors, typical glioblastoma, classical features, that is high cellularity, marked atypia, brisk mitotic activity, microvascular proliferation, necrosis. It is going to be glioblastoma or astrocytoma WHO grade 4. But now this is very important, okay, because most of the neurosurgeons, they say that, oh, it had been reported as a grade 2 tumor or a grade 3 tumor. It was not looking as aggressive as grade 4, but how did it recur? So let me bring this to your notice. Any astrocytoma histology, that is, it may look like grade 2 or it may look like grade 3, but if they show third promoter mutations, EGFR gene amplification, or gain of 7 and loss of 10 chromosome, then it will be labeled as grade 4 astrocytoma or glioblastoma. I hope you're understanding. Means the histology report on histology or HE slide it will look like a grade 2 tumor or a grade 3 tumor. It will not show necrosis. When do we call it glioblastoma? When we see brisk mitosis, necrosis, and microvascular proliferation. But we are unable to see that on histology. Okay, then we go for them. I hope I'm trying to simplify things. Then we go ahead with the molecular, and they will show all these. If they show any of these mutations, no. Now, no. Again, wild type can be any grade. It can be grade 2, 3, or 4. Means on histology, suppose your pathologist reports it's a grade 2. No. Wild type can be again any grade. I hope I made this point clear. On histology, it will look low grade, but the clinical course of the patient will be very aggressive. That's why they have imposed upon doing these molecular studies, even for the low grade tumors. Let's have a look at case number 2. A 70-year-old lady presented with lower limb weakness and pain, incontinence of urine, and features of lumbar radiculopathy. She also had forgetfulness. Now, MRI revealed an irregular, heterogeneous, hyperintense lobulated mass in the cavum septum pellucidum, frontal horn, and body of the right lateral ventricle, closely abutting the body of the corpus callosum. The tumor measured 3.6 into 4.5 into 4.3 centimeters. On FLAIR, T1, and post-contrast, a heterogeneous enhancing mass was noted. So on radiology, the radiologist said it could be a high-grade glial tumor. We can have a look at the intraventricular tumors. Okay, so tell me. No, it was mainly intraventricular. So what comes to your mind? Okay, yes. So the differential diagnosis which come to our mind are high-grade glial tumor, could be glioblastoma, anaplastic ependymoma, anaplastic oligodendroglioma, again intraventricular meningioma or typical neurocytoma, METs, and even SEGA are they are found in the younger age group, but sometimes, you know, in elderlies it is an incidental finding when they go for the scans. So this is what we received in our lab. So on intraoperative cytology, a mixed tumor was noted, that is fascicles of spindle cells with interspersed anaplastic glial cells. You can see this is one. This is a single astrocytic cell. So you can see the size and even the large nucleolus in this. On histopathology, it was a biphasic tumor showing predominantly sarcomatous component and anaplastic glial component interspersed. So we did immunohistochemistry in this case. So what was expressed in the tumor cells was GFAP and S100 was found positive in the glial cells, whereas the sarcomatous cells were negative for GFAP and S100. We did a special stain on this. The reticulin was positive in the sarcomatous component. The P53 mutation, means P53 overexpression, was seen in glial as well as the sarcomatous component. Vimentin was positive and the MIB1 is high. It's 10 to 12%. So what do you think? Yes, correct. Yeah. Now I'll tell you how we arrived to the diagnosis. So let me tell you the negative markers. EMA was negative, so meningioma was ruled out. SMA was not expressed. Rhabdoid tumor was ruled out. SOX10 was negative. Schwannoma was ruled out. And again, synaptophysin and chromogranin were not expressed. So SEGA or any ganglionic or a neuroendocrine tumor was ruled out. And again, we did the IDH status because we had the glial cells in that. So it was IDH negative. That means what it is? Yes, wild type. Yes. So we came to the diagnosis of gliosarcoma, WHO grade 4. Let's have a look at the case, third case. A 50-year-old man presented with headache and delirium. MRI revealed a heterogeneous extraaxial dural-based mass with skull bone erosion and extension into the scalp. What do you think it is? Yes. 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 And most common. First bring always the most common DDs to your mind, and then you should have a list of rest of the things. Pardon? Could be. Now we are just discussing DDs. Okay, yeah. So what comes to our mind is aggressive meningioma, that is anaplastic meningioma, METS, lymphoma, or a high-grade glial tumor. So on intraoperative cytology, again, the tumor was a high-grade spindle cell tumor with increased vascularity. So we suggested maybe a typical or anaplastic meningioma, solitary fibrous tumor oblique, hemangiopericytoma, and Ewing sarcoma. So on histology, this was a structure. It was a patternless compact tumor. You can see increased vascularity and branching of the blood vessels. Okay, that is called as staghorn appearance of the blood vessels. Necrosis was present and it was showing brisk mitotic activity as well. So we proceeded with immunohistochemistry. These cells were GFAP negative, that is a glial tumor was ruled out. EMA was negative, meningioma ruled out. CD34 was lost in the neoplastic cells. CD99 and FLY1 was negative, that is Ewing sarcoma was ruled out. And cytokeratin negative, metastatic carcinoma ruled out. And what came positive was STAT6. Now this STAT6 nuclear positivity is because of genomic inversion at 12q13 locus causing fusion of these two genes, NAB2 and STAT6. So can anybody tell me what is the diagnosis? Yes, yes. So an impression of final diagnosis of solitary fibrous tumor, hemangiopericytoma, WHO grade 4 was made. Now let's see what is this SFT phenotype and HPC phenotype. Now SFT is histologically grade 1 tumor. They behave in a benign fashion and the treatment of choice remains gross total resection. While this hemangiopericytoma, HPC phenotype, these are histologically grade 2 or 3 and they show high recurrence rate and they may even have intra or extracranial metastasis, and adjuvant radiotherapy is beneficial in HPC phenotype. Let us have, since meningioma is the most commonly occurring tumor and DD for this. So WHO grade 1 meningiomas are benign tumors and they are most commonly occurring. And they have very low risk of recurrence, that is 7 to 25%. And the MIP1 in these tumors is less than 4%. Now, WHO grade 2 meningiomas, the incidence is around 6%. And the atypical meningiomas will show increased likelihood of recurrence, that is 29 to 52%. And the MIP1 here is more than 4%. Whereas the grade 3 meningioma, these are rarely found. They have malignant potential. They may even metastasize and the recurrence is around 50 to 94%. And the MIP1 is very high in the anaplastic, that is WHO grade 3 meningiomas. It is more than 20%. So this is how I conclude my lecture. I would be happy to answer your questions. It is a diffuse astrocytic glial tumor, but they are all IDH mutant tumors and they will show 1p19q co-deletion. Again, they are graded as grade 2 and 3. Grade 2 and 3. Yeah. Yeah. Yes. No, I have not, because because of the time limit, I have not. Yeah, so high grade meningiomas, depending on the molecular, they will show the CDKN2A, cyclin dependent kinase inhibitor 2A mutations, as well as they may show TERT mutations. Yeah, so this is what they have added. Exactly, yeah. And they have included many more entities for gliomas. Pediatric gliomas have been separately classified. They have also included 6 new entities of glioblastomas. Again, H3K27 mutant tumors. They have specified the criteria that only the midline tumors with histologically features of high grade should be called as H3K27 mutant glioblastomas, because even some of the ependymomas or the pilocytic astrocytomas, they may express this H3K27 mutation. So they should not be labeled as these tumors. Diffuse midline glioma.
Okay.
You can ask me personally if you have any questions, because we have to proceed.
Thank you. Thank you so much,
Thank
ma'am.
you very much.
Zoom John?
Yes.
Hello.
Yes.
Dr. Meghna just concluded this lecture. I think Lars is in there and he wants to have one lecture there.
Okay, do you want to introduce the next speaker?
Lars.
Yeah. Good morning. Good morning from Germany, doctors. Here's Lars is speaking, and thank you for inviting me and giving me the chance to make a short presentation on a product. Maybe some of you don't know. I hope you can hear me good and well, and I hope you are all fine all over the world. Okay, so let's start. IAP has invited me as Cherian and myself. We are since a couple of times good friends, and I am currently working for a startup based in Austria, which has founded one of the revolutionized microscopes in the world in the past. To be clear, 3 years ago, and I would like to show you just 2 video sequences and giving you the chance in the after that to take me some questions and maybe to get in contact with us. So I will start. As I see the guys are doing a little surgery with a classical microscope, and I will share my screen with you and show you a short video. I don't know if it works with sound, but if you have any questions, just jump in and ask me the questions. That would be great.
Okay, you're gonna share it now?
Yeah, John.
Okay.
Yeah, I will share now.
Okay, we can't see it now. We can't see anything.
Okay, so I will share it now.
Yeah, make sure you turn the sound on too. So
yeah, I'm connected with my headsets. I'm not sure if it's work with the sound now on the.
Yeah, I'll let you know. I'll let you know once you start it.
Okay, so I will start it.
Okay.
And just make the full screen. Okay, switch a little bit back, and then you will see it. Okay, does it work with sound, John?
There's no sound now. No sound.
Okay, so maybe it can be possible that
Well, when you start the video, before you start it, it asks you, do you want to include sound? When you share it, that's when it asks you if you want to share sound.
Let me
so start again. So start the video again. Okay.
But the sound is turned on.
Yeah. You got to start from the beginning. Turn the video off. Turn it off completely. Completely.
Yeah, I will start new.
When you turn it off completely, get it off the screen. Turn it off. Turn it off.
Wait a second.
You got to start. the whole thing all over again. Turn the video off.
Yeah, but let me do. I just having some issues with the laptop, but I can tell you what you will see now.
Okay.
That would also be working. Okay, we will start. Okay, here you will see the first robotic scope in the world. We have done or we have the idea to cut the view and the seeing. As you see, where's the robotic arm? This is one of our CEOs. This is Marcus, which is the guy who has the idea 3 years ago. Here you see our production sites for the oculars, and our robotic scope has the main benefits that that you can sit ergonomic, that you can do your surgery ergonomic free, and change your angles without moving your body, just with some movements from your head, and you will always have the view to the surgery field, to the cetus before your eyes. As you see here, you don't need to move. The robot arm is moving for you. There are 2 cameras in with a 3D 4K build. This is our CSO, with his Mike, and you see some guys of our office in Austria. Yeah, and here we have done a great research, and yeah, with last March 2020, we have get the CE mark, and we are shortly before the approval for the FDA in the States. Yeah, and with I don't want to miss you to show, and I've asked I to show you this. And there is a second video, because what is also mandatory for you is that you do your surgeries not alone. You can also do your surgeries with 2 guys or more. And we have developed, and this is brand new, you will see it as one of the first surgeons in the world. You can view with both surgeons. So one is the master, who is able to change the perspective, and the second will have the same view as you maybe do with microanastomosis or something else. And yeah, that was my short introduction to the robotic scope. If you have questions to this, maybe to mention one thing, I am in negotiations, and I'm still in a great contact with Ibe. He will get he will become one of the first robotic training centers in the world, based in India. We are just in the ending of our negotiations, and yeah, so you are invited. We are planning to install this in his new cath lab in May or June, depending on the pandemic and on the travels. But if you are interested in something, you can get connected directly to me, or you can connect with us via our official email address. I will put it into the chat here. And yeah, to know, we are in Europe, in every single land. We are just setting up Spain next week with an entity. And for the States, we are happy to have our new office since last week in New York. So we have robotic scopes all over the world nearly. And if you like to see more, we are happy to get you on our screen. So thanks for your time, guys.
Okay, Lars, I would like to invite you to do a presentation separately on neurosurgical TV of this interesting project. We'll talk later.
Yeah,
okay?
just give me a mail, and we will make an appointment, John. That would be great. Yeah.
Great. Okay, panelists, questions for this interesting technology. It's one of the only centers in India, I guess, right, Lars? Is one of the center for robotic, this type of equipment? Okay, any questions, comments? Okay.
So,
Ipe, are you there? Ipe, are you there? Maybe Ipe could comment. Now, Ipe has used this, right, Lars?
Not currently. We are negotiating because we have done some meetings, some online meetings with IPE for some new features, and now we are still in the negotiations and organizing the transport to IPE's institute.
Oh, excellent.
So yeah, and on the pandemic, it's a little bit complicated, as you maybe know.
Right. So you're essentially training IPA. So it's going to be a training center for your equipment.
Yeah, that's correct. It could he would become the first training center for neurosurgery in the world.
Oh, excellent. Excellent. Where is it in use right now somewhere in the world? Is it someone using it now somewhere?
Yeah, on your discipline, it's used by Dr. Mottini in the near of Milan in Italy.
Oh, okay.
Yeah, he has it installed since beginning of December, and our main focus was before the ENT discipline, but we have learned during our trials that there will be a great approach also to neurosurgery for
Good.
skull base and for spine. Yeah.
Okay. Yeah, I guess that's common area for both specialties, the skull base. That's what I'm learning.
Yeah, I know.
Dr. Dio Pujari, are you there? I'm going to pick on people that I see here.
Good afternoon, John.
Hi, Dr. Dio Pujari. Did you see this product?
Yes, I'm seeing some dissection and I'm listening to the talk. Yes.
Oh, okay. Okay, welcome. Okay, Lars, anybody else have a comment or question on the robotics? And I guess, Dr. Nisla, what's the plan now? What are we going to do? Are you there, Dr. Nisla? He's leaving me floating here. What's the next talk, Nisla? Dr. Nisla, are you there?
Is that Narayan, is that Jankiram dissecting?
Let's see, possibly, let me check here. Yeah, okay, well, let's get you off the screen there, Lars.
Yeah.
To see what is going on here.
Yeah, I stopped sharing my screen, John.
Yeah, okay. And I'm unmuting. Okay, we'll just hang here and wait to see what happens. Oh, I see. Yeah, I see what you mean. So I'm gonna pin that. Okay, now we're just gonna get the audio working. Hello, can anyone hear me? We need some audio here. Okay, let me try calling. Hello? Okay, just hang in there. We're getting, trying to get in touch with the head there. Oh, break, oh, taking a break. Oh, okay. Oh, break time. It'd be nice of them to let me know that. It's nice to let me know after the break that we had a break. Okay, we'll be back in 15. Just hang in there. Hello, Saeed.
Yes, John. How are you?
Yeah, this is unofficial. We're off the, well, we're on the air, actually. People are watching us talk, chit chat.
Yeah, it's a great lecture.
Yeah, that's great. That's
Very,
great.
very interesting. And the great lecture of Dr. Menga. It's very interesting on brain tumors.
Yeah, I'd like to ask her to do a series, you know, neuropathology.
Yes, we have next on June a neuropathologist, Professor from Marseille.
Oh, good.
Yes.
Olivier
Chino. Olivier Chino, excuse me.
Oh, okay.
He's my friend, actually.
Oh,
Olivier
good.
Chino is an expert, world renowned pathologist, neuropathologist.
You know, Dr. Goel.
And at the same time, we will have Professor Dufour and Professor Chino.
Oh, good. Good. You know, Dr. Goel's wife is a pathologist, neuropathologist.
Yes, great.
Yeah. Do you know her? No.
Excuse me, I don't understand.
Do you know her, Dr. Goel's wife?
No.
Okay.
No.
Okay. She's a neuropathologist. But I'm going to ask Megana if she wants to do a series.
Okay.
And also vendors like this robotics equipment, and I think they can have sessions with doctors, essentially showing their product, kind of playing with the product, especially with VR and AR being more used. I think they'll be able to showcase their products a lot more effectively, almost as good as being there, I think.
Yeah, it's very interesting. That's the future. Where are we in the future? Where are we in the future?
Yeah, I think advertisers,
the progression of
it's going to affect them. It's going to affect them too, as far as the way that, you know, potential clients are, you know, advertised to. And this will be an area, maybe commercials in the webcast, like television, because it's a television platform.
Yes.
Hello, Dr. Nasula. I gotta see what we're doing. Oh, 15-minute break. Okay. Nalesh. Okay. Yeah.
Hello, John.
Yeah, hi.
Yeah.
Yeah, we have a 15-minute break, right?
Yeah.
Okay.
Yes. We are having food, but Dr. Sushil Patkar will be joining soon. He will start his lecture at 2 o'clock.
Okay, just let us know.
Yeah.
In another 10 minutes maybe.
Okay.
I'll just.
Yeah.
Whether he has
देना यार जल्दी, मुझे जाना है। Thank you. जल्दी से छाती जाना है मुझे। चालू है। चालू है। हाँ। भी टॉपिक। अरे सोचो फॉलो फॉलो अरे उनको चल
Hi, everybody.
Hello, are you going to introduce the next speaker?
Hi guys, can you hear me?
Yes, we can hear you. Let me see if I can get you an introduction. Dr. Patkar?
That's right.
Okay, yeah, we're a little disorganized. Hello, hello, can you, okay, I guess
Yeah,
I'll
this is Dr. Nilesh. Hello.
Okay, yes,
Yes.
you're gonna introduce the next, you're gonna introduce the next lecture?
Yes, sir. The next page is Dr. Sushil. Sushil is one of them.
No,
In the whole of India, you can say.
No, that's not good enough. No, that's not a good introduction. We need someone to give an introduction from a good computer. Who can do that? Can someone give us an introduction from a good computer? Okay, I guess I will. Hi, this is John Bannon from Neurosurgical TV. We're having a webcast simplifying Atlanto-axial fixation innovation with Sushil Patkar. Okay, Dr. Patkar, it's all yours.
Good afternoon. Can you see my presentation? Is my presentation on?
Yes, it is.
You guys can see my slide?
Yes. Do you want to make it
Okay,
larger?
so
There you go. Perfect.
That's right. Thank you very much. At the beginning, let me thank my dear friend Aip, who has begun with a bang in career, and I'm sure he has got miles to go and miles to go to change neurosurgery and the type of neurosurgery that is being done around here. And I thank Aip for this opportunity. So I'm going to just share a little bit of my work on Atlanto-axial fixation. I have no disclosures. The only disclosure is my mentor, teacher, and guide, Professor Ramani, from whom I learned spinal surgery. So I look at Atlanto-axial joint somewhat like a maze, and we have to find a solution which is straight through the maze. If you look at C1, C2, the predominant movement in C1, C2 is rotation, and any operation which fixes the rotation will fix the Atlanto-axial joint and treat the instability. Megal's technique described in 1986 did good justice to it. Unfortunately, the anatomy of the vertebral artery prevented this operation being performed in almost 30 to 40% of the cases. So in spite of being an excellent operation, it fell out of popularity till this anatomy was discovered, where they found that the vertebral artery can be very high riding and there can be very little place to pass the screw across the joint without injuring the vertebral artery. It was Dr. Goel in 1994 and then Hums in 2001 who changed this concept where you could pass screws into the pedicle or the pars of C2. And then, of course, a lot of people try to give credit to Dr. Goel or to Dr. Hums when actually it was Goel's technique. But I'm happy that of late all this has changed and people call it the Dr. Goel's technique. Then when I studied the pedicle and pars of the C2, I found that the course of the vertebral artery can be very variable, and that in spite of any technique, there always remained a chance of vertebral artery injury. Necessity is the mother of invention. Research is search again. And if you look at the CT scan, there is always dense bone under the facet of C2. And the fallacy of the CT scan is till you do the CT scan in correct coronal planes, you cannot identify this bone. There is always dense bone under the facet, free of the vertebral artery. And if you pass the screw just under the facet joint, the entire discussion about vertebral artery and injury to the vertebral artery becomes redundant. There is no need of the talk of vertebral artery injury or navigation, etc. if you use this new trajectory just under the facet joint. Instead of passing the screw from the pars or the pedicle, you pass the screw right underneath and let the screw go downwards into the vertebral body. So now this is an example. You can study this, that there is always bone under the facet of C2. This is another example, and see how the screw is passed. And these screws, my dear friends, are divergent screws. They go down to the body. And if you go back to physics, you'll find, see this, it need not be that the screw heads have to be parallel to each other. The C2 screw can be above and the C1 screw. The idea is that the screw should be holding the joints together and give you good space for putting bone graft. And you can see this even in a very high riding vertebral artery, still this technique can be done without any fear of injuring the vertebral artery. These are divergent screws, and a divergent screw construct is biomechanically superior to parallel screws described by Goel and Harms. And then this technique got published way back in 2016 as a new entry point for the C2 screw in posterior C1, C2 fixation, significantly reducing the possibility of vertebral artery injury. Then British Journal of Neurosurgery, then Global Spine Journal, etc. But then I was not still happy. VSP plate screw construct is stronger than a polyaxial screw rod construct. Actually, polyaxial screw rods came in lumbar spine because the plates could not be bent sidewards. And therefore, people came out with polyaxial screws. In C1, C2, there is no such problem. And therefore, we must resort to using the VSP plate. The VSP plate gives you better opportunities to fix, reduce, manipulate the C1, C2 joint. Like this example, can you see this? If you pass the screw and use a VSP plate, there are multiple holes in the VSP plate where you can adjust. This was, of course, published as a American Association of Neurological Surgeons poster. And this was the concept that you could have multiple opportunities to adjust the screw in the C1, C2 joint. And these are some examples where you can see you can bring posterior compression, distraction of the joint. And then I went on to modify the screws. And this was the final construct. And you can see this concept is very simple, that you pass a Steffi kind of screw. These were made for me by Jeon, put the spacer, and you can pull the joint, the C1 backwards, and manipulate the C1, C2 joint in the VSP plate, reduce it, compress it, and the VSP plate is definitely more. In polyaxial screw construct, you will have to loosen, and the moment you loosen the top nut, the implant becomes unstable. So this got again published in Journal of Neurosurgery in the June 2020 issue. I will show this video later if you have time. But this was the technique which was published in JNS, the video journal section in June 2020 as a cover page article in the July 2020 issue. Then, of course, still I was not happy and restless because of the paravertebral venous plexus and the vertebral artery, the necessity to divide the C2 root. And these were all cantilever constructs from behind, trying to manipulate the body in the front, and the line of weight transmission was in the front. If you see the recent literature in lumbar spine, there is a slow but definite shift towards understanding fixation in lumbar spine, and A-lift procedures like X-lift, O-lift, these are becoming more popular than P-lift and T-lift, and people are now shifting anteriorly because the most important thing is to use a wedge-shaped cage which can recorrect and recreate the lordosis of the lumbar spine. The same concept, if you study in the C1, C2 joint, the weight gets transmitted from the occipital condyles to the atlas and then onto the C2 facet. Very little weight goes on to the posterior aspect. So the essential fixation must be here. If the patient in extension has got angle of mandible above the C2 through disc, then these patients have to be operated from the front, and this is possible in more than 95% of the cases. And you have to realize that this operation is just nothing else but an anterior cervical fusion, where you don't disrupt any muscles except the anterior attachment of longus coli. Unlike the posterior surgery where you are disrupting the entire posterior tension band, there is a lot of bone stock where you can pass the screw. There is a lot of space to garden the joints and put adequate bone grafts or cages without any fear of injuring the vertebral artery, without destroying the posterior tension band. These are the direction of the screws, if you see, starting under the facet and going upwards and outwards, and in the lateral going towards the posterior aspect of this, and you got adequate hold as good as the Megel screw. And mind you, any screw which crosses the joint is superior to a cantilever construct. When you want to fuse a joint, you have to have the screw across the joint. This is basic principle of orthopedics. So this is the screw trajectory. There are various options like using plates and screws, and you don't require a lot of instruments, just a proper micro drill and a C-arm, and you can see the correct direction of the screw, how it goes across. You don't require too many instruments, just a few set of right angle retractors, a good micro drill, and a set of screws. And that's about it. Nowadays, you see Medtronic comes with big instrument boxes with so many instruments inside for doing posterior sequence or lumbar spine. And they also have one instrument to open the box and one instrument to close the box. You don't require those kind of gadgets. So these are some examples of Atlanto-axial dislocation. See this? And you can see just by passing the screw and putting bone grafts in the joint, you can get the correction. This is another example of Atlanto-axial, long-standing Atlanto-axial dislocation treated by passing anterior transarticular screws. Then I went on to put plates and cages. And you can see you can put large tricorticate. The essence of the operation in C1, C2 is reduction and fixation. Recreation of, you have to create instability to treat deformity. You want to treat deformity, first create instability. Then get bone graft inside the joint. The principle of fusion is there should be bleeding bone across the joint from both the joint surfaces, and then put the bone graft. This is the main operation. The implant is a secondary aspect of the operation. Unfortunately, people focus on the implant and they think that the implant is the operation. The implant just increases the fusion rate and allows early mobilization. But getting bone grafts properly, seeing that there is good gardening of the joints, that is the aim of the operation. So these are some examples. I will not spend time. Long-term results showing fusion across the joints with anterior plate screws. And you can see that this operation is done through a muscle planes like anterior cervical spinal surgery, just disrupting a little bit of the longus colli. Most of the neck joint movements are preserved. You can see that some restriction of rotation because the C1, C2 joint is fixed, but flexion, extension, there is no problem. The posterior tension band is intact. All you need is a set of screws. And this is the long-term result as to show that the joint is fused. This is the end point of the operation. This is how the operation should ultimately look like when you do the CT scan or MRI 6 months to 9 months down the line. And if you're not getting this, then the operation is incomplete and the whole process was futile. Of course, you get complications. Anybody who says that doesn't have complications either lying or has not operated enough. So this you see that sometimes you become overconfident, don't use the C-arm, and you can end up screwing in the wrong direction. This was a patient, again, where I had a suboptimal reduction and the screws were passed. I had to remove this and redo this. Sometimes you get a little weakness of the hypoglossal nerve and the marginal mandibular nerve, but of late this has reduced because initially I used to dissect the hypoglossal nerve. I've stopped looking for it like the recurrent laryngeal nerve in thyroid surgery. If you don't search for the nerve, there will be no deficit. Start a little below at the C2 disc and dissect upwards, you will not get a problem. So these are some implant failures. You can see this. This was osteoporotic bone, and I had an implant failure in this. I was not use locking plates initially. Of course, that has all changed. These are my earlier slides. And then in one patient, I did not drill into the C1 lateral mass properly, passed the screw overconfidently, came out of the operation, and when the patient woke up, she woke up with the torticollis. I had to redo this case, remove the screw, again pass, see that I drilled. Because you remember, that atlas is not cancerous bone, atlas is dense particle bone. And sometimes if you're not drilled well into the atlas, you might just end up with this kind of situation. So there are many complications, you can't hide from them. Of course, there are complications, but nothing as serious as when you do posterior surgery. So again, my results were published at various places. This was the first time in Japanese spinal surgery I published the procedure of fixing the anterior C1, C2 joints with plates. Before that, there is no description in English literature about anterior plate screw fixation of the Atlanto-axial joints. Then subsequently in Journal of Spinal Surgery from India. Now, these are cases, very unusual cases. For example, this case of lateral mass tuberculosis, this kind of patient would have ended up in a posterior occiput C1, C2 fixation. This can be easily done by unilateral fixation using a plate screw as well as a transarticular screw, and you do away with doing an occipito-cervical fixation. So craniovertebral tuberculosis is a very good application. Another, this is odontoid fractures. Most of us know that type 2 odontoid fractures need to be fixed, but there are many odontoid fractures which do not read and do not fit into the classification. For example, fractures which are running through the facet joint, fractures which are displaced, fractures which are impacted. See, this is an example of an impacted fracture. This just, you just don't call it type 2. This requires reduction and fixation. Odontoid screw, I think, is a very, very simple operation only in elderly patients, not for as a universal application for all patients, because the odontoid changes with time. Even in elderly patients, there's a very high failure rate. because the odontoid becomes osteoporotic. So displaced impacted fractures, comminuted fractures, osteoporotic fractures, odontoid fractures with associated C2, C1 fractures, there has to be new thinking. Horizontal odontoid fractures, I will show you some very excellent examples. There are a lot of important technical points in an anterior odontoid screw. Number one, the screw must go beyond the distal cortex. The screw must sink into the proximal cortex. There should be adequate bone in front of the screw. And you put your hand on your heart and you see that most of the odontoid screws are done without following these principles. This is an example, the odontoid screw has to be perpendicular. If it is not perpendicular, it is going to displace the fracture rather than fix the fracture. And fractures don't read textbooks. You don't get fractures which are horizontal. Now look at this example. Somebody has done an odontoid fracture. Neither has it gone beyond the distal cortex, neither the proximal head has been sunk inside, and this is the end result that the screw starts coming out. Like I said, the odontoid fracture, odontoid bone consistency varies with age. So just an odontoid screw, which is the most popular operation, is not an operation which can be done in all cases. In younger patients, odontoid is dense bone, and if odontoid is fractured, 100% it is associated with injury to the ligamentous complex and is a highly unstable injury, and just doing an odontoid screw, I think, is a very wrong concept. So this was a displaced odontoid fracture. This patient would have ended up in a transoral odontoid excision and C1, C2 fixation. So this patient was operated by my technique where we reduce the fracture, pass transarticular screws and get it back in alignment. You can see how the atlas has gone behind, it has reduced and come back to position. This is another patient where the fracture is running into the facet joint. So type 2 fracture running into the facet joint is an unstable fracture. Here I use a VSP plate with screws. The advantage of the VSP plate is that the basic principle of fracture fixation can be followed. That is compression fixation, and you will see the long-term result. Now this is a kind of anteriorly displaced fracture where I impale the fracture with a tab, bring it back in position, then use a plate screw fixation to fix the anterior arch of the distal fragment, the proximal fragment, and all in compression mode. This is the technique, and the long-term result is to show that the odontoid has been, the cortex has been reformed and the bone has fused. That should be the end point of the treatment. And if this is not done, then this operation is useless. This is another example where you see this odontoid fracture, which is almost inclined posteriorly with combination of the C2 bone. And this kind of fracture, when you put an extension, is going to worsen further. So this patient is not going to be, you can't pass the odontoid screw in the perfect position. So you do a VSP plate, and over a period of time, you see that the fracture has healed. Formation of bone across the fracture should be the end point of the treatment. Anything short of that is incomplete. Now this is again a fracture, displaced fracture of the odontoid process, which is unstable situation because there's a fracture plus displacement means the ligament is disrupted. So the patient is fixed to the VSP plate and anterior transarticular screws. This was the construct which was described by me, that you can treat both the fracture and the instability from the front without disrupting the posterior tension band. So this was the construct where you have a VSP plate in the front, do compression fixation of the fracture, and pass bilateral transarticular screws. So it is a treatment which can be applied for any fracture. For example, an anteriorly inclined fracture. This fracture cannot be treated. This is the VSP concept where you pass the screw very close to the edge. As you tighten, it will compress. This is a basic principle of orthopedics. So type 2 anterior slanting fracture would have ended up in posterior C1, C2 fixation. But if you do the anterior VSP plate, you can treat this fracture without doing a C1, C2 fixation. Now, this is a displaced impacted fracture. You put the patient traction, it doesn't reduce, explore the place, pass a tab, reduce the fracture, pass a plate, and then fix this, and then pass anterior transarticular screw. So you treat the fracture and the Atlanto-axial instability all at the same sitting, only by one approach. No need of doing posterior. So this is another example, locked C1, C2 facet. Very, very unusual injury. Very difficult to treat. Traction doesn't reduce them. There's deformity. Open the fracture site. Create instability by cutting the longus colli muscle. Create instability. Once you create instability, impale the distal odontoid, bring it back into position and pass. So to treat deformity, the juniors must understand, you must be ready to create additional instability. So you can see the long-term result. Now, this is another example, unclassified odontoid fracture, vertical odontoid fracture with pars fracture on one side. In extension also, it remains, unreduced. These are the kind of nasty fractures with the pars fracture and a fracture of the odontoid not described in standard classification. So what you do is a new treatment which was described by me, passing a transarticular screw because of the facet fracture, passing a plate screw and treating the disc with the anterior plate. This is the long-term result. You can see flexion, extension, fusion, and the fracture having been remodeled and fused all through a small incision through the muscles without disrupting the posterior tension band. I call it direct compression, reduction, fixation. Again, published in neurological research in 2017, subsequently in neurosurgery, and with no CM, no navigation, no injury of the vertebral artery. Then the next thing that attracted my attention was basilar invagination. There is no consensus of treatment. Natural history is not clear. Best surgical approach remains debatable till Dr. Goel, my friend, has described the posterior Atlanto-axial joint distraction and fixation of the C1, C2 joints. And then subsequently, Sarat Chandra, his facetal realignment is the Rosetta Stone. You realign the facet. That is the treatment of basilar invagination. So there are, the facets can be in various positions. I think type 1, type 2, type 3 can be treated by either posterior distraction or anterior distraction. For the very gross severe one, still transoral odontoid excision remains an option, where many people may not agree with me. So new thinking is distraction compression, which was put forth by Dr. Sarat Chandra. And this type of odontoid fracture still is a candidate for transoral odontoid excision because the joint is vertical. Whatever distraction you put, the joint is going to distract in the same direction. It is not going to distract in it unless and until one remodels the joints like Dr. Praveen Shalke described. But I don't think that is easier said than done. And I don't think that that operation is still easy. It is still evolving. But then the posterior surgery, is bred with a lot of complications, a lot of problems with the vertebral artery, the C2 root, the vertebral venous plexus, etc., etc. The anterior surgery is much simple, does not require anything more than dividing just a few attachments of the longus colli, unlike posterior surgery where the entire tension band has to be disrupted. And the technique is simple. Just go and expose the joints and put cages inside and fix. There's a big bone available of the lateral mass of C1 and the body of C2 to get the distraction. This is like an anterior cervical fixation and no need of injuring the C2 root. These are examples. You see this and you can see this and you can see this. These are the cages which are made for me by Jeon company from Chennai. The special smaller sized cages which are wedge shaped. And then when you put, this is a long-term result where you can see the bone graft, bone fusing. Now the most important part is to fashion the opposing surfaces and cause bleeding from them. You have to take the drill and make holes in the lateral mass and into the superior facet. Only then the bone will grow across the joint. Otherwise, just pushing inside some cage and relying on nature to cause fusion, I think is bad orthopedics. So this is another example. You can see this and see how the odontoid has come down. And this is the cages with bone graft. And another example, this flexion extension, long-term result that it has remained in position. So now there are many lines which describe basilar invagination. The most important one is the grab hook syntax. That is from the C2 to the posterior end of C2 and the clivus. And this distance decides how much is the cervicomedullary strain. So you can see this example, grab hooks realignment, see this and see this post-op. It is reduced to 4.4 mm. It should be less than 9 mm, they say. Now you see this, the distraction and repositioning of the odontoid is important. Getting the cage inside the joint, which is wedge shaped, this is a principle of physics. The wedge shaped cage will push the atlas upwards and backwards. So this is how the cage works. You can't put wedge-shaped cages from behind because there's very little space to push the cages. So you push this wedge-shaped cage from the front. The wedge works as a simple machine. And of course, this got published first in 2016 in again neurological research. Anterior facetal realignment, distraction for Atlanto-axial subluxation with basilar invagination, a technical note. Then subsequently in neurospine, I had published my work in 2019 and the video also is there. And demystifying basilar invagination, anterior retropharyngeal cage distraction, the wedge technique. And this has got published again in JNS video last year in the June 2020 issue. For those who are interested, it is there in British Journal of Neurosurgery. These are example of the wedge cage, how you can put the wedge cage and bring the odontoid down and realign the odontoid. And I've gone, look at this case, the very gross, severe basilar invagination, you distract it, and I've gone up to 9 mm, 9 mm. You can put a big cage and push it back. Now, this is a new concept that is coming up. I've done a few cases, a spacer, which has got one screw which goes into this lateral mass of C1 and one goes into the body of C2. And there's a locking mechanism. But of course, this is still primitive. I have not done many cases of this type. But I will tell you that it is very important to expose from the front because the odontoid gives you opportunity to realign the odontoid process. You can hold the odontoid and bring it back in position. And once it is back in the position, then you can fix the Atlanto-axial joint. So now this is an example of a new solution which is already under publication, review for publication. This is a basilar invagination with an abnormal vertebral artery from behind, and you can see that this facet joint is overhanging. So too many complexities. So I went from the front. Now look at this joint. I think the essence of treatment of basilar invagination and deformity is to get the joint back into position. You can appreciate the joint here, and you can appreciate the joint now. Reducing the joint, getting it back into position, that is the treatment of Atlanto-axial dislocation and basilar invagination. Simple. So this is the new implant which I put, and I use a bicortical screw. And you can see this grab oaks line. You can see the bone graft in the joint. And you can see this repositioning of the atlas over the axis. And this is the new implant. I call it the Pathophysiology plate, which is made out of titanium. And one screw goes into the lateral mass on each side. And there is a screw which goes to the bicortical into the body. These are 4 mm screws, big screws which go into the body of the C2. And this is a long-term 6-month follow-up flexion extension. You can see the reduced Atlanto-axial joint with the Pathophysiology plate. Pre-op, and this is post-op. You can see how it is effective and rigid in holding the atlas over the axis and reducing the Atlanto-axial dislocation. So these videos can be seen by those who are interested. I think this is going to go out of the window. This is not a good operation, disrupting the entire muscle complex, detaching the muscles from the occiput. It is, you detach the biceps and then you say that my flexion has become weak and I put a plate across the joint. This is all, you visualize a wrong physics. So this is an example how you can do it. The problem is anterior, the solution has to be anterior. This kind of operation, disrupting all the muscles, disrupting the attachment to the occipital bone, putting screws in, when the weight transmission is in the front, I think this is not in the principles of proper spinal surgery or orthopedics. So this again, I'll show the videos later if we have time. So this is another new concept which I came out with, that, since carrying the skull on the head, spine is like this, whereas this is a best superior concept where you carry the entire globe on your hand. This was a curse to this Atlas because, he had gone against Zeus, his brother. So this was a patient who had undergone Atlanto-axial transoral surgery, incomplete surgery with the infected posterior wound, and the entire lateral mass and Atlanto-axial joint was infected. The patient was in severe pain, bedridden for almost 6 months, and they had come to me. This is a new operation which I devised, where I transfer the weight of the skull onto the anterior aspect of the spine. Because there's infection behind, I don't use this area. I transfer the weight of the skull onto the anterior aspect of the spine. So instead of this and this, we do this, where the weight is carried on the head. So this is another patient who had come with fibrous dysplasia. There's nothing available for fixation over here. So again, I had to transfer the weight of the skull onto this. You can't transfer, these are very weak, they'll break. So this was the new concept of transmitting the weight of the skull onto the bodies of the C2, C3, 4, the lower vertebra. And there's a long-term follow. Of course, now it is more than 2 years, and there are many other cases which I have done. This pre-op, post-op, 6 months, 12 months, and the bone starts getting remodeled. So this technique is very, very simple. It just does not require too much of manipulation. So this is the case where you expose the cervical spine and you have to understand that lateral to the cervical transverse processes, there is no important structure. So if you go on this side, there's a safe plane lateral to the muscles. So you take these rods and bend them twice, one in this plane and one in this backward plane, and push it back through the muscles and fix them anteriorly onto the vertebral bodies with this new fixator, which has been made by me. And this is again made by Gion for me. So I fix it on the vertebral bodies. And once that is done, there's a locker in the center. You turn the patient, the rods are coming at the back. Then there are special plates which have been made to you find out which is a dense area on the skull on the CT scan. There is no need to make a midline incision. You just make 2 vertical incisions on the sides and fix that onto the dense area of the skull, which is laterally. And you can pass a rod in that, and with the domino connector, connect the rod to this. And then with skull traction, you can reposition it, and in the position that you want, you fix the with the ini nut onto the skull. This is the final construct. And this was the patient who had, a traumatic of this Atlanto-axial dislocation with a pathological fracture and severe cord compression. There was no bone available for fixation. And then this operation was done. And after about 2 weeks, she got up. For 2 weeks, she was bed. For 3 months, she was bedridden. Before, after surgery, 2 weeks, she gets up. She can pass. She's very happy now. So craniovertebral fixation, new technique, again showed in American Association of Neurological Surgeons and then published also in neurological research, craniovertebral fixation, a new technique of craniovertebral fixation. So we have to focus, when we talk about Atlanto-axial dislocation, we have to ask ourselves, where is the fourth nucleus? Where is the line of weight transmission? What is the quality of bone? And whether this technique is safe and simple and anybody and everybody can do it. There is no point in having a very complex operation and everybody cannot do it or is getting dissuaded from doing it. So our focus must be, on making it simpler. This is my friend Atul Goyal, who is the pioneer of craniovertebral surgery. And I think that there are many concepts which I have learned from him. This is another new concept which have come out for the rod, because many times you get this rod slippage. So this is a new rod which has been made by me, which I use in almost all kinds of surgery. So the rod gets locked into these screw systems. So small innovations which are important. Never be happy. Always ask, is there a better way? Is there a better way? It is, if happy people are actually dumb people, you should never be happy. So truth will come sooner out of error than from confusion. Dogmatism, don't be dogmatic that this is the only way to do it, because then you cannot come out with something new. Always everything has got a kind of effect where in the beginning you feel I can do everything. Then you realize that there are a lot of mistakes, and then you come to understand the operation and find a solution. So everything goes to the Dunning-Kruger effect. Don't get disillusioned somewhere you're on the curve. You have to come down and again start rising up and find the mid path. So I always remind people of Joseph Maroon's presidential address, where he says, although the pathological process of spine remain largely unchanged, still we have to come out with newer technologies which will improve the patient's life. Best versus reasonable, Icarus versus Aquina matters. And I always am grateful to my wife and my anesthetist for last 35 years, who has been my anesthetist. Thank you very much, my dear friends. I hope I'm in time. Have I finished?
Yes,
I have time to show some videos. You want to see videos? I can show you. If you're running short of time, I will stop.
Thank you, Patkar sir. Actually, thank you for the completing in the time. If there is any question, audience can ask.
Do you want to see the videos?
I think Dr. Dev Pujay sir is already logged in, and his time was 2:15.
Okay,
So
Okay.
Is Dr. Dev Pujari here?
Yes.
Yes, sir.
Thanks
Dr. Dev
for this opportunity. And Dr. Patkar has given us a wonderful talk on many of his innovative and original approaches to the CV junction. And I have been asked to talk about what is new in endoscopic skull-based surgery. I am going to talk about a few things which can't strictly call new, but something which I think is not regularly described and may be of some interest to the audience. Uh, and some of the things which have changed because of our special circumstances, current circumstances. So when we talk of new techniques in endoscopic surgery, I think we have to be aware of the fact that we are working in a pandemic time where the maximum impact has occurred on endonasal surgeries. One of the first papers which came out of Wuhan and later on came out of Stanford told us that it is one of the most risky operations to do, and probably we should be away from it. And then several departments have done COVID-related modifications in their techniques and uh, how to get over the several problems which we can do. And most places have restarted doing these surgeries. So one of the changes which we have made in our situation is, unlike most other brain tumor surgery cases, for endonasal surgery, we get our patients doubly tested with RT-PCR at an interval of at least 5 days. And apart from the doubly testing the patient and his relative, we also use a PAPR during surgery. I think let's go to what are the various COVID-related modifications we have had to do. So as I said, preoperative assessment of 2 RT-PCRs and chest CT, use of PAPR for the main surgeons. Everybody else also wears double masks, etc. One of the main changes that has occurred in my own technique is less use of drills. I have become, over a period of time, I have become more and more used to drills rather than using punches, and that gives you a better control, I feel. But because of the aerosols, we have come down to using punches once again while exposure. And though this works very well for the routine cellular exposure, for a extended approach, or when you want to expose a carotid, it becomes quite necessary to use the drill. Similarly, we are used less of bipolar since the pandemic, because again, because of the aerosol problems, and we use more of topical hemostats, which we did not use earlier because of the expense involved. But I think that is something which we have to now live with the changing times. The other thing which we have started doing is that we have become more liberal in using pedicle flaps. Most of the times, as I will come to it later, we start using the rescue flap. But whenever we have any kind of doubt, we use a pedicle flap so that we avoid second surgery. We do not want to bring patient again and again to the operation theater. And before discharging the patients, 5 days usually from the day of surgery, we do a flap inspection and cleaning together in operating room before the patient is discharged. The other change or other new thing which has happened in our practice in the last few years is the more use of endoscopic skull-base surgery in children. As you can see, though the endoscopic technique was developed much earlier, and extended endoscopic surgery has been discussed for more than 3 decades now. It is only towards the end of 90s that the use of this technique in skull-base tumors was actually described, and the dedicated papers have all come in the 21st century. One of the most common indications are, of course, the CSF leak repair, developmental anomalies like meningocele and odontoid invagination, neoplasms like pituitary tumors, which are not so common, craniopharyngiomas are fairly common, and chordomas in children, which are ideally suited for this kind of indication. And the challenges are the small nasal apertures, ill-defined turbinates, delayed development of sinuses. The intercarotid distance was a major worry for most people, but I think by the age of 3 years, it becomes quite fixed and remains so in the adulthood. So it is not such a major issue as we were worried about earlier. The size of the airspace in the nasal cavity again depends on the structure of the nose in a particular patient, and the worry about skull-base growth centers is real, but probably not as worrisome as we earlier thought. Especially the sphenoid sinus gets pneumatized initially at the age of about 3 years and completes its pneumatization by about 9 years. So beyond the age of 9 years, it is very, very safe, and it can be as good as doing it than an adult. But in an earlier age, it can be an issue, and you need to be prepared to drill quite a lot, and therefore you cannot perform this surgery without using a proper navigation. I think the anatomical challenges have been very well described in a radiological anatomy paper written by this group, which has told us from Chicago, I think, who have talked about the fact that the piriform aperture is the likely limit only in very young children, mainly below the age of 2 years, and sphenoid pneumatization is usually not a problem above the age of 3 years. And the claval intercarotid distance, again, I think remains fixed, and we just talked about it, it is irrespective of age. Other issues in children, of course, are the blood loss, using proper set of instruments, and how to reconstruct, which is a big challenge. This is a Cushing's disease patient. This patient, when I saw, was about 8 years old. They refused surgery at that particular time. And then 1 year later, the child came in a very deformed kind of a condition. And they agreed about surgery at this stage. You can see a microadenoma situated next to the cavernous sinus on the right side, and this is after removal. And you can see within 6 months there is a remarkable change in this child. So it is a life changing experience in some of these disorders, especially the hormone producing tumors, even they occur in children. On the other hand, non-bromocryptine or non-cabergoline responding prolactinoma is another issue. This is an 8-year-old girl who initially came because of her hormonal issues. And over a period of time, in spite of getting initially controlled with cabergoline, came back to us after about 18 months with visual deterioration with such a large tumor. You can see it is growing virtually in all possible directions. And in such cases, you have no recourse to treatment except for going for endonasal surgery. And you can see that the sella is being drilled here. We have done an extended procedure because of the large amount of tumor which has gone into the third ventricle already. And you will find that the tumor is coming out nicely. You can see the normal pituitary gland at the back and the tumor being gradually separated. And this becomes very, very important when you go into the suprasellar space. We are actually working inside the third ventricle. You can see the wall of the third ventricle from which the tumor is being gradually separated. And towards the end of the procedure, you will find that you need to use a 45-degree scope with all curved instruments to get the front of the tumor out. And when you do that, then you reach almost up to the foramen of Monro, as you will see very clearly when we are removing this. And once you have done that, you can see the whole third ventricle gets isolated, and you have the whole area exposed with a good excision of the tumor. This is more common, as we talked about, in children. This is a recurrent craniopharyngioma patient, the tumor going into one Sylvian fissure. And I'm sure you have seen some nice dissection today to understand what we are trying to show. Again, a slightly extended procedure. It becomes a more of a elliptical incision when you do a opening up of the planum sphenoidale. And here I am trying to go a little bit exposing the carotid artery because the tumor has gone into the Sylvian fissure. And you can see that the tumor is being removed. You can see that the tumor is being separated from the pituitary stalk here. And when we go further, you can see that there is some tumor attached still to the upper part of the stalk from where it is being removed. And at this juncture, we decided that we are trying to look into the Sylvian fissure. And therefore, we go from the opposite nostril, and then we start seeing into the Sylvian fissure here. And you can see that the MCA, the tumor has been completely removed from here, and you can see the whole bottom of the Sylvian fissure nicely, and the stalk has been preserved very well, as you can see on the post-operative scan. So we've done about 74 procedures in 60 patients so far in children, and have had a reasonably good experience to recommend it. When the tumor is too large, going into the third ventricle, has a predominantly cystic component, we try to do a combined approach where we first decompress the cyst from the top and then go endonasally to remove the tumor. And we've written about our initial experience in this paper, which has worked out very well for us. For subarachnoid tumors, the tumors which are inside the dura, usually this approach is not recommended, but these were actually doctor parents, and though we suspected this could be an epidermoid, they originally came with a diagnosis of craniopharyngioma. We decided to go ahead and operate on this patient, and as you will be able to see, a classical cheesy epidermoid is coming out, and it is an ideal approach in that sense that you can decompress the optic apparatus quite well, you can save the pituitary stalk quite well, and it works out to be a very good approach for surgery. So we've done about 12 children below the age of 4 years, 4 of them below the age of 1 year, 5 to 12 years, about 28 patients, and 13 to 18, about 20 patients. This is one of the youngest children which we have operated at the age of 4 months, I think, for an encephalocele, which presented with nasal obstruction. And after decompressing the encephalocele, we have been able to, repair the defect with a nasoseptal flap, and the nasoseptal flap has healed quite well. So these 4 children under the age of 12 months, where the nasoseptal flap has worked, is one of the earliest experience in the world, and we recently published that. In CSF rhinorrhea case, especially this is a recurrent child, sometimes it is very difficult to know where it is coming from, and the use of fluorescein has helped us in identifying these defects and repair it better without being too invasive. So I would say that in pediatric population, using pediatric scope, using micro-ear instruments, judiciously choosing the intracranial pathologies to treat, the fact that we may need to use a combined procedure for craniopharyngiomas and meningoencephalocele, and proper cleaning after the surgery, because you have a very, very high possibility of developing adhesions in these patients. About the flap, I was telling that our approach has changed to now using a rescue flap in almost every patient, unless it is an extended approach where we'll do the flap right in the beginning. And we use collagen now quite liberally for a closure rather than using a fascia. And fat plug is of course used followed by the flap for these kind of patients. Improving radicality of excision, I think we have developed our own ways. This is a pituitary tumor where you will find that we try to do an extracapsular kind of a dissection. We try to find a plane between the normal pituitary and the tumor, and then go along the cavernous wall on both the sides first to clear that, and then you will go right up to the top. So the ideal thing is first you clear up from 6 to 9, then you clear up from 6 to 3 depending on where your normal pituitary gland lies, and then you go in the area between 10 o'clock to 1 o'clock at the top, so that you don't have the diaphragm falling on you. If at all the diaphragm falls on you, then you have a possibility that you may be able to use either a cotton pledget or use sometimes even the cotton swab. You insonate the carotid artery and then make sure that you will take the tumor away from the cavernous sinus wall. And in this manner, you can achieve a radical excision, more important in functioning tumors, but probably important even in non-functioning tumors if you want to get a radical excision. Of course, you need to use a Doppler, you need to use curved suction, you need to use some kind of a navigation for this. We usually use either a Stryker mask or we use the electromagnetic navigation of Medtronic, which are equally good for this kind of approach. Sometimes the tumor is very sticky, very, very adherent to the diaphragm, and it is difficult to remove such a tumor. And in which case, if the tumor is sticky and it is not allowing you to get the tumor out completely, what we try to do, I'll just go back to this for one moment to show you just a technical kind of a thing. You are trying to use a cotton swab to, keep the arachnoid intact because the diaphragm has become thinned out, and then try to remove this, and you are able to remove such a tumor most of the times without damaging the coming down of arachnoid. We all know that most of the morbidity in pituitary surgery is because of the CSF leak, and therefore if you can avoid it, nothing like it. When the tumor goes in cavernous sinus, sometimes it is possible. It is dictated mainly not only by the presence of the tumor in the compartment of the cavernous sinus, but the displacement of the carotid. And in such cases, you try to go as laterally as possible. And more importantly, the consistency of the tumor is equally important. So here the flap has been taken, you can see that this is we are removing the not only the mucosa but also the bone over the carotid so that you can get into the cavernous sinus, and you will find that the tumor has first side, and then we are trying to see if we can get into the cavernous sinus. Now, when you are trying to see that if you can get into the cavernous sinus, you will find that you need to change the angulation of the endoscope. You may have to come through the opposite nostril. And while doing this, you will realize that you are actually working almost on the lateral aspect of the carotid here. In this patient, you can see the carotid here, the tumor on the lateral aspect of the carotid and the medial aspect of the carotid, and a radical excision again can be achieved. You can go specifically, this is a residual tumor after a previous surgery for a Cushing, where the whole tumor was in the cavernous sinus, and we opened this separately and we managed to remove this tumor completely from the cavernous sinus. Use of coronal plane, yes, you can go lateral to the carotid. This is a V2 schwannoma. Ideal procedure to do it, you take the back wall of the maxilla before you do that, and you can see the tumor bulge almost there. And once you have seen that, you can gradually dissect it out from the orbital periorbital fascia, and this tumor could be completely removed in this particular fashion. This is another patient. This is after the surgery for that schwannoma. You can actually go into the Meckel's cave. This is a patient who has had a radical surgery for trigeminal schwannoma, and then it has recurred mainly in the pterygoid fossa. You can see, and we thought that it is the best removed by using this approach. So you go lateral to the carotid over here, and you can actually expose this area quite well, and you can start seeing the tumor. Once you have removed the tumor, the main challenge is how to repair this. Again, if you have made a generous flap, you can probably go and remove this tumor almost completely, and you can do this surgery without going intracranial at all. Combined approach, I think we have done a few cases with our oncology colleagues. This is a patient with a bony tumor, which was involving the cavernous sinus, which was involving the orbit. And here we have done a endonasal approach as well as a frontal approach at the same time. And you can see that the we did not have to mobilize carotid so much because we could work medially as well as laterally to this. Of course, navigation is indispensable. And you can see here that you are able to clear the tissue from this approach quite well. And once you have done that, then you can push the tumor from above, and you can almost simultaneously do that so that you can see your instruments and you can form a proper plane and push the tumor down into the nasal cavity for a radical excision. In such cases, again, the repair becomes important, and therefore a combined repair, you get a gallio-pericranial flap from above and you get a nasoseptal flap from below, gives you a very, very good cover. This is the post-operative patient, and it is more than 4.5 years now that the patient has had no further recurrence. So thank you for this opportunity. I just tried to tell you certain unusual indication and extended applications in last few minutes, and I hope that is useful. Thank you. I'm happy to answer any questions.
Thank you so much, sir. Is there any question from the audience? If there is no question, we shift to the next speaker, Dr. Abhida Shah.
Thank you once again.
Dr. Abhida Shah.
Yes.
Yeah. Dr. Abhida Shah, she is a distinguished teacher in the KEM hospital. She is doing excellent work in this neuroanatomy with the white fiber, and she will be talking about a paper in the white fiber tract anatomy.
Okay, we have an audio problem here. We need someone needs to turn off the one on. Maybe you have two mics on, Abby.
No, I have only one on.
You may have two. Turn everything off besides what you're on.
Should I stop share and start again?
Yeah, there we go.
Okay,
there we go.
Okay. Good afternoon, everybody. Thank you, Ike, for this opportunity and this invitation. I'm sorry I could not be there, but let me start presenting from here. So for now, every neurosurgeon who wants to do intra-axial brain surgery, it is becoming a prerequisite to understand the white fiber anatomy of the brain. So these are the major white fibers of the brain, and these are the deficits that can occur due to damage to these white fiber bundles. They have been ignored for quite some time when we are concentrating on eloquent cortical anatomy. But now, as more and more monitoring is being performed, we realize the value and importance of these tracts and the deficits that occur due to their damage. So recently we published this paper in 2018 on the architecture and function of the white fibers of the brain, and a fiber dissection study which was performed in KEM hospital by me and my colleagues. So based on this, to simplify the understanding of white fibers, we classified the white fibers of the brain into 5 groups. 4 were horizontal and 1 was vertical. The 4 horizontal groups are, the yellow circle here is the short association fibers or the superficial group. The next group in the horizontal fibers is the middle group, this blue circle here. These are the long association fibers. So this is the cingulum here, and the superior longitudinal fasciculus, the medial half of it, that comes in this category. Also, you have the IFOF, the uncinate, and the arcuate, which also fall into this category. Then you have the deep group of association fibers that are in relation to the ventricle. And here you have the fornix and other stria terminalis, stria medullaris, thalami that are present in relation to the ventricle and are all C-shaped. The 4th horizontal group is that of the commissural fibers, and it consists of the habenular, corpus callosum, posterior commissure, and the anterior commissure. And the last group is this orange circle, or the vertical group of projection fibers, that is the internal and external capsule dorsal part continuing as the corona radiata. So what is the significance of this classification? If you understand this blue structure here are the projection fibers. These projection fibers separate the middle group of long association fibers into a medial half and a lateral half. So the fibers like the cingulum and the medial part of the SLF, which are medial to these projection fibers, do not cross over to this side. And lateral to the projection fibers, there is the uncinate fasciculus, the IFOF, the inferior longitudinal fasciculus, the parts of the sagittal stratum, and the arcuate fasciculus. So they're distinctly separated by these projection fibers. The second important thing is the projection fibers keep the commissural fibers between them when you include both the hemispheres. So if you see these red fibers here, these are the fibers of the corpus callosum, and they are limited laterally by these projection fibers. The only commissural fiber that crosses this just below the internal capsule is the anterior commissure, which I will show you in later dissections. So to understand this anatomy, I'm going to show you the fibers of the brain from all its aspects, from the lateral, inferior, and the medial aspects. So we start with the lateral aspect of the brain, and we are all familiar with this image. So when you have to start dissecting, you remove all this pia and the vasculature over the surface of the brain. And this is what you see before you start preparing the specimen for dissection. So this is the magnificent image of the brain, which is divided into frontal, central, parietal, temporal, and occipital lobes, with the hidden lobe of the insula lying within the operculum in the Sylvian fissure. And the last lobe is the limbic lobe, which I will show you. So to start dissecting from laterally, you first remove all the gray matter that is present in between all these sulci. You dissect a thin layer of gray matter here. You identify the white fibers in this region and you dissect around it, and you will get this structure. These are the superficial system or the short arcuate fibers. You see there is a thin layer of gray matter that has been preserved on the surface of the gyrus, and all the other gray matter within the depth of the sulci has been removed, and this is the whole short arcuate fibers. So if you see this beautiful image, you see innumerable connections of the short arcuate fibers or the U fibers between the various gyri of the brain. So to take a closer look, here I'm just showing you some connections that are present between the middle frontal gyrus and the precentral gyrus. Then there is a connection in the depth between the pre and the postcentral gyri in this region. This is known as the please the passage of Broca. This is the connection of the middle frontal gyrus to the precentral gyrus in the depth. Again, there are multiple connections in this region which are important during surgery. Once you remove this short arcuate fibers, this is what you will see on the lateral aspect of the hemisphere. So this you see is the corona radiata, which is the continuation of the projection fibers. In the center, lateral to it, you have the lateral part of the SLF. So traditionally, this has been known as the SLF1 on the medial side and SLF2 and 3. But I like to call it the lateral part of the SLF as it is lateral to the projection fibers. So these are fibers that run from the frontal to the parietal region to basically the supramarginal and angular gyri. And if you see carefully, maybe you can distinguish two parts here, SLF2 and 3, but it is usually difficult to trace them separately. The next fiber bundle here, just beneath the SLF, is the arcuate fasciculus that runs from frontal, parietal to temporal. This connection here is a short fiber connection between the Broca's area in the inferior frontal gyrus to the arcuate fasciculus. So more of the brain has been dissected. Now you can see the lateral part of the SLF more clearly, and this is the arcuate fasciculus. I have colored them in this image so you can identify this blue thing is the lateral part of the superior longitudinal fasciculus, and this orange structure is the arcuate fasciculus. After all the gray matter has been removed, this is what remains of all the fibers that you see from the lateral aspect of the hemisphere, the SLF, the arcuate. Here you have another fiber bundle that is the vertical occipital fasciculus. And in the depth here, you will also have the frontal Ashland tract. When you look at it from the medial aspect, just to complete the middle group of fibers, so this is the corpus callosum, then you have this fiber bundle here that is the cingulum. The cingulum has distinct connections with the precuneus in this region that you can see here, and another frontal connection majorly to the superior frontal gyrus. Just above the cingulum runs fibers of the medial part of the SLF, traditionally known as SLF1, but I call it the medial part of the SLF. So this is the group of fibers that you see from the lateral aspect or the middle group of fibers. And how is this relevant during surgery? So if you see this is a tumor in the supplementary motor area. This is your precentral gyrus. This is the posterior part of the superior frontal gyrus, classically at the supplementary motor area. You can see it in this MRI clearly. This is the central sulcus. This is the precentral gyrus. This is the tumor. You can see that the corticospinal tract has been displaced posteriorly, and all the other fibers, the projection fibers, will be displaced medially and posteriorly. And once you understand this anatomy, you can go in and do a good radical resection of this tumor, and you can see this flare image. All of the tumor is out. The monitoring shows that the motor evect potentials are normal. And this is the en masse resection of the glioma that we are now currently performing. And we've recently published a paper. This is Professor Goyal's new philosophy on resection of gliomas. This is another tumor in the pars triangularis and the pars opercularis. So if you see this functional MRI, the speech area has been pushed posteriorly a little bit, and these are the functional areas of the motor cortex. These are the anatomical correlation with these fibers. So if you see this location, this is a tractography image that I've constructed, and the fibers are displaced medially. So you have the arcuate fasciculus running posteriorly and medially to the tumor. And if you enter in this area, it will be safe to perform a good resection. Now we've seen the fibers from the lateral aspect. Let's go a little deeper into the region of the insula. So this is the frontal, parietal, and temporal opercula. The insula forms an external shield for the central core of the brain. So this is the region of the central core where you have the basal ganglia, the thalamus, the internal capsule in this region. The insula forms an external shield for this region. The anterior part of the insula is related to the caudate. The posterior part leads to the atrium. And these are just an image showing some important relations. So once you open the opercula, which are the curtains, you start seeing the gyri of the insula. These are separated into a short gyri and long gyri by the central sulcus of the insula, which is in this continuity with the central sulcus of the cerebral hemisphere. You can see the direction completely and clearly it's in the same line. The gyri in the anterior part of this central sulcus are the transverse gyri and the accessory insular gyri, and you have the anterior, middle, and posterior short insular gyri, and this is the anterior and posterior long insular gyri. I'm not going to go into details of this. So this is an image where the opercula have been removed, and you can see the gyri, which are surrounded by the superior, inferior, and anterior limiting sulci. The whole thing is called the circular sulcus of the insula. So you remove the gray matter, and this is the first structure you will see. You start seeing the extreme capsule. Between the extreme capsule, you see these fibers. These white fibers come up from the extreme capsule, connecting the gyri and the insula to the cortex and form part of the claustrocortical fiber system. Once you remove this extreme capsule, you see a very thin layer of gray matter here in this region, and that is the claustrum. Once you further lift away the claustrum, you'll start seeing the external capsule. So these are fibers of the external capsule. This is a bit of the putamen has been dissected, and beneath that you have fibers of the internal capsule. So this is the classical spoke and wheel appearance that you see here. These are fibers of the external capsule. This is the putamen, and in the depth is the internal capsule. Now the external capsule has actually got two parts. So the ventral part is formed of association fibers, whereas the dorsal part are formed of projection fibers, which connect the insula to the corona radiata. So basically behind the arcuate, fibers of the external go up and meet the internal capsule to form the corona radiata. This is the dorsal part. So the ventral part consists of the IFOF and the uncinate fasciculus, which are association fibers connecting the frontal, temporal, and occipital brain. Now more dissection in this region, you can see the IFOF more clearly. The uncinate has been cut here. And this is another image that shows the IFOF originating from this area, going behind and forming part of this sagittal stratum. This structure here is the uncinate fasciculus. Now the globus pallidus and the putamen in this region have been removed, and you start seeing the internal capsule. The arcuate fasciculus has been cut here in this region, and this is the sagittal stratum. So now the whole of the gray matter in this region has been removed, and the entire extent of the internal capsule is reached. So you have the anterior limb, the genu, posterior limb, the sublenticular part, and the retrolenticular part, which is the Mayer's loop of the internal capsule. So this is your limit. When you dissect from laterally, this is your end point. Beyond this, you will traverse the internal capsule. So based on these dissection studies, we also identified, if you see this loop here, this is the Mayer's loop, which actually curves from inferiorly, forms the roof and lateral part of the temporal horn. And this is the region of the hippocampus. So there is an area here in the anterior part of the temporal horn, which is devoid of any fibers of the Mayer's loop and safe to enter. So this is just a tractographic image showing the various fiber bundles. This is the arcuate, the yellow is the IFOF. So some tumors in this region quickly. This is a region in the tumor in the perisylvian region, morely in the superior temporal gyrus on the left side. If you understand the tractography, if you understand the anatomy of the fibers, you can go in and perform a safe radical resection without causing any problems. This is a tumor in the insular region going towards the uncinate fasciculus. And you can see again a good radical resection we have removed with the understanding of our anatomy. This is a small technical note that I had published in Asian Journal. When I was earlier performing insular glioma surgery, I had some difficulty in identifying some vessels, and I used ICG to determine whether they were end passage vessels or they were going to the tumor. So I'm not going to show this video, just I'll show you that I identified this vessel as going across and going to the motor cortex and then preserved it while removing the tumor. This is again another tumor in the region of the insula. You can see these fibers, you can understand the displacement. You understand that the tumor involves a named fiber tract and displaces the adjoining fiber tracts. And with this philosophy, you can go in and remove the tumor. So these are the fibers that are displaced. The important ones are pushed, and you go in, find a safe entry point and perform a good resection. We've seen the lateral aspect completely, and now we are going to the inferior aspect of the brain. I will not go into the cortical anatomy. So this is the region of the uncus and the parahippocampus. You remove the gray matter in this region and you start seeing this fiber bundle here. This is the end of the cingulum. This is the radiation of the cingulum as it turns and comes and ends in the parahippocampal region. Once you remove this radiation of the cingulum, you start seeing the ependyma of the temporal horn. You remove the ependyma and you will see the hippocampus in all its glory. This gray matter in the anterior aspect of the temporal horn is the amygdala. This is the choroid plexus. Then I have deflected the hippocampus and the choroid plexus down, and you start seeing the beginning of the Mayer's loop. This is the lateral geniculate body, and you can see fibers that are originating in this region, going and turning into the roof and temporal part of the lateral part of the temporal horn. So this is the Mayer's loop in another view, where the specimen is turned laterally. And this is the image that you've seen earlier, where it forms the roof and lateral part of the temporal horn. So if you see this image, this is the IFOF. These are the sagittal stratum. Now I have tilted this image. You see the relation of the hippocampus to the sagittal stratum. So if you see IFOF is turning here, the Mayer's loop is turning here, the anterior commissure is behind. So this area is safe and devoid of any fibers. So you can make a safe entry into this region. So Professor Goel described this approach for performing medial temporal lobe epilepsy surgery. And we use the approach to the middle temporal gyrus at this point, which is devoid of any fibers, enter the anterior part of the temporal horn anteriorly, and then go ahead and resect the whole amygdala, hippocampus, make a disconnection here and remove this portion of the neocortex completely. So again, to just show you that we enter from this region through the middle temporal gyrus, which is devoid of any visual fibers. Again, the same approach we are using for tumors in the middle temporal region, in the parahippocampal region. You see this lesion in this region, and I have operated this patient and removed the tumor radically. Again, another huge tumor in the region of the parahippocampal gyrus. Again, the entry is through the between the middle and inferior temporal gyrus, more towards the middle temporal gyrus. You can see all the fibers are displaced superiorly if you understand this anatomy and perform a radical resection. Now going to the frontal part of the brain, this is the H-shaped cruciform sulcus of Rolando, dividing this into the medial, anterior, posterior, and lateral orbital gyri. So we devised an approach through this region for lesions that are located deep in the region of the ventricle, that is the caudate head. This was our earlier paper, and recently we have published this paper where we have devised true trajectories to reach the lesions lateral to the frontal horn or to the caudate head. One is to the medial orbital gyrus and one is to the lateral orbital gyrus. And you can see the direction of the trajectories that takes you directly to the caudate head. To understand how it is safe for fibers in this region, this is a basal view of the brain from the inferior aspect. This is the anterior commissure. These are some fibers of the uncinate fasciculus as they're going to the temporal lobe. And this is an upturned specimen. This is the frontal brain, temporal brain. This is the region of the frontal horn. This will be the region of the caudate. And if you enter from here, you are avoiding most of the fibers, or if you enter from here, maybe just a little bit of forceps minor may come in the way, but both of them are safe trajectories to approach lesions in the caudate head. And they are the shortest trajectory instead of an interhemispheric approach to reach this region. See, if you see this tumor, if you have to reach here from top, the trajectory is very long. And this is a safe trajectory, a short trajectory to reach this lesion. As you can see in this image, a lateral orbital trajectory with a complete resection of the tumor. Lastly, the limbic system. So this is the cingulate gyrus, and it continues as the parahippocampal gyrus. So parahippocampal gyrus continuing here as the cingulate, continuing posteriorly as the lingual, and it forms the cortical ring of the limbic lobe. Once you start removing the gray matter in this region, you start seeing the mammillary body and the mammillothalamic tract as it goes in the anterior nucleus of the thalamus. This is an image showing the fibers that have been removed on the lateral on the medial aspect of the hemisphere. So again, this is the cingulum. This is its parietal connection. This is its frontal connection. And these are on top will be the medial part of the SLF. Once you dissect more in this region, I've cut the corpus callosum here. This is the caudate head. So to dissect for the limbic system, we have to remove this caudate head to identify the anterior thalamic radiations, which continue to join the cingulum. So this is the whole Pappage circuit that has been dissected, which begins here in the region of the hippocampus, goes on to become the fimbria, the fornix, columns of the fornix, mammillary body, mammillothalamic tract, anterior nucleus of thalamus, anterior thalamic radiation, cingulum, and back again in the parahippocampal region as the radiation of the cingulum to end here and completing the circuit. So this is the whole Pappage circuit that has been dissected out here by me and my colleague Subdeep, who is also there in this webinar. And this is another component of the limbic system, that is the olfactory tract and the medial and lateral olfactory striae. So this was our paper way back in 2012. And this anatomy is important to understand resection of parahippocampal tumors, of limbic system tumors. So this is a tumor in the region of the parahippocampal gyrus, and a resection has been performed using the same trajectory that I described earlier and with a good, safe radical resection. So if you see this tumor, you realize that it is affecting the cingulum. It is unilateral. It is going in the direction of the precuneus, as the connection of the cingulum goes in the direction of the precuneus. You understand this? Come interhemispheric. You see that the projection fibers are displaced laterally, the other fibers are displaced inferiorly, and you can go ahead and perform a beautiful resection. Lastly, the fibers of the corpus callosum or the commissural fibers. So basically, if you understand the commissural fibers, this is a recent paper that we have written. The corpus callosum is made up of dorsal, ventral, anterior, and posterior radiations. So these fibers that go up, that traverse up and join the middle aspect of the corona radiata to form the centrum semiovale, I call the dorsal radiation. This part that goes anteriorly is the forceps minor or the anterior radiations. The ventral radiations are these fibers that cover the roof and lateral aspect of the temporal horn and that is the tapetum posteriorly, and these fibers that you see here going in the region of the basal ganglia and the caudate head. And the posterior radiations are the forceps major, as you can see here, connecting both the occipital cortices to each other. So these are the colored coded for the various fibers of the corpus callosum, the dorsal, the ventral. This is how they are related to the IFOF. So basically the corpus callosum connects your entire hemisphere with minute connections, and we have recently just dissected this and we have sent for publication. So if you understand the anatomy of the corpus callosum, it becomes easier to operate on corpus callosal gliomas. So it's a tumor of the splenium. It appears bizarre, but once you understand the fibers, that the projection fibers are laterally displaced, the other corpus callosum fibers are displaced anteriorly, you can go in safely to an interhemispheric approach and perform a good radical resection, as you can see here. Last one is the anterior commissure. So the anterior commissure begins in the midline and connects both the temporal and frontal regions. This is the frontal connection. This is the temporal connection of the anterior commissure. It resembles a bicycle handlebar, as you can see in this image here. So basically the anterior commissure runs posterior to the IFOF and anterior to the Mayer's loop, as it runs in the lateral part of the temporal horn, and it runs and it hugs the temporal horn. So if you see this anterior commissure on one side, it is coming here, it gives out a frontal connection here. This is the substantia innominata, and it continues here in the lateral aspect of the temporal horn, and it is kind of embracing the entire temporal horn on both the sides. That is the appearance of the anterior commissure, as I like to call it. You can see this anterior commissure joining fibers of the IFOF and the Mayer's loop as it forms part of the sagittal stratum. So finally, just to conclude, so this is your medial aspect of the hemisphere, and this is the classification dividing into 5 layers that I discussed earlier. From the lateral aspect, superimposed on the lateral aspect of the hemisphere, again, you have this yellow circle is the middle group, the red one is the superficial group, the blue one is the projection fibers of the vertical group. And when you see from superiorly, you see that the projection fibers lie here, and the middle group of fibers that are lateral remain lateral, and that are medial remain medial to this projection fiber system. Thank you very much.
Okay. Thank you, Abby. Hello? Thank you, Abby. Okay, we're open for questions or comments. Does anybody have any questions or comments for Abby?
Thank you, ma'am. That was a very excellent presentation. Is
Okay,
there
go
any
ahead.
question? There is no question, then we will shift to the next speaker. Next speaker is Dr. Sumit Sinha. He has extensive, almost 17 years of experience in neurosurgery. He is practicing endoscopic and minimally invasive skull-based surgery. He will talking about the keyhole surgery in the petroclaval meningiomas.
Well, hello everyone out there, and at the outset, before I speak, I wish to thank Professor Ike for this wonderful meeting that he keeps on organizing and gives us a chance to meet virtually, at least in this endemic era. And I congratulate him again for this wonderful thing that he does every now and then. I would be speaking for the next few minutes on this beautiful approach for these formidable tumors, I would call them as, known as petroclaval meningiomas, and as to how to perform these type of complicated surgeries with this beautiful approach that is called as a keyhole surgery. So we all know that petroclaval meningiomas, they arise from upper 2/3 of the clivus and located at the petroclaval junction, medial to the 5th nerve by definition. And this is what petroclaval meningiomas is. And in the literature, we have seen that they carry not very good gross total resection rates and have cranial nerve deficits with surgical approaches, various skull-based surgical approaches. So in order to quickly wrap up about the traditional skull-based approaches for these tumors, the tumors which involve the upper third of the clivus, they can be done by orbitozygomatic or Cavernous approach. The middle third can be done by transpetrosal approaches. And the lower third of the tumors which reach the lower third of the clivus as well, they can be treated with far lateral or combined approaches. So this was one very good paper about the conventional skull-based approaches, which I got from literature published from the Chinese group, and they classified this into various type of tumors: clival, petroclival, petroclevo-sphenoidal, sphenopetroclival, and then they devised an algorithm for the tentative most suited approach for every particular type of a tumor, ranging from basic retrosigmoid approach, retrosigmoid transtentorial approach, retrosigmoid intradural suprameatal approach, subtemporal transtentorial approach, and combined petrosal approaches. Well, all the difference was that this variation in the approach, the aggressiveness of the approach increases with the increasing extent of the direction of the spread of the tumor in the middle fossa vis-a-vis the posterior cranial fossa. So, howsoever, with the keyhole approaches, it is very simple to remember. If the tumor is predominantly in the posterior fossa, it can be dealt with by a basic retrosigmoid approach, or a retrosigmoid transtentorial, or retrosigmoid intradural suprameatal approach. Howsoever, for these combined approaches, the keyhole approach, the answer for the keyhole approach is the staged subtemporal approach, followed by a basic retrosigmoid approach in a staged operation. So let's see as to how it goes. So for conventional skull-based approaches, they can be replaced by keyhole approaches to the post-petroclival meningiomas, which can be subtemporal transtentorial approach, or a retrosigmoid transtentorial or retrosigmoid intradural suprameatal approach. I would like to show 2 quick videos in subsequent part of my presentation if time allows. So now, what is the rationale for keyhole approaches? Why so much of fuss about it? Because we all know small incision, lesser approach related morbidity, it is less time consuming access. You can save your energy over the tumor better rather than into consuming your energy into making the access to the tumor. It's got better cosmesis, no doubt about it, causes less temporal muscle atrophy, and of course the wound healing is better with these approaches. Let's see, come across with some examples. This was one petroclival tumor. I apologize for the poor quality of the images. Now, this was done by keyhole subtemporal approach, and you see this is an immediate post-operative MRI showing complete tumor resection. Another one of the petroclival meningiomas, which was predominantly in the posterior fossa, was also going in the middle fossa, done by a keyhole subtemporal approach. You can see this is the evening post-operative CT scan of the same patient showing almost complete tumor resection. Another one with predominant middle fossa involvement, and some of it also going into the posterior fossa, of course done by a subtemporal keyhole approach, and this was the size of the incision. And of course, not to mention, navigation is an absolutely mandatory technological advancement that has to be with the keyhole approaches. And you can see this is the immediate post-operative CT scan of the same patient with complete tumor resection. Another one, again done by a keyhole subtemporal approach. Now this is the traditional keyhole incision, the straight linear incision, and the circle round that we show you is the tentative craniotomy, the size of which is around some 4 to 4.5 centimeters. And this is the post-operative scan of the same patient. Now, to run the subtemporal approach, I would like to show you a small video, and I would like to fast forward it in interest of time. And as to what is this is the skin incision, and I already mentioned it. And this is the patient position is turned laterally with the affected side up, of course. And this is the traditional lateral decubitus position, as you can see that. And this was the tumor. You can see the angle of the approach of this tumor, and the incision which lies just above the zygomatic line and immediately in front of the meatal line. And this is the size of the incision, skin incision, and muscle being cut, and some of the muscular work is being done. The bone is being exposed from posterior end of the posterior root of zygoma to the anterior end of the posterior root of zygoma. So this is very important and especially you require a navigation guidance also. Now, why is this important? Because the anterior tip of the petrous apex or the Kawase triangle, it lies on the lie of between these two landmarks. So this is a very important point. And then the craniotomy is being done, and this is the size of the craniotomy. This is the imaging, the angle of the approach, and you see that some amount of bony work, and then the subsequent dissection is just like, you know, as you do in a normal conventional any skull base anterior Kawase's approach. So stripping of the dura, identifying the V1, V2, and V3s, middle meningeal artery, coagulating it, and doing the stripping job to identify the lesser and greater superficial petrosal nerves, and saving the facial nerve and identifying the Kawase rhomboid, so that it is then drilled, and you make the bone space and then open the dura, and then there comes the tumor directly, so that you work on the tumor, start working on the tumor, decompress. No place at any point in the surgery is you feel like you are being compromised in the working space. And the key is to open the dura and to drain the CSF gently. And as any other meningioma, it is important to preserve the arachnoid planes, as in this keyhole surgery. So you see the fourth nerve, the arachnoid, gently respected and taken away from the tumor tissue. The posterior cerebral artery and the superior cerebellar artery, you will shortly see the tumor is being dissected away from that, decompressing the tumor, making the tumor more manageable, more handling, more manipulative, and then making it small, dissecting it from other important neurovascular structures, and of course the brain stem. So this is how the dissection goes on, and you have to be very, very patient in this region, because this is very unforgiving region, and a small damage to the perforator, we all know, can lead to disastrous consequences. Patient not waking up, patient waking up hemiplegic after your surgery, which will ruin your wonderful operative exercise. So dissecting the PCA here, this has to be a sharp dissection. All these steps are more or less similar to, except that only the craniotomy is small. You don't require conventional skull base, extended Kawase, modified Kawase, only a keyhole craniotomy that is appropriately and accurately placed with the help of navigation guidance is the must. And there you see the basilar artery there, separating and lifting the tumor slowly and slowly from the basilar artery there with all concentration, and then decompressing the tumor tissue. This is the attachment of the tumor tissue to the petroclavial ridge, and there you see slowly and slowly the tumor is being lifted up. The other side of the brainstem there you see, and this is the basilar artery here. And the tumor separated from the fifth nerve, retrogazerian fifth, and taking out the rest of the, sucking out with the CUSA, and cutting the arachnoid sharply, respecting the arachnoid. And there you see it has been completely dissected from the basilar artery and the basilar perforators. So this is the tumor being lifted from the brainstem surface, and is being taken out slowly and slowly, piecemeal fashion, taking care of the small perforators that might cling on to the tumor capsule. You need to sharp dissect them. And then lastly, retrogazerian fifth dissection of the tumor from this fifth nerve. So this is the last chunk of the tumor tissue, which is slowly taken out, stimulating the retrogazerian fifth so as to know the integrity and functionality of this nerve. Neuromonitoring is absolutely essential, and here comes the final bits of tumor tissue which are still remaining adhered to the fifth nerve, and looking for any residual pieces of tumor tissue. And then at the end, stimulating and taking the endoscope inside is of great help at this moment, because it shows you the residual tumor anywhere, and shows you the important structures and the cranial nerves. This is the post-operative scan done on the same night, showing tumor excision completely, and this patient went home safely without any neurological deficits. So another approach in the keyhole craniotomy is you can do that with a retrosigmoid approach, especially this tumor, which is solely in the posterior fossa. It is a retrosigmoid approach is better suited for this. More so ever, you can see that about 1/3 of the tumor tissue is behind the internal meatal line. So this is not a good tumor to attempt through a subtemporal approach. So better is to go from back, and this is the immediate post-operative video of the same patient, and showing no neurological deficits. Of course, cranial palsy we will be able to see once the patient is extubated. Another day, normally we keep them electively ventilated most of the times overnight, and then extubate the next day. And this patient had mild fifth nerve, which gradually improved over time. Another posterior fossa petroclival meningioma attempted through retrosigmoid transtentorial approach. This is the immediate post-op CT and the MRI showing complete tumor excision. And this is an endoscopic view. You can see that this is the sixth nerve. This is the tentorium over here. This is the peaking occipital lobe. And this is the fifth nerve. And this is the brainstem. So complete tumor excision from the petroclival ridge has been attempted through this wonderful retrosigmoid approach, which is the workhorse approach for the neurosurgeons. And you see subsequent stages, cutting the tent in the first image, and then this is the 7th complex. This is the superior cerebellar artery over the tumor, dissected sharply and removal. And this is in the end after the complete tumor resection. So this was this approach. Another tumor which was predominantly in the posterior fossa, but a small portion going into the Meckel's cave also. Patient had fifth nerve symptoms before the surgery, attempted through retrosigmoid suprameatal transtentorial approach. So you see, this is the size of the craniotomy, the post-operative CT scan of the same patient, and at the end or during the middle of the surgery also, I often take in my endoscope inside in order to be sure as to about the excision of the tumor attachment, the dural coagulation of the tumor tissue done. And this is the Meckel's cave over here. The entire tumor tissue has been burnt about and completely removed from at the end. And this is the 7th complex. These are the lower cranial nerves over there. Here depth is the 6th nerve, and here is the 5th cranial nerve. So it's a beautiful endoscopic view after the complete excision of the tumor tissue. And this is the patient immediately at the end on the evening after the surgery. And you see no third nerve, no sixth nerve, and patient is being just now extubated. And I don't know whether I have time to share this video of retrosigmoid approach. Well, I would choose to not to, because in the favor of time. The third strategy of removing of these tumors is the combined staged retrosigmoid and subtemporal transtentorial approaches. So this was one such tumor which you can use your combined keyhole subtemporal followed by next day or maybe next after discharge retrosigmoid approaches. So these are huge tumors which are impossible to treat by any single keyhole approach. And you see this patient operated once subtemporally, and then later on, after this subtemporal resection, there was some amount of significant amount of posterior fossa remnant, which was taken out through the posterior fossa retrosigmoid keyhole approach later on. And this is the final CT after the after this surgery. Another such tumor which was for combined approach through the middle fossa and the posterior fossa. And this is this patient I operated recently and is due for the rest of the tumor tissue removal next month. So this is the immediate post-operative video of the patient showing intact ocular movements and no neurological deficits. So the take-home message for petroclival keyhole surgery is that petroclivals are formidable tumors, have to be respected a lot, and they carry highest rate of morbidity even with various technological advancements, and it's a mortality as well at times. And you burn your fingers if you're not very cautious about dealing with these tumors. Massive skull-based approaches, they are absolutely no longer required to treat these lesions. Well, you have to respect these lesions, and keyhole approaches offer a rational and less morbid, a better option in such tumors. And all the more reason because subtemporal Kawase and retrosigmoid are workhorse approaches for most of the neurosurgeons. And in a keyhole approach, they can offer a complete resection with minimal morbidity. Thank you so much.
Hello. Thank you so much, sir.
Yeah, thank you, Subdeep.
The next lecture is from the Dr. Sukhdeep Jawar. Dr.
Yeah.
Sukhdeep Jawar is practicing in Punjab, and his work in the 3D model and in news anatomy are very fascinating. You will enjoy this lecture. I invite Dr. Sukhdeep Jawar to demonstrate his skills.
Thank you, Nilesh, for this introduction. And at the first, I'd like to thank the organizing committee and especially IPE Cherian for putting up this great show for youngsters. I hope everyone is having a great time and learning this anatomy. So today I'll be talking about comparative anatomy of cavernous sinus. It's an academic study. So as you all know, skull base is a very vast area, and all the skull base, we have the cavernous sinus, which is the main area, and we have our this internal carotid artery is the main artery which enters the from outside, travels in the petrous bone, then in the cavernous sinus, then it goes intracranial. So most of our discussions are in the skull base are focused around internal carotid artery, especially when we are seeing this now endoscopic approaches. They are all centered around the internal carotid artery. But in the previous time, as you know, this Parkinson triangle and all these triangles, they were described in relation to approach this artery. These nerves were, which was coming in the way, they acted as a geometrical this thing triangular areas, so they were described in the literature for the communication of various this thing. But as you know, these all these lesions and all these pathology, they don't understand these triangles, they don't understand how these things are we are describing. They have their own way of involving the critical areas. But for a better communication, for learning, we need to know how this anatomy is working. Anatomy is same whether you watch it through endoscope, whether you watch it through microscope, but the perspective changes. So thing is, when we as a neurosurgeon, we are so used to watching this anatomy from the top. Once we are introduced through the endoscope, we sometimes get confused. So let's try to lower this confusion. Of course, you have to do a lot of hands-on dissections. You have to go to lab. You have to do cases, and then you have to see the pathologies, how these pathologies are distorting that anatomy, how this anatomy will help you in removing those pathologies. So let's see first the triangles in a summary. You have the three group of triangles. We have cavernous sinus triangle, we have middle fossa triangles, then we have the paraclival triangles. So this almost cover whole of the middle fossa and some part of the anterior cranial base and some part of the posterior cranial base. So as you all know, we have the four cavernous sinus triangles, which are related to cavernous sinus. We have a clinodal triangle, we have oculomotor, then we have supratrochlear and infratrochlear. And once you are infratrochlear, then you are outside the cavernous sinus. We are in the middle fossa. We have four triangular areas, which are not always very much triangular, as you know. So we have anteromedial, we have anterolateral, then we have posterolateral, then posteromedial in a clockwise way. So anteromedial, anterolateral, posterolateral, and posteromedial. And then we have, of course, two triangles, which are paraclival, inferolateral and inferomedial. So this is a picture of the skull base, which we were just seeing. You can see all of this is the middle cellar area. We have anterior clinoids. We have our this wedge-shaped petrous bone which goes inside, and it which is basically a synchondrosis, and it forms our petroclival fissure and sphenopetrosal fissure. And the junction of these two fissures, we have a opening, foramen lacerum, and through there, your ICA enters into the intracranial compartment. So you have to imagine this all 3D anatomy. You have to imagine in your mind. Then you will be able to better appreciate. So my connection is a little slow. So you see, once we know this, now this is a frontal view, which we generally see through our endoscopic areas. We have here our and the sphenoid sinus. So this is the front. I want to show this lingual process. Just remember, this is a lingual process. This is the projection from sphenoid backward. Here we have attachment of the petrolingual ligament. So from petrous to lingual. And this is the point where ICA enter inside the cavernous sinus. This is the we are very much confused sometimes which is the cavernous ICA, which is the outside the cavernous ICA. So technically this is the point where we have of petrolingual ligament. Come to the rings also. So if you see this anatomy from microscopic point of view, you can see here the oculomotor triangle. You can see here the clinoidal triangle. Of course, now you with the lateral side, you can see all the triangles: supratrochlear, infratrochlear. You have anteromedial, anterolateral, posterolateral, and posteromedial. You can see beautifully here is the your Kawase triangle. So these are your clival triangles. So coming back to the endoscopic view, this is the main working area in the endoscope. We know a good pneumatized sphenoid sinus is the main room which gives you access to all of the skull base with your endoscopic instrument. Of course, this is again very beautifully pneumatization of the carotid. Sometimes this bone is very thin and it may be deficient, so we have to be careful. So you have opticocarotid recess, which is the ventral representation of the optic strut. So we'll be coming to that also. So all these anatomical points, they are important when you are doing operations in this area, whether you are doing it microscopically or endoscopically. So if you see now, this is the OCR. So this is the picture after removal of the bone. So now you can see all the arteries, inferior hypophyseal artery, you have dorsal meningeal artery. You can see how the paraclival internal carotid artery, it is going and it is forming a C-shaped curve, which is the cellar part of the internal carotid artery. And then it goes intracranially. So endoscopically, this whole anatomy changes. Here we are not dealing with the triangles. Here we are dealing with the compartments. We have a medial compartment, lateral compartment of the cavernous sinus. So this is the lateral, this is the oblique view of the lateral wall of the cavernous sinus. You can see this C-shaped curve, and you can see some part of the lateral cavernous wall. So if you try to medialize, or of course it is if it's just for the anatomy, not sometimes practical. So you can medialize the ICA, and then you can see whole of the third nerve. Here you can see third nerve entering the roof and going along the lateral wall, and you can see the sixth nerve traveling inside the cavernous sinus. Of course, it is lateral to ICA and medial to the lateral wall. So sixth nerve is the only nerve which is traveling inside the cavernous sinus. So coming to specific triangles, we have clinoidal triangle. Of course, it is between the, it is medial to the anterior clinoid. So here we have taken out the clinoid process. You can see this is the a lot of youngsters, they get confused. Where is carotid collar? Which is proximal ring, distal ring, carotid oculomotor membrane. So these pictures will try to remove that confusion. Now you can see this clinoidal part of the ICA is very much well defined when you see through endoscope. From microscopic point of view, it is sometimes not that well defined. Of course, now you can see here is the distal ring. Here is the proximal ring, And you can see this proximal ring is not that adherent to the adventitia. There is some venous space. So that's why it is called a loose. So you see, if I see from endoscope, now you come from the, if you see this picture, so the dura, which is below your anterior clinoid, is your proximal ring. And if you see from this side, I've shown you this is the optic strut. So there is a dural membrane which is below this. This is your proximal ring, and this is your distal ring. And the compartment of this triangle between this is your interclinoidal ICA. So this is interclinoidal ICA here. So here I have medialized, I have this moved ICA just to show here even anterior clinoid has been drilled. So you can see how this is anterior clinoid, and just below anterior clinoid you can see third nerve traveling like this. And on top you can see this is ophthalmic artery. Of course, this is now intracranial part of the ICA. So oculomotor triangle, again, very interesting triangle. Here we have three boundaries which are three ligaments which are connecting anterior clinoid, posterior clinoid, and your petrous apex. And in the center, you can see third nerve entering, and this is the top view here, and this is the lateral view, third nerve entering this as a cisternal kind of opening here. Then it immediately, after some time, goes into the lateral aspect. So this is the oculomotor triangle. And if you see from below, you can see this C-shaped. I have tried to just lower this part of the ICA, and you can see there third nerve entering on both the sides. You can see this is the third nerve. So this is that oculomotor triangular area. If you try to see endoscope, and many of the pituitary tumors, they can go in this part of the ICA and part of the cavernous sinus, and then they can, if you are not careful, you can damage part of the third nerve here. So if you know this anatomy, then of course you will be more careful. Of course, supratrochlear fourth nerve is one of the thinnest nerve, just below the third nerve, and supratrochlear space is very narrow, and infratrochlear is little more, which is Parkinson triangle. So here we have this sixth nerve here. If you remove this three, you can see thinly here is the fourth nerve, and very narrow area, not not possible to explore endoscopically. Of course, sometimes what these lesions do is they expand these spaces. So if you know anatomy, then these spaces can be created. So these pathologies can create these spaces for you. So this is of course infratrochlear, below the trochlea, over the V1 here, and this is a large space. It's a Parkinson triangle, as you all know, and it gives you access to this vertical part of ICA, meningohypophyseal trunk, and of course this is the sixth nerve here. And from below, of course, from endoscope again, you can see this is the infratrochlear, this is the third nerve. Third nerve is practically, you can say, fourth nerve. Fourth nerve is not possible to see in this specimen. So this is basically infratrochlear space here. So coming to the middle fossa triangles, of course, anteromedial, I've already explained. So this is between V1 and V2 here is your anteromedial, and between V2 and V3 is your anterolateral triangles. So endoscopically, of course, if you have done this dissection, this is the V2 here, this is the V1 and V2. And this, if you remove this space, is not always constant. That depends upon the configuration of your trigeminal branches. Sometimes they are very close, sometimes they are very far. And of course, if you see this opening, it gives access to your middle fossa. This is part of the temporal lobe, which you can see here. So this is from the ventral aspect. And this is again anterolateral. Anterolateral, you can see here, there is a lot of space here between V2 here and V3 going vertically here. With this, also there is a mystery sinus between pterygoid plexus and the cavernous sinus. So this again can give you a lot of access. This is of course now we are going into infratemporal area also. So this is also giving you a lot of access to the middle cranial fossa. And in this specimen, you can see the whole of this clival dissection. You can see some part of the V2, and you can see branches of V3 here. So posteromedial, again, quasi triangle. This is medial. So this is medial. This is a quadrangular piece of the bone, which if you can remove, then you get access to, in this picture, you can see there is access to basilar artery and whole of the anterior part of your this brainstem. So again, endoscopically, of course, it is difficult to see, but you see if I have just tried to retracted this trigeminal, and this is lateral to your ICA, and this is the part which we saw in the microscopic picture. And if you try to go behind the ICA, it is possible to go here. You can see this is petrous apex. So we are drilling the petrous apex. This is, you can see the six now, how obliquely it is going from one layer of the dura and then entering the cavernous sinus. And on top of that, there is a ligamentous structures, which is petrosphenoid ligament or Gruber's ligament. Here also you can see the more of this petrous apex can be drilled to have access to this area. So this is the whole of the dissection from endoscopic point of view. You can see six nerve, very oblique course, goes behind the ICA, and then that enters this venous confluence here, and then it goes into the cavernous sinus. Of course, here I have preserved the dura, and just to show this branch, this is a dorsal meningeal artery, which is a branch of meningohypophyseal trunk. So now coming to posterolateral, this is also called Glasgow triangle, and the content mainly is this. You can see here is the artery. This is the middle meningeal artery. So from endoscopic point of view, this is very lateral. Here you can see all the dissection of the infratemporal fossa has been done. These are all branches of mandibular nerve here. So if you see, there is an internal maxillary artery which is related to branches of mandibular nerve, and you can see there is this middle meningeal artery arising and entering the skull base here, technically just leading to middle. Of course, inferior, then we have the clival triangles, which are in relation to your entry of the fourth nerve, and this is the sixth nerve. So if you see the infero-medial triangle, you can see this. Here we have the third nerve here, and this is the sixth nerve here. Sixth nerve entering, third nerve is practically, you can say, fourth nerve. So these are this is the area which again we are seeing from the clivus point of view. So this is the inferolateral triangle. Inferolateral triangle, you can just imagine it is just the porous of this Meckel's cave. So this is the entry of the Meckel's cave. So this is the triangular area which is called inferolateral triangle. So this is here from endoscopy, you can see fifth nerve. Then we have this arachnoid around the Gasserian ganglion. And of course, then it divides into three branches here. You can see from inferior aspect. And then you can see here some part of the seventh, eighth nerve complex and this ICA going into the internal auditory meatus. So this is again a beautiful picture showing all of the dissection of the skull base cranial nerves. You can say basilar artery with arachnoid preserved. You can see sixth nerve going very oblique. We have fifth nerve, we have seventh, eighth, we have lower cranial, and then we have 12th nerve going into the hypoglossal canal. Of course, this is very long journey of the ICA in the skull base. We have parapharyngeal related to Atlanto-axial joints, Atlanto-occipital joints here. Then we have petrous part, which is all the petrous has been drilled here, related to mandibular nerve here. And here comes your foramen lacerum, then paraclival, then going into the paracellar, and then the paraclinoid. So this is the whole journey of endoscopic roadmap, you can say, of the ICA in the skull base. So parapharyngeal, then we have this petrous part, then we have paralaceral part here, then paraclival, paracellar, and this is paraclinoid. This is the cella here. This is V1, this is this is V1, this is V2, and this is V3. So these all nerves and vessels, how they are arranged in skull base is very, very interesting. So these are different types of cella. You can see how this is a top-up view of this, all the cavernous sinus anatomy, microscopic anatomy. You have ICA, meningohypophyseal trunk. You have inferior hypophyseal artery going to the posterior pituitary. You have a dorsal meningeal artery going to the clivus, supplying the sixth nerve here. And you can see the sixth nerve here entering the Dorello's canal. This is the venous confluence. This is petrosphenoid ligament. Here you can see better Gruber's ligament, tie-shaped ligament, which I showed you through endoscope also. So this is again fifth nerve, third nerve, fourth nerve. So this is all in all. You can see beautiful picture of cavernous sinus with all the arteries and cella. And this is, of course, sometime we do brainstem dissection, not relevant to this course. So in short, what I want to say is once, of course, I can show you in 3D also. We wanted to come there and show, but due to some COVID situation, it is not possible. But this is all, anatomy is all three-dimensional. So you do a lot of dissection, you do a lot of cadaveric work, then you can make this whole picture in your mind. So you don't need virtual simulation and all those things. Of course, they are important, but you needs hands-on dissection to do to learn this anatomy. With this, I conclude, and thanks for this opportunity. Thank you.
Thank you, Sukhdeep sir. This was like a revision for us. So in the morning dissection, we saw exactly the same thing.
Yes, yes.
With the endoscopic and with the microscopic. This was a very excellent for the participant. Is there any question? We'll move to the next speaker, Dr. Manas Panegai, sir. Has he logged in?
I believe there he is.
Yeah. The Manas Panegai, sir, will be talking about the indications of the contralateral optical canal drilling. Manas Panegai, sir, is a professor of the neurosurgery at the Nizam Institute at Hyderabad, and he has almost 2 decades of experience with a number of cases, including 500 cases of CP angle, 400 cases of aneurysms, and multiple cases of AVM. Dr. Manas Panegai, sir.
Just one minute. Can you see my screen?
Yes.
Yes, sir.
Thank you, Dr. Cherian and Dr. Nilesh for inviting to speak on in this seminar. We had very good lectures from Dr. Abida working between tracts and Dr. Sukhveer to work between nerves, and the application of them from Dr. Dev Pujari and Dr. Sumit Sinha. So here I'm a little away from the topics. I changed my topic from CP angle because a lot of talks on CP angle I saw. I thought I'll speak on optic canal decompression, contralateral, because normally we think that when you do an optic canal decompression, we do through a ipsilateral craniotomy. But then when one needs to do a bilateral optic canal decompression, like in idiopathic intracranial hypertension, one can do with an endoscope bilaterally do a bilateral optic canal decompression. But then people do not prefer to do optic canal decompression bilaterally together because the chances of visual worsening has been high. But then if one does it, but what are the problems with just doing an endoscopic bilateral optic canal decompression? Now this paper, they analyzed the extent of decompression doing transcranial and endoscopic optic canal decompression, and this came recently. And when you do a transcranial, either an extradural or intradural optic canal decompression, and an endoscopy, one can see here that in endoscopy, one can only decompress 115 degrees of the optic canal. Whereas when one does transcranial, one can go up to 245 degrees. So the extent of decompression, and especially if you're doing for a surgery where optic canal decompression is required, probably transcranial is a better option than endonasal optic canal decompression. But then we have a thought block that if one does a transcranial, one can do only a unilateral one. When endoscopy, one can do bilateral. But here I'll be telling our experience on decompressing optic canal, both the ipsilateral as well as the contralateral, through the same craniotomy. We don't do routinely, but we in the past few years we have done 32 cases. 3 cases were of fibrous dysplasia who came with of the sphenoethmoid bone, who came with visual loss, where we had to do a bilateral optic canal decompression. 4 of them were of multiple aneurysms, where
we have to clip the opposite side paraclinide aneurysm with ipsilateral approach, contralateral approach, and then 8 cases of idiopathic intracranial hypertension and 17 cases of suprasellar meningioma, where we did from contralateral approach and did a contralateral optic canal decompression. I'll take an example of each group of cases, one cases in each group. Out of the 3, this is a 55-year-old lady who came with visual loss, and this was the MRI. He had bilateral visual loss, and there was, one can see here in the MRI that he has significant sphenoethmoid fibrous dysplasia with bilateral optic canal decompression. The significant loss was on the right, on the left side. But then if we decided if you go from the left side, the bunch of the whole bone mass will cause problem in decompression. So we decided to go on from this side so that one can do ipsilateral optic canal decompression as well as the contralateral optic canal decompression. And this was, we did a CT scan, and this is the video of the case. We had done a CT scan. Extradural was difficult to identify. So this was an intradural, both ipsilateral and contralateral. It was very thick bone. We use both drill as well as the bone CUSA. Once you reach near the dura, you use the bone CUSA. The bone CUSA was used to widen the optic canal. You can see here the thick, the dura around the optic nerve. Here, the ipsilateral optic canal is already decompressed. I'm just showing the contralateral. One has to do from the falciform ligament till one reaches the annulus of Ginn. You can see here the whole optic nerve, sorry. And this is the final one. Both optic nerves are seen. This is ipsilateral optic canal decompressed. That is the contralateral optic canal decompressed. Even the contralateral one can do more than 180-degree decompression. Ipsilateral, one can do 240 degrees. Contralateral, at least more than 180 degree, which is more than the endoscopic approach. All the 3 cases of hydrocephalus which are done had at least static vision. At least 2 out of 3 had a recovery of vision. Now, this is an example of aneurysm. This patient of multiple aneurysms. The ruptured one was on the side of craniotomy, and this was a paracranial aneurysm where again we did the optic canal was decompressed, the contralateral optic canal decompressed, optic nerve, and the ICF medial to the carotid was exposed, and the aneurysm was clipped. So we have done only unruptured aneurysms to a contralateral approach, and usually most of them are, all of them are multiple aneurysms. We have approached through the side of the aneurysm which has ruptured. There are 8 cases of idiopathic intracranial hypertension. It's not that the first option is to do a optic canal decompression. The first option is always a medical management, and then they usually do a shunt. And if they fail, then only we opt for give an option of transcranial optic canal decompression. So if it's a failed TP shunt, they go for optic canal decompression. But in some cases, you have papilledema in those cases, and the patient has a normal lumbar pressure. So if the pressure is normal in presence of papilledema and the diagnosis is IIH, then shunts do not work. So again, one has to do a transcranial optic canal decompression. And in cases, some of the cases, one case we had a tonsillar herniation in the MRI. In presence of tonsillar herniation, if one does a TP shunt, it can probably worsen the deficits. So if there is an associated tonsillar herniation, we prefer to do a transcranial decompression rather than a TP shunt. So this is what is our algorithm. If you go a medical therapy failure, go for surgery. First, put an external lumbar drain. If symptoms improve, then go for a shunt. If symptoms do not improve, then we go for a unilateral craniotomy and with bilateral optic canal decompression. So this is a case example of a 28-year-old female. TP shunt was done in 2010. Patient had presented with headache and visual loss. She was fine for 3 years, and this is the progressive improvement of the visual loss with improvement. And in 2014 also she was fine. 15 she started having early papilledema and again worsening of vision. And this is the gross papilledema with worsened vision. And when we did a lumbar pressure, the pressure was normal. So we did not revise the shunt. So we did a bilateral optic canal decompression. And after 6 months, she had recovered. Her papilledema had recovered. Now this case was the diagnosis of an IIH, and but the MRI showed that there is tonsillar herniation. So we did not offer a TP shunt for this patient. After failed medical management, we offered a unilateral craniotomy and bilateral optic canal decompression. The third indication of cranial decompression is when you have a bilateral papilledema with a normal lumbar pressure. And this is the case of 46-year-old female, which I treated in 2017. The MRI had the classical picture of optic nerve sheath distension. One can see here the coronal picture, the sheath were distended, but the lumbar pressure was normal. You can see the magnified view, the distension of the optic sheath, and patient had headache, had visual loss. You can see the tortuosity of the optic nerve and indentation of the globe also here. So these are all classical signs of IIH, but the lumbar pressure was normal. So the treatment, and can see here that near the optic canal, there is no CSF seen. So we opted for a transcranial optic canal decompression in this patient. And this was the pre-op. Before surgery, is the perimetry, and this is post-op. There was recovery of the at the end of 3 months. It's done through a standard pterional craniotomy or a frontotemporal orbital craniotomy. Intradural optic canal decompression is done. The ipsilateral one is done. Drilling is done along the optic nerve. And the dura is opened from the falciform ligament till one reaches the annulus of Ginn. When one reaches the annulus of Ginn, drops of CSF, which is collected in the optic, causing distension of the optic nerve sheath, one can see that. That is the end point. And once the ipsilateral is done, one can go for the contralateral. This is along the contralateral optic nerve, drilling along the optic nerve. Many times, sometimes the sphenoid sinus gets opened when one drills the opposite optic nerve. One has to be careful. And if one detects there is an opening of the sphenoid sinus, it has to be plugged with a fat and fibrin glue so that it do not have a CSF leak postoperatively. And again, dura is opened from the falciform ligament till one reaches the annulus of Ginn. At least 1 centimeter of the optic canal has to be opened, more than 180 degrees of the opposite side, and almost 250 degrees of the ipsilateral can be done. Optic nerve can be done. You can see here the CSF coming out from the optic sheath. This is from the opposite optic nerve. Now the third indication is of meningiomas, tuberculum-cell meningiomas, which have optic canal extension into the optic canal, wherever the tumor is extending into the optic canal inframedial to the nerve, and the tumor is attached inframedial part. Most of the time, these tumors are not attached in midline. They are either to the right or left side. Usually the side of attachment is the side of visual loss. Like this patient had presented with the left side visual loss, and this was a tumor. Classically, would have thought of doing an ipsilateral, the left side frontotemporal terminal craniotomy, decompress the optic canal and remove the tumor. But if one follows the endoscopy principles, then one has to see the attachment first without touching the optic nerve. So one can do with an endoscope, or what we preferred is to do a opposite side craniotomy, so that directly we can have an access to the attachment, as well as drill the optic canal, contralateral optic canal, and take out the tumor without touching the optic nerve or manipulating the optic nerve. So a contralateral approach, either endoscopic assisted or microscope, can be done in this kind of cases. And this is not a new approach. This was described long ago, contralateral subfrontal approach for a favorable visual outcome. And we have done at least 17 cases, and 70% of them had recovery of vision as compared to 30 to 40% when we had done in ipsilateral approach. Now, this is a case example, which a lady who came with right side visual, present no persistent vision on the right side for 3 months. You can see here that the tumor is more attached on the right side. So we did an approach from the left side. So the attachment, that the tumor is removed from there's the opposite optic nerve, that the attachment was medial to the optic nerve. Now there is some tumor going into the optic canal. Contralateral optic canal decompression was done using a bone CUSA, and the tumor which is inside the canal was taken out. One can use CUSA or a diamond drill. You can see here the tumor which is going to the canal, after canal is decompressed, is removed. So in ipsilateral, one has to mobilize the whole optic nerve and then work below that. But in do a contralateral, so in a contralateral, one need not mobilize the affected nerve. So the chances of visual recovery is better. And this is at the end of optic canal decompression and removing the tumor, whatever was there in the canal. Now this is a case of suprasellar meningioma, which preoperatively we had not detected any aneurysm. We had done a contralateral approach, and this is the ipsilateral optic nerve. The tumor was again attached medial to the opposite optic nerve. The tumor was removed, decompressed, devascularized. And once we remove the tumor, you can see here on the opposite side ICA, we found an aneurysm there in the paraclinoid region, which we dissected and put a clip. This is fortunate for us and fortunate for the patient that we did not decide to do an endoscopic transnasal approach. Otherwise, probably would have been difficult to treat this aneurysm. In addition to dealing these cases, we have done 4 cases of multiple aneurysms with a contralateral approach. Of the meningiomas we have treated, we had good outcome. 10 of them needed optic canal drilling on the contralateral side because they had intracanalicular part, and vision improved in 13 of them. So in our experience, contralateral optic canal decompression is a technique which one has to do in many cases, and it has been useful to improve the outcome, especially in suprasellar meningiomas and fibrous dysplasia, means in all these indications. The advantage is that the normal optic nerve is visualize first, which can be traced to visualize the opposite side optic chiasm and nerve. Many times when you go through ipsilateral in larger tumors, the optic nerve is so much stretched out that one cannot differentiate the tumor and the nerve. But if you trace from the normal nerve to the chiasm, one can at least find out where is the nerve and preserve it. And it causes, one can decompress the canal from the medial aspect and avoid manipulation of the affected nerve, and hence the visual recovery is better. And if you're treating with meningioma, one can treat associated pathologies like aneurysm through the single approach. One need not go in again or do an endovascular coiling at a second stage, which reduces the cost of treatment. Thank you for your attention.
Thank you. Thank you, Panaswamy sir. Is there any question from the audience?
Sir, do we do decompression? You do frequently in head injury patients also? When there is an RAPD or there is an acceptable visual loss due to head injury, is it being done?
Yeah, if the CT scan shows compression, the optic canal has a bony fragment, then only we do. If there is no compression or if there is an optic sheath hematoma. But if you do not find any compression, then we don't do a canal decompression.
Thank you, sir. We can now move to the next speaker. Next speaker is from the Mexico, Professor Victor Perez. Has he joined? Hello, John.
Hello.
Yeah. Welcome, sir.
Yeah.
Professor Perez is a neurosurgeon and neuroanatomist from the Mexico City, and his presentations are always beautiful to watch. He is talking about cavernous sinus triangles.
Oh.
So you can start your presentation.
Yeah, thank you.
There's Victor.
Yeah.
Hi, Dr. Victor. How are you?
Hello. Let me share my screen. I have some problems here.
Take your time.
With my screen. No. Oh no, I don't know what.
Oh, it fell off. You okay there, Victor? His Wi-Fi may have frozen. So just be patient.
If Professor Victor is taking time, can we shift to the next speaker? Then we'll come back again to this. The next speaker is Pablo Gonzalez from the Spain. Has he joined?
I am.
There's Pablo.
Hi, John.
How you doing?
So you let me know if you can watch it and hear me.
Pablo.
Yeah.
Amigo, what's happening?
Here I am. I'm ready.
Okay.
Okay.
Go ahead with your presentation. Thank you for being there.
Thank you, Ipe. Thank you, everyone, and congratulations to you and the team for bringing up this program. And I feel guilty because I decided to share with you the CPA anatomy, and I realized that there were many presentations, but I'm sure that repetition will be okay. So just to share with you some ideas about the CPA, some very basic ideas on, again, how the anatomy can help us to optimize our procedures. So it's well known that this blue line is representing what we call the CPA, and the CPA, the cerebral-pontine angle, it's a fissure which is located in between the bones, the upper part of the medulla oblongata, and the medial aspect of the petrosal surface of the cerebellum. And in this wonderful area, we have very important structures that are the branches, lateral branches of the basilar artery, the choroid plexus rising from the Luschka, and the fifth nerve. We also have the 7 and 8 nerves and the lower cranial nerve. So that's why it's so important to know. But obviously, we have another structure, which is very important when we are trying to approach the CPA pathology, which are the different dural layers and how the different sinuses are located in between these dural layers. So in this sense, it's important and mandatory to understand how the superior and inferior petrosal sinuses are confluencing here, following the lateral direction to the junction of the transverse sigmoid sinus, superior petrosal sinus, and inferior petrosal sinus, which is arising from the cavernous sinus and joining directly the jugular foramen area where the jugular valve is. But this is what we see generally when we are approaching laterally or anterolaterally the CPA through a retrosigmoid approach. And here generally we place the bar hole quite close to the junction of the transverse with the sigmoid sinus. And this is the view we should have in a lateral approach to the CPA. Important structures also, arteries, mainly the AICA. Sometimes the pica, it's pushing upwards the anatomy of the CPA. And in some cases, we also have to deal with the superior cerebral artery. And in this sense, we do have, as we said before, 3 different compartments, superior one, middle, and inferior one, where we have cisterns. The superior one, we do have the cerebellopontine cistern with the 5th nerve, same cistern with the 7 and 8 nerves in the middle part. And in the inferior part, we generally have the cerebellomedullary and premedullary cistern with the lower cranial nerves and the pica. So these are the important structures we do have. And you can see how this angle, small area, is of highly interest. Well, something very, very important to know in this area, in my mind, are the cisterns, and this is what I have learned from my mentors and my professors, because 90–95% of the pathology we will be dealing with in this area, it's a benign pathology, which usually respects the natural anatomy, and the natural anatomy is clearly defined by the cisterns and by the arachnoid layers. So this is why it's so important to understand the different cisterns we do have in this area and the contents of each of them. And generally, this is the view extracted from the beautiful microneurosurgery book from Professor Yasser Hill. Which are the approaches we can use in order to deal with the pathology located here? So we can go to a lateral suboccipital approach, represented in green. This is a classic retrosigmoid approach, which is obviously the most common one. But in case we need, as we have seen before in the wonderful lectures, we can use transpetrosal or even far lateral approaches, which will give us and expand the surgical field in this area. So this is the view we could gain with the far lateral, much more lateral and inferior view. This is what we can have after doing a petrosectomy. So we will be dealing mainly with the anterolateral aspect of the pons. But the retrosigmoid craniotomy is a very fast one, quite simple to perform and very safe. And with this approach, we have a lateral view of the cerebellopontine angle, and we have direct control of the branches of the basilar and also the lateral aspect of the cranial nerves. So let's concentrate on the retrosigmoid approach and let's discuss some important issues. This is how I use to place the patients. Nowadays, I elevate a little bit more the head of the patient, but I always rotate a little bit the head of the patient towards me in order to facilitate the gravity to push gently the cerebellum downwards. So about the skin incision, the important landmarks, very well-known ones, are the mastoid tip, and we always try to find the posterior root of the zygoma, the inion. So then we trace this line, and the cross line in between this one and the one which is running upwards from the posterior aspect of the mastoid tip or the digastric groove is the point in which generally the sigmoid and the transverse sinus join together, which means it's a little bit anterior to the so-called asterion. So that's where we place at the center of our skin incision. Then I do a curvilinear incision based on that anatomy. And this is what we will expose after opening the subcutaneous tissue and retracting the muscles. So this is the junction of the sigmoid transverse, and the asterion is a little bit posteriorly generally. So this is the bony anatomy in which we can see the asterion, which is the junction of the lumboid, parietomastoid, and occipitomastoid sutures. So here, generally, if we go to the inner aspect of the skull, we will see that the transverse sigmoid sinus junction is a bit anteriorly and superiorly located. This is our craniotomy. So we use this landmark in order to try to expose the inferior part of the transverse and the posterior part of the sigmoid sinus. And generally, this is how we do it. We place a bar hole located in the asterion, and then we do our craniotomy with these two traces. We leave a small bony bridge in order to retract the bone without any damage, or trying to diminish the damage of the sigmoid sinus. And a good landmark in order to have a good orientation of the relative location of this sigmoid sinus are these mastoid emissary veins, which generally they drain to the sigmoid sinus in this kind of transverse direction. So once we see them in the surface of the skull, it means that we still have some bone to be drilled. So this is the curvilinear incision. Just wanted to show you how we can take advantage of this anatomy. I'm uncovering a little bit the asterion. Sometimes when you cannot see the asterion properly, you can drill a little bit the external surface. So this is the inferior part of the transverse sinus. In case we have some doubts, we can use the Doppler. And this is the way in which I was telling you that we do the craniotomy. And then we expand the anterior view towards the posterior aspect of the sigmoid sinus, trying to optimize as much as possible our anatomy. We were discussing about the cisterns, and approaching the cistern is something that should influence our dural opening. So the dural opening, generally, there are many ways to do that: key shape, Y shape, X shaped. This is how we do it. In case we want to deal with the middle and inferior aspects of the CPA, we can do this incision. But in case we want to go to the upper part and use the supracerebellar and the CPA exposure, we can do this dural incision. But always the first thing we do once we open the dura is to look for the cerebellomedullary cistern in order to relax the cerebellum. So this is what we do. This is the direction we should follow. And once we see it, this is something that changes the surgery and the mood of the surgeon also, because it means that the cerebellum will get relaxed very soon and our space to the CPA will be opened again. So upper compartment, we were discussing superior cerebellar artery and fifth nerve, and the classic pathology we are dealing with in this area is the compression, vascular compression causing a trigeminal neuralgia. So this is a craniotomy we do. This is a transverse sigmoid sinus. And in this case, we just need to open the dura in this superior corner of our exposure. So with this maneuver, we are trying to expand the opening. And the first thing we use to find in this corner within the supracerebellar space is the complex of the Dundee's veins draining into the superior petrosal sinus. About this anatomy, there are different types, and this is the most common one, in which in type 3 we find the superior petrosal veins draining into the superior petrosal sinus, just lateral or posterior to the fifth nerve, and this is what we used to find, which difficults a little bit the access to the trigeminal nerve, but we can have the windows in between these veins. So in this case, we use the endoscope in order to see which window is the most optimal. So this is the fourth nerve, this is the tentorial notch. So that was the crudal cistern and the ambient cistern, which we are opening. So here we have the superior cerebral arteries. In this case, two superior cerebral arteries. This is the pons, which are obstructing and compressing the fifth nerve. So obviously in this case, it's much better to access this area through the supracerebellar space. So now we are pushing upwards the superior cerebral arteries. And again, with the endoscope, we can check 30 degrees endoscope, we can check that the trigeminal nerve is fully decompressed. So about the upper compartment and the trigeminal nerve, this is the general topography of the different branches. So we have V3 posterior inferiorly and V1 superior anteriorly. And the motor branches generally are arising, as Professor Rotten perfectly described, superior to the V1 exit point. So this is the motor branch, which is turning below the Gasserian ganglion and joining V3 finally in the middle fossa, just at the level of the Meckel's cave. So in this area, we can also deal with some meningiomas or schwannomas, and this one is clearly a petrous apex or anterior petroclival small meningioma, which was compressing the fifth nerve, as you can see, and causing a very uncomfortable neuralgia. So that tumor is arising just anterior to the trigeminal nerve and pushing the trigeminal nerve posteriorly and causing this neuralgia. Images are very important to understand in order to decide which is the best approach and the surgical strategy. And in this case, you can see that our view is going to be obscured by this hyperostotic bone located in the petrous apex, which is located right there. And this is the so-called suprameatal tubercle that in this case should be drilled in order to access the trigeminal nerve and the Meckel's cave. And also, as you will see in the video, it was very useful in order to decompress the trigeminal nerve before starting the removal of the meningioma. So we are opening the cisterns, getting a good view of the anatomy. Now we are moving superiorly. You can see the fifth nerve and the motor branches of the fifth nerve, which are completely compressed posteriorly and obscured by this bone here. So this is the midbrain that was a pons, and the fifth nerve is completely compressed, as you can see. So first maneuver we want to do is to decompress it laterally or posteriorly. That's why we are doing the suprameatal tubercle in this moment. And once we decompress it, we always place one wax in order to prevent CSF, rhinorrhea. And now we are working superiorly and inferiorly to the fifth nerve, which is being decompressed. So this is how it looks like almost at the end of the surgery. With the endoscope, we can see the sixth nerve. It's dangerous to go there if we have no clear control of it. So now we can completely devascularize the feeding arteries of this small meningioma and fully decompress the trigeminal nerve. We cover always our drilling in the petrous bone with some muscle and some spongostan in order to prevent CSF leak. So this is the post-op in which we can see that the trigeminal nerve is fully decompressed. The patient experienced an improvement in the neuralgia, but she still has some quite uncomfortable hypoesthesia in B3. So let's go to the middle compartment where we mainly have the ICA and the 7 and 8 nerves. And there's something curious about it is that the point in which the fifth nerve and the 7 and 8 nerves arise from the brainstem are located in the same sagittal line. However, if we look it from above in an axial plane, we'll see that the fifth nerve is running upwards perfectly, anteriorly, but the 7 and 8 nerves are moving laterally in order to enter the internal acoustic meatus. And this is relevant because once we enter the CPA, first thing we will see is the 7 and 8 nerves, which are more posterior or lateral, and the fifth nerve is quite anterior to our exposure. So that's something important to realize. This is a curious case of a 12-year-old boy who came 3 years before with this small schwannoma, and he was completely hearing loss in the left side since he was a baby, and now he was starting to lose some hearing function in the right side. In 6 months, this patient experienced a decrease of the hearing function in the right side. And you can see that only in 6 months, this schwannoma was growing like crazy. This is mainly a schwannoma located in internal acoustic meatus. Generally, in these cases, we use gamma knife, but this case was very special because the patient had no hearing function on the other side. So that's why we decided to do a removal through a retrosigmoid approach. Generally, in big tumors, we cannot see properly where the internal acoustic meatus is located through this retrosigmoid exposure. This is not the case. This is a small one, but in these cases, we can take advantage of this fantastic landmark shared by our colleagues from Tübingen, in which we can see these lines which are running upwards from the jugular foramen to the lower part of the internal acoustic meatus. So if we see these dural folds, we can have an understanding of the relative location of the internal acoustic meatus, as we can see in this dissection we were doing in the lab. So this is the lateral opening of the internal acoustic meatus, which is what we have to do in this case because the tumor is located mainly in the inferior vestibular nerve, and we want to drill and decompress laterally that part before starting the removal. So again, we are opening the dura, quite basally in order to access the cistern. Again, we release CSF, and then we complete the dural opening. Here we have the dural folds. You can see them running upwards, and in the most superior part of these dural folds, we will have the relative location of the internal acoustic meatus. We are doing it using the laminatome also to increase 9 millimeters exposure I wanted to expose in this case. So now we can see the superior and inferior vestibular nerves with the acoustic nerve behind and the fascial nerve. So we are checking where we are located. That's the fascial nerve being stimulated right there. And just with this maneuver, our neurophysiologist told us that the patient was experiencing some improvement in the hearing function, which was something quite confusing for us. So now we are decompressing the tumor internally and trying to get a nice view of the acoustic and the fascial nerves, which should be located anteriorly. But as we move anteriorly to the fundus, we will have less angle of view. So that's why we are working now with the endoscope, 30 degrees endoscope. Now we can have a nice view of the remnant of this acoustic schwannoma, which was located quite anteriorly. And in this case, again, the endoscopic assisted surgery was really helpful. The patient came back to his normal hearing function. Preoperative decrease of hearing function was stable. So we didn't damage the hearing function, which was indeed my real goal. So this is how it looks like after surgery with this simple lateral retrosigmoid approach. And maybe we have a remnant there. I'm not sure. I'm monitoring this patient closely for 3 years now, and there is no growing, and he's quite happy with the result. So really CPA tumor I wrote here because this is a small dermoid, epidermoid tumor, which is located in what we call the CPA, just anterior to the 7 and 8 nerves entry points. So this tumor is located mainly in this area, and this is a hidden area to our microscopic view. So let me try to prove you what I mean with this. So again, first maneuver, opening the cisterns, relaxing the CPA, checking where the lower coronary nerves are located. And now we move to attack the tumor, which is anteriorly located to the 7 and 8 nerve complex. So with this view, we could understand that the fascial nerve is located just anterior to the vestibular nerves. But let me show you what happens if we use the endoscope. We can see that the fascial nerve is completely moved inferiorly and posteriorly located here. This is the fascial nerve, and we are checking now with the microscope. So this is a nice example of how useful it is to use the endoscope. So that's why we are starting to debulk the tumor from the superior window in order to try not to damage this fascial nerve here. So once we are inside the tumor, these are easy tumors to sac. And now we are moving to the inferior window where the fascial nerve is located. So we are trying to open the cistern, the arachnoid, in order to protect the fascial nerve from the heat of our maneuvers and try to work as much as we can through the superior window. So once we are very happy with the result, we decide to introduce a 45 degrees endoscope, and we can see that there was some remnant there hidden in the area just anterior to the 7th nerve. So this is the anterolateral aspect of the pons, and this part of the tumor was not seen easily with the microscope. So in this case, again, the endoscope was really useful in order to perform a nice removal of this tumor. So again, a good use of the endoscope. This is the view we can gain with the microscope, but if we introduce an angle endoscope, we will gain a panoramic view of this area and fully decompress the structures in the CPA. Another really CPA tumor, this is a posteriorly located meningioma, but it's pushing anteriorly the 7 and 8 nerve complex. So obviously the feeding arteries of this tumor are rising from this hyperostotic area of the petrous bone, just posterior or lateral to the internal acoustic meatus. So this is what we want to expose first of all, to try to kill the tumor before starting its resection. So that's why we are moving quite posteriorly or laterally to the dura of the petrous bone. So we are devascularizing the tumor. We are drilling this hyperostotic bone, which is located lateral to the internal acoustic meatus. Now we are opening internal acoustic meatus, and we are trying to use the arachnoid, which is covering the complex, the middle complex, middle compartment of the CPA. So this arachnoid is really helpful in this case in order to protect these neurovascular structures and accomplish a nice resection of that meningioma. And just finishing, moving to the lower compartment, we can also use the retrosigmoid approach in order to deal with some pathology located here. But in some cases, we should need a kind of far or enough lateral exposure, as in this case here. So the first one is a glossopharyngeal neuralgia. In this case, we can use the retrosigmoid, classic retrosigmoid approach in order to decompress the glossopharyngeal nerve. So here we do have 7 and 8 nerve complex. So this is the middle compartment. Now we are moving the endoscope downwards in order to open the lower compartment, so we can see the glossopharyngeal nerve, cisternal part of it. That's the spinal accessory nerve running upwards in order to join the jugular foramen. So that's the basilar artery, and we will see a small pica which is anteriorly located. In this time I was not using too much the endoscope, but I'm sure the endoscope could have been really helpful in order to deal with that artery which was compressing anteriorly the glossopharyngeal nerve. So we were able to dissect it and to separate it and to place some Teflon there, as you can see here. So this is the glossopharyngeal nerve which was quite compressed, but in this case we needed an inferior and more lateral exposure in order to deal with this hemangiopericytoma which was growing from the vertebral artery. So this is the vertebral artery. We wanted control of it because this is a bleeding tumor which sometimes arises from the walls of the vessel. So you can see how it's growing from the vertebral artery. And that's why in this case we needed quite a basal exposure because we wanted to have control over the vertebral artery. So once the vertebral artery and all the cranial nerves are under control, we can continue and keep going with the resection. But in this case, I was not able to perform a complete resection because the tumor was really adherent to the wall of the vertebral artery. So here we have it. This is the part of the tumor which sorry, this is the vertebral artery, and this is the point in which the tumor was growing from it. So sometimes this anatomy is not so easy. This is a quite special case. This is a doctor of our hospital. She was experiencing some headache during the whole day, and at 2 a.m. She came to the emergency room, and the GSC is 7, and we can see a lesion, a tumor which was bleeding and compressing the brainstem, causing hydrocephalus. So in these cases, the anatomy is extremely important because we need a wide exposure. We need to, in this case, to open as much as we can the skull, because we are expecting to have a cerebellum like this one. We tried to apply all the concepts I was just sharing with you. I was trying to reach any system to release CSF, but it was completely impossible. So I decided to fastly go to the tumor to debulk it. But as you can see, it was terrible. I had no chance to do that, and the cerebellum started to have this terrible herniation. It was pumping towards us, so we decided to change our strategy and to be quite aggressive. And we started using the CUSA in order to remove part of the cerebellum. We couldn't go inside there, and the patient was having some hemodynamic problems. So that's why we removed part of the petrosal aspect of the cerebellum, and then we fastly attacked the tumor, try to vascularize it, and apply the same concept right now in order to try to debulk as much as possible this petrous bone meningioma. So in this case, again, even if we are in travels like this one, try to respect the arachnoid. The tumor was quite hard, so we had to use the knives. This is something that we are not using during regular elective cases, but this case was really special because the patient was having some problems and we had no good access to the CPA. That's the bleeding. You can see the bleeding, that it was outside the tumor in this subdural space. So now we are trying to go to the upper part of the compressed trigeminal nerve. And finally, it came towards us. The patient had a very difficult postoperative course, but luckily now she's not working anymore. She has some walking disturbances, but she can walk alone. And she had some diplopia due to cranial nerve paresis. So that was the last case I wanted to share with you. And just to conclude, Very important to realize that most of the lesions located in the CPI are benign, so they are respecting the arachnoid layer, so take advantage of them. Many vascular compression syndromes in this area, which if we perform a careful and safe surgery, the result is going to be fantastic for the patient. Surgical positioning is very important. The patient must be comfortable, but also the surgeon should be very, very comfortable in order to proceed with the surgery. Take advantage of the external skull landmarks, CSF releasing. So try to plan your craniotomy and dural opening, first of all, to reach one of the cisterns in order to release CSF and relax the brain. Try to understand the arachnoid layers because they are your really, really good landmarks inside the dural space. And try to use the endoscope as much as you can because the endoscope is going to expand our view to a much more panoramic understanding. Finally, try to understand the intracranial dural and bony landmarks because sometimes you must drill some part of the petrous bone in order to expand your view, and try to understand how the different nerves are arranged inside the internal auditory canal because this is going to be helpful in order to deal with pathology in that area. So that was all. Thank you very much. And again, congratulations for this fantastic course.
Yeah, hi. Good. Thank you very much, Pablo. Pablo, you know Victor, right? You know Victor, of course. Victor, yes. Are you there?
Yeah.
Victor, yeah, we have two of the giants of neuroanatomy. So are we going to make IPE's lab the virtual cadaver lab of the world, Pablo?
So we are working on it, and I will keep you updated because we are doing some nice dissections there, and we are setting up the cameras and so on. So I hope I will be able to share it with you very soon.
Oh, great! That's great. Okay, any comments or questions from the panel?
John.
Yes.
Pablo.
Hi.
Excellent cases, Pablo. Very good lecture. You know, guys, I remember about a couple of years back, we had been to Spain with my fellows. We did some dissections there, and then after that, in a midnight madness, we climbed Veleta, one of the highest mountains in Spain, probably the second highest in Spain.
Second one.
And we climbed it during midnight. We went to the mountain during midnight, and then came back. So let's keep doing such crazy things in surgery as well, Pablo. Safe, of course, but I mean, right now that we are in Krishna, we look forward to collaborating with Alicante more and more. And,
we will for sure. We have to. Thank you. I will never forget that day, that night. Indeed. It was great. Thank you.
See you guys.
Okay, someone want to introduce the next speaker?
If Professor Victor is ready, then we can start his presentation.
Can you see the screen?
Yes.
Okay. Thank you, Dr. Aip Sherian, for inviting me to this wonderful course. So I'm going to speak about the cavernous sinus. That is cavernous sinus are located each side of the sella and pituitary gland. In this picture, we can see the superior view of the sellar region, and in both sides, the cavernous sinus. Here we have the supraclinoid carotid artery and optic nerves, the third cranial nerves, fourth and fifth cranial nerve. Here we have the sella. Okay. The cavernous sinus is defined as dural space in which the cavernous segment of the internal carotid artery causes. Here
excuse me, Victor, your slide is not moving.
It's not moving?
The PowerPoint is not really connected. Yeah.
Now?
No. Make it bigger. It's frozen.
Okay.
Start again. Start again.
Let me share again.
There you go. Whoop, fell off again.
Now?
Yes.
Yeah.
Yes.
Cavernous sinus is defined as the dural space in which a cavernous segment of internal carotid artery courses. Here we have internal carotid artery. In this case, I removed the dura that covers the cavernous sinus. We can see here also the sixth cranial nerve. I displace the third and fourth cranial nerves to go into the cavernous sinus. This contains not only the cavernous carotid artery, but also a venous confluence that receives veins draining the orbit, in this case, Sylvian fissure and middle and anterior fossa, and has free communication with the basilar, superior and inferior petrosal, and intercavernous sinus. The oculomotor, trochlear, and ophthalmic nerves course in the lateral wall. Here we have an aspect of the lateral wall in which we have the third cranial nerve, fourth cranial nerve, and the three divisions of trigeminal nerve. This is a Gasserian ganglion. I have injected also with color blue the cavernous sinus, and the abducens nerve courses on the medial side of the ophthalmic nerve between it and the internal carotid artery. Here we have the abducens nerve in this case. Here we have the intracavernous portion. The nerves in the sinus wall or sinus are from superior to inferior, the third cranial nerve, here, the fourth cranial nerve, and ophthalmic and abducens nerve. This is the superior division of the trigeminal nerve. And here we have the anterior aspect of this cellular region, the optic nerves, the supracranial carotid artery, the pituitary gland, and third cranial nerves. In this view, we have I removed the anterior clinode process, and we can see an exuberant plexus, vein plexus, coming from the orbit. Here we have supracranial carotid artery, optic nerve, and third cranial nerve. Another picture to see this exuberant vein plexus in the removing the anterior clinode process. Another view. There are 4 triangles in the cavernous sinus, 4 middle fossa lateral to the cavernous, and 2 fossae in the paraclavial area. In here we have the infratrochlear triangle, in which we can see the meningohypophyseal artery or trunk. Parkinson described a triangle within the lateral wall of the cavernous sinus through which the intracavernous portion of the carotid artery and its branches might be exposed for the surgical treatment of carotid cavernous fistula. Here we have the Parkinson's triangle and some branches coming from the meningohypophyseal trunk and also the lateral artery of the intercavernous carotid artery. Here we have the clinoidal triangle. This triangle is situated between the optic and oculomotor nerves. Here we have this clinoidal triangle, and the triangle is exposed by removing the anterior clinode process. This is the anterior clinode process, optic nerve, supraclinode carotid artery, and third cranial nerve. In these pictures, we can see the origin of the ophthalmic artery. Here, the optic nerve and the ophthalmic artery. oculomotor triangle. Two margins of this triangle are formed by the anterior and posterior petroclinal dural folds that extend to the petrous apex. The third side is formed by the interclinoidal dural fold that extends from the anterior to the posterior clinoid proboscis. The infratrochlear triangle, Parkinson's triangle, located between the lower margin of the trochlear nerve and the upper margin of the ophthalmic nerve. The origin of the meningohypophyseal trunk from the posterior bend are located in this triangle. Here we have the meningohypophyseal trunk. And if I remove the trigeminal nerve, we can see much better this meningohypophyseal trunk, giving rise to 3 or 4 branches, as you can see in here. Here we have another dissection of trigeminal nerve, the Gasserian ganglion, third cranial nerve, fourth cranial nerve. And here we have the third, fourth, the abducens nerve, and the trajectory of this intracavernous carotid artery. In this other dissection, we can see this branch of the meningohypophyseal trunk is the dorsal meningeal artery. And here we have the intercavernous sinus, anterior, posterior, the pituitary gland. The basilar sinus is the largest venous connection between the paired cavernous sinuses. The superior and inferior petrosal sinuses also open into the lateral part of the basilar sinus, creating a large venous confluence along the posterior wall of the cavernous sinus. This is the basilar sinus. This is also exuberant basilar sinus. I remove the dorsal aspect of the meninge in order to see this important plexus. Here we have the sixth cranial nerve, the Dorellos canal. The abducens nerve enters a dural cave known as Dorellos canal, where it passes below the petrosphenoid ligament, Gruber's ligament, that extends from the lower part of the lateral edge of the dorsum cellar to the petrous apex to enter the cavernous sinus. Here we have the lateral aspect of the intracavernous carotid artery, sixth cranial nerve, and the artery, the lateral artery coming from this part of the cavernous carotid artery. Here we have another beautiful picture about this intracavernous carotid artery, the meningohypophyseal trunk and the lateral artery. The inferolateral trunk, this is the inferolateral trunk, artery of the inferior cavernous sinus arises from the lateral side of the mid portion of the horizontal segment of the intracavernous carotid. This is an important artery because this artery irrigates the lateral cranial nerves that cross the cavernous sinus. In this picture, we can see this region in the middle fossa and also the cellar region without injection in a fresh specimen. Intracavernous branches, the meningohypophyseal trunk arises lateral to the dorsum cellae or just before the apex of the first curve of the intracavernous carotid. The meningohypophyseal trunk gives rise to 3 branches: the tentorial artery, also called the artery of Bernasconi Casinari, which courses lateral to the tentorium. the inferior hypophyseal, which travels medially to supply the posterior pituitary capsule, and the dorsal meningeal artery, which enters the dura of the posterior sinus wall and supplies the clival dura and 6 cranial nerve. Here we have a short video to show this dissection of this region. In the right side, we can see the origin of the ophthalmic artery. And in the left side, I didn't see the ophthalmic artery. I displaced this intracavernous carotid artery, and I couldn't see the origin of the ophthalmic artery. So the ophthalmic artery is coming from other side that this has been described by Dr. Roton. Some ophthalmic arteries are not coming from supracranial carotid artery. In this case, I have found some very small arteries coming from the medial side of this intracavernous carotid artery. As you know, the artery is more common is the meningohypophyseal trunk and the inferolateral trunk, but sometimes I have seen a very small arteries coming from the medial side of this intracavernous portion of the carotid, the intracavernous carotid artery. This is a picture in a lateral view of the cavernous segment of this artery after removing dura and also the cranial nerves. Here we can see the meningohypophyseal trunk and the ophthalmic artery and this segment of this carotid artery. And this is a posterior view after removing dura and also cranial nerves in this region. So this is a picture of the nerves and arteries and also brain structures that are around this region. Thank you very much. Thank you. John Bennett.
Thank you very much, Victor. Excellent presentation. Okay, any questions from the panelists or comments?
Is there any question?
Yeah, any questions or comments? Go ahead.
Otherwise, we can shift to the next speaker.
Okay, okay, go ahead.
Has he joined? Dr. Ramesh Nair.
We can't hear you.
Dr. Ramesh Nair, has he joined?
Yes, he has. Yes.
Okay, yeah. Dr. Ramesh Nair is going to speak about the complex ABM surgical planning.
Hello.
Hi, John, and hi, Victor.
Okay, hello.
I think the audio from the host unit is very faint.
Yeah, yes, it is. It has been. Okay, Ramesh, you're all set.
Thanks very much, Aib. Great to see you back in India. Looking forward to meet you soon. And thanks to all my friends here, John and Victor, and see Pablo, everyone's here. Good to see you all. I'll start sharing my screen. Do let me know if you can't see or hear my audio.
Okay.
These are some of the my own personal views on some of the AVMs we treat. So obviously the surgical strategy always depends on what kind of cases you treat, and it differs from a ruptured AVM versus an unruptured elective AVM. For example, this is a young man treated in 2018. He came initially under the emergency team with a massive hematoma. You can see from the hematoma that it is quite large and causing a lot of mass effect. And on the CT angiogram, they can see parts of the AVM is being pushed to one side.
Ramesh, we can't see your presentation. Can you share your screen?
I'm really sorry. Just give me 1 second. Thanks for reminding me, because I think I forgot to share the screen. Can you see the screen now?
Yes, yes. But
Sorry about that.
Make it bigger.
Yeah, will do.
Okay.
So this is related to some of the surgical strategy I use when I treat large AVMs. I just want to take you through some of these points. And as I mentioned before, the strategy depends on the clinical scenario, and it's different from ruptured and AVMs, and also it's different in elective AVMs. For example, this is a young man who was admitted through the emergency in our trust in 2018 with a massive clot from a ruptured AVM. You can see from the picture here that the part of the AVM is shifted to the back of the clot. So in such a scenario, he underwent emergency craniotomy and evacuation. So the most sensible thing is to avoid trying to excise the AVM at the same time. This is a life-saving operation where your intention is to remove the clot and try and save his life. And this is what he had. He underwent, the emergency team did the craniotomy and evacuated the clot and left a layer of clot over the back of the cavity where he had this AVM. So since then, we could finally do all the workup we needed to do. And as you can see, the scan in August and subsequently a couple of months later, showing this AVM, which is fairly compact with draining veins predominantly to the superior sagittal sinus and some to the superficial middle cerebral veins. But often in a case of acute hematoma, the AVM is hidden and obliterated, and also the correct angioarchitecture is not clearly seen. That's why you need to wait for some time. And also in emergency situation in the middle of the night when non-neurovascular surgeons operate, it's not a good idea to try and resect it. This patient subsequently had to have a craniectomy because he had brain swelling, and then subsequently came to my clinic early January 2019 with this MRI scan showing a craniectomy with an AVM in the posterior parietal area. So this is, again, what I need to emphasize here is that sometimes things will change with time and you need to get updated scans and angiograms before you attempt, because this is going to be a long operation and you may want to replace the bony defect as well. So this is, he had that and had a cranioplasty put in, but the cranioplasty, normally they are straightforward operation, but when you have a long operation, and sometimes there is a risk of infection getting in. So unfortunately, this man had an infection of the cranioplasty, which I had to remove and then had to put back. So
the complexity not only depends on the AVM itself, but also the scenario where these patients come from. So ruptured AVM, as I mentioned, we need a complete workup before you operate on the ruptured AVM. Many patients, as I see, they get referred a few months later after they had their primary treatment. So for another man, fairly recent, came with a blade on the left temporal lobe, fairly eloquent. He had that trouble in word finding task, and this is the hematoma. One of the advantage with the hematoma is that if you operate during that emission, often you can see that there will be a pile surface of the AVM, and also the hematoma cavity also will have a surface, which helps you in terms of your dissection. This is the most recent case about last week, came with a major bleed but remained stable from a neurological perspective. Again, a right frontal AVM with a big clot. So these are the things which we need to consider when we decide when to operate and what is the best timing to operate. Few things you need to look out for. Some patient you need to study carefully the angioarchitecture. Why did they bleed? Sometimes they may have a venous stenosis. Sometimes the veins may have gone through thrombosis. Look for nodal aneurysms. Some patients may have some swelling which was not detected before. That means it is changing and there is some transformation going on within the AVM. And carefully study the draining veins. How many draining veins are there? Which one is the primary draining vein? And if you see the veins which are traversing through the parenchyma into the ventricle, they are difficult because if they are the primary draining vein, they may not be able to take the load of the arterial pressure through this vein, because the arterialization may not be complete and they may have a higher risk of rupture. So in terms of judging the emergency nature or the urgency of the situation, all these factors comes into account. For this man was a young chap, a nurse working in a nearby cardiac center, came with a small abnormality on the left temporal lobe. He came with a seizure, just one episode of seizure, and had an MR scan which shown the swelling around this AVM. We knew that he had an AVM because he had a CTA and also had some speculated calcification. But why was he getting swelling around it? So he was discharged from the emergency department following anti-seizure medication and was supposed to come back to my clinic. But this was a concern. He was having some swelling around that AVM. But before he could attend my clinic, turned up back to the A&E with another big bleed. This time with slightly more neurologic deficit, more in line with left parietal lobe syndromes. Here, this is what the angiogram shows, a feeder from the distal PCA supplying that AVM. So what you find in such cases is that you get this thrombosis within it. So this is one thing which you sometimes may encounter when you have the thrombosis, spontaneous thrombosis of such veins. You get a higher risk of bleeding from such aneurysm. This is something which one needs to be careful about. So this is the after the excision of the AVM. So on the CT angiogram, you need to follow these vessels carefully. Each and every feeder, how are they arranged, and how can you identify on the surface, and you try to correlate with the MRI scan and also try to match it with the angiogram. So this is, you get build up a mental picture of each feeder, and the twists and turns of each feeder and the way they're coming to surface, and if they are on the surface, if they are more deeper. These are things which you need to identify. So spend a lot of time studying these features, and that will help you in surgery. What about MR scan? Also quite useful. I always do MR scans prior to an operation on AVMs because it's important to get a good anatomical localization, and also this will help you to identify the vessels. Look for the vessels on the MR angiogram as well as MR contrast scan, and you can also use this for navigation purpose as well. But most important investigation which you need to spend a lot of time on is the angiogram. This is where you need to have a proper high quality angiogram, especially with the higher frame rate, which each advancing frame, you see the AVM is filling little by little, so you know which feeder is going into the AVM, because some of these feeders, especially in eloquent locations, are so critical that the feeders may not
you may feel that all the feeders are going into the AVM, but sometimes they may pass on, go on to supply an eloquent area, especially around the motor area or around the motor speech area. This is the reason why. This is a patient who came with a bleed in the left temporal lobe with a feeder coming off the PCA territory in the PCOM area. And also look at the way the veins are arranged. There's a short primary draining vein which straightly goes on to the sigmotransverse sinus junction, and another vein which is more anterior and tortuous. So these are important because you need to know which one you need to sacrifice. So at a point you come in surgery where you have to decide which vein to take before you can complete your operation. Sometimes they may have equivalent dominance, sometimes they may have a slightly different dominance. Here you can see that there is a bit of stenosis, so maybe there's more venous flow through the other side. And also look out for aneurysm within the nidus, which will make it slightly more higher risk. Venous sacs and direct venous fistulas also increase the flow within the AVM, which will determine the complexity of the operation. So this is the same case. Here you can see the draining veins. Let me just remove it. So this is the draining vein here. This is the left temporal lobe, and the base of the temporal fossa is here. Each time is spent on trying to identify the vessels going to this AVM. So here now the feeders are being ligated, and it's a circumferential dissection. So small draining veins can be dissected, but leave the final draining vein at the last, which is the standard principle in AVM surgery. What about this? Is another 23-year-old young female. She was a nurse in a local trust. Came with speech disturbance. She could not speak, and she was so frustrated and crying when I met her with a bleed in the posterior frontal area. She had this AVM. She had a fairly compact AVM with some neovascularity around it, but most of it is fairly compact. But as you can see on the anterior posterior view, it's fairly elongated AVM, which is what you normally see in most of the cerebral AVM, where they have like a conical shape, pyramidal shape. And the most distal point was traversing through the white matter tract. And the problem with this AVM is that most of the AVMs the part of the AVM was being fed by the mid-cerebral artery branches on the surface, but there were some branches which was going very deep and then coming to supply the deepest part of it. So that is a problem when you operate on this patient, especially in eloquent areas. So be aware that these feeders, if you try to get to the feeders surgically from here, sometimes you can cause neurological deficit. In this case, I was not able to get it, and then that small remnant was left after the operation. Subsequently, she did really well following the operation, and she improved in terms of speech function, but subsequently had gamma knife. This is a recent scan she had following the gamma knife. We will wait for another 2-3 years before we do final angiogram. Another case, slightly more complex. This man came in 2019 under the stroke team with a venous labia thrombosis and a stroke-like picture. So what is picked up by the radiologist was that there was a thrombosis near the vena flavae, but also equally you could see a lot of changes in the brain. There is a sign of a big AVM here, but so generally the brain looks very congested, a lot of veins all around. This is because he had venous sinus thrombosis of the posterior third of the sagittal sinus. So all the vessels were engaged. This is the area where he had the previous thrombosis, and this is a large AVM frontal lobe. So he was discharged from the stroke team, then came to my clinic. Then various options were discussed. It was not found to be suitable for any endovascular treatment, so he wasn't given any treatment. I had a long discussion whether to answer surgery given the complex nature of his vascular problem. Because the congested brain, there is an easily higher risk of bleeding if you attempt surgical excision. And this is the contralateral right ICA injection showing the big nidus, but it was mostly from the left side. This is again showing the branches. There's an ophthalmic branch, then showing the falcine artery which is going through the forks and supplying it. There are a few branches from the MCA and ACA, and a very quite congested brain. You can see also that there is feeder aneurysm, and also we found that he's got some aneurysm around the acorn. It's a very sessile aneurysm, which I can appreciate in this lateral view. While waiting for a final decision, he came back early this year with a subarachnoid hemorrhage. So it was a difficult situation where we don't know where he bled, whether he bled from the AVM or he bled from an aneurysm. This is the subsequent CT angiogram. Still, the brain looks fairly congested with a large AVM. Given that he had a bleed, we thought it's best to treat him rather than leaving it for the natural history. So attempted to treat him with embolization followed by surgery. So he had a good successful embolization, but they had to take a more proximal target. And you can see in this lateral view, the back of the sinus is all blocked. This is the preoperative angio picture. Then you can see also the feeders coming from the middle meningeal. So it's not only the parenchymal feeders, he had a meningeal artery supplying it. So these are things which you need to consider when planning for it. For example, this one is an intrahemispheric approach, anterior frontal craniotomy. And this is a forks. I'm just separating one of the forks falcine feeders. So delineating it so that I could cut off the falcine feeder to the avium. So avium is being here, the forks is here, the midline is here. So I will not go into the specific technique, just to mention that it is circumferential dissection. You have to identify the feeding vessel and trace it to the nidus, and only take out the abnormal arteries going into the nidus, and often one side of the artery can give feeders to the nidus and the other side can go to the normal cortical artery. So this is especially important when you are operating near the eloquent areas, because the rest of the artery may continue to pass on to the normal cortical areas. So this is that large AVM. Part of the embolization you can see, and also equally important, sometimes the AVM is covered by a normal cortical veins going into the sital sinus. So this is midline, this is the AVM here, and so spend a lot of time. So this is a coiled artery here. You can see there's some glue within it, and also this is a draining vein. But the glue, the interventional guys did actually had gone into this draining vein, so it's blocked it. But the main draining vein was intact. That's why he didn't have any further hemorrhage following the embolization. That is the concern with some of the interventional procedures. You can make a obstruction to the draining veins if it is not careful. You can see one of the feeders is coiled by the interventionist, but still it is still filled. So a lot of time is spent on identifying so this is sort of final stages, and there's the primary draining vein which is kept till last. They may require some clips. Sometimes they can have AVM clips, or often you may have to use aneurysms clips for more securing it. So as you know, this man had an acorn aneurysm, which we were not sure whether it bled or not. But because it's an interhemispheric approach, I decided to, at the end of AVM resection, go into the interhemispheric fissure from the top. Try and so I'm just sort of dissecting the. So this is the gyrus rectus being dissected from the top. Aneurysm is here. So it's a multilobulated acorn. I didn't see any rupture point. This is one nubbing here. There's another nubbing here, and separating the branch. There's other branches looping behind it. So I will put a clip, because it is not certain whether this had blood or not. Prior to we took him to theater, but having had that suspicion, decided to clip it. So this is him. He did very well, apart from the fact that 2 weeks later he had COVID, but he didn't have any major problem from the COVID infection. Push is also entirely different entity. They have feeders which are more anterior and maybe difficult to reach from the beginning, and often endovascular embolization and preoperative embolization is often helpful. And as you can see, many of them get supply from the meningeal branches. So that is another common thing with, especially near the trochlear. This was several years before, previously, a big bleed. And these feeders, the superior cerebellar branches and the anterocerebellar artery branches and also pica branches, all of them are coming to supply this big AVM. So some help from the endovascular team is useful to embolize some of these vessels which you come to last during an operation. So this is the post-resection without any issue. So in terms of positioning, often think about which feeders you want to see and where are the veins are. You need to locate the veins, which gives you a good landmark, and knowing the anatomy of the vein and the pattern of their flow can give you a good landmark. And navigation may even if you don't have a navigation, you can get to where you are. So this is a young man, unruptured AVM, left frontal lobe. The only thing he wanted was, you can see the primary vein and the smaller draining veins. Only thing he wanted was he didn't want any scalp incision. You know, his hair was precious, so he didn't want any I would have done it through a bicornal incision. So I had to do an operation through the forehead for it. And, you know, it is along with this screen crease, which he was happy with that incision. Okay, generally for AVMs, you prefer a large craniotomy because you want to have the proper anatomy and study the anatomy, looking at all the arterial feeders and identify them. So what I would say is that it's like a war. You need to know the enemy before you attack it. So once you know the anatomy and once you know where the feeders are and where the primary veins and secondary veins are, then it makes your life more easy. Then it's like in aneurysm surgery, we try to avoid interrupted rupture. So this is the same technique here. You get all the feeders first, and then it will be much more safer. So this is the most, I'll stop with this last case, which is the most recent case from last Wednesday. She came with a bleed in the right frontal lobe. She remained clinically well, very anxious psychologist. Here, the importance of studying the feeders. Here, this is the right ICA injection. There's an anterior cerebral artery feeder coming from the front, coming to the surface. You see the anterocerebral artery feeders, they all come from the medial surface of the hemisphere. So you're going to find them on the medial hemispheric surface. And there is another branch, which is again another branch of the anterocerebral artery, come from slightly more posteriorly, then it bifurcates. One branch coming straight up to the AVM, the other one goes back and then comes back here. So these anatomical features you have to keep in mind when you expose these AVMs. So this is the AP view, which gives you that perspective. The first feeder which goes into the AVM here, the other feeder comes here, bifurcates, one branch goes into the AVM, the other one goes back and comes back. So these are things which you will have to look for. And where is the draining vein? It's straightly onto the sagittal sinus. The small secondary one is more frontal, so which you can remove when you have to expose the deeper part of the AVM. Unfortunately, she had a big clot underneath, which is a useful thing because part of the AVM is also on the hematoma side. So there's a pile surface here, and there's an interhemispheric surface, and so there is a hematoma surface as well. Here, the first feeder that's coming here, and that is the branch which we noticed first, and there is you can see the cortical veins. You can see how I preserve the cortical vein by not dissecting of the dura. Here also I try to cut the dura along the vein, not try to peel it off to get more medial exposure. This part of the vein is arterialized, but this part is not. You can see the venous blood is just getting in a balance with the arterialized bed. So that means part of the AVM vein is draining into this part of the vein. Let's move it. So here, exposing that branch that comes straight to the AVM. And so if I followed this branch lower down, I could see this bifurcation, then the other branch goes more posteriorly. Here, this branch comes directly into the AVM. And this is what you see here in the MRI on the sagittal image. Here it comes, and then one branch comes directly, which is what I see here. So it's so this is the third branch, which is the branch that comes from that original medial branch, then comes the posterior one comes and back to the AVM here. So that is being clipped. So this is the other one which is being clipped, and so one by one all these branches will be clipped. So once you know that you got most of the feeders, because there will be some middle cerebral artery branches which you may not see because they are deeper. So this is the RGA branch that is being feeder, that is being, so 3 branches. So this is what I need to do in such cases: identify the 3 main feeders and then block them off. That gives you, then I check it with the turgidity of the AVM and the venous flow with the Doppler. You can also use ICG. We'll go on. This is the dissection, which is just around the AVM. The final parts of the AVM is being dissected off. So you can see already see the clot here. So that's helped. Otherwise, you'll have to dissect all the way around the AVM, and then finally the draining vein is cut. And also careful not to coagulate near the sagittal sinus too much. You don't want to have any thrombus going inside. So leave a stump of the draining vein here. The clot is being taken out. So she's doing really well. So I want to finish by saying that you need to study the anatomy in details. Always sit with the person who did the angiogram and take you through the vessels, and always try to look at all these scans and match up with each one, and then imagine what you're going to see on the surface. And also be mindful of the primary draining vein, especially when you try to dissect the AVM. Try not to put too much pressure on the vein, because if you do try to kink it, you can have an intraoperative bleed. Sometimes if you don't get on top of the bleeder, the AVM keep on bleeding, and then you will lose the control. So always be one step ahead and always be in control. And some cases will be useful to get preoperative embolization. And also in some cases where you think it's quite deep and you don't want to risk a neurologic deficit, also think of stereotactic radiosurgery. Thank you very much. I will stop here and
very good. Thank you, Ramesh.
Thank you.
Are you there?
Yeah.
Are you there, Nilesh? Are you there?
Yes, sir. I'm here. Thank you, sir.
Thank you.
And before we move on to the next speaker, there is an announcement because of some emergency. For the panel discussion, Professor Ayub Cherian and we, the whole team, won't be able to take part in this panel discussion. But I will request Dr. Natarajan sir, Parthiban sir, Wang, and Raghunath and Daniel, if possible, we can continue with this panel discussion online. Otherwise, if they are willing, then we can think about rescheduling it in some other time. So, what's their opinion?
Okay.
Professor Ayub has requested this.
Yeah. I think I'm Parthiban. Hello.
Yes, sir.
Yeah, I think so, because of the time concern,
Yes.
It looks like that. Maybe we can have it on some other day.
Yes, sir.
Maybe next meeting, I think it can be done.
We are planning in another 2 weeks, maybe on a next Sunday. We can have this panel discussion as a separate entity.
Fair enough, I think so, because the wonderful lectures just going on at daytime. No problem. Yeah, for me, no problem.
Parthiban, Regu
Yeah.
here. Yeah, I think I share your opinion. I think we can definitely have it on another occasion. When everybody is available.
Yeah, I think so.
Sure.
Okay. Thank you for the cooperation. Then we can have this panel discussion on the after 2 weeks on the next Sunday. We can have this in the evening.
Yeah.
At whatever time which is comfortable to, we will discuss this in our group. Then we post it.
Sure.
Yeah. Thank you so much, sir.
Thank you.
I will now invite the next speaker, Professor Casper. He will speaking about the nuances in the posterior fossa.
Okay, do you see my screen?
Yes,
sir. We can see.
Good. So, Ayub and team and Yoko, thank you very much for having me. I want to contribute with a talk on more intra-axial disease now, because we've heard a lot about CP angle and extra-axial disease, and I want to talk about nuances of the Telovela approach for intraventricular lesions reaching the CP angle. So first of all, are these intraventricular tumors a real challenge? And I think the answer is yes, because they're usually rare. They're surrounded by high real estate, and especially in younger staff, experience is lacking. But don't be intimidated. If you follow some principles, it really works. And there are many options out there for you to join. So what we want to look at is left side tumors that are located in the foramen Luschke, and tumors that are located in the ventricle proper. They're all pathologies that can be found in this arena. So for today, we just want to look at ependymomas, meningiomas, and maybe at the end, a neuroepithelial cyst as an example of how to tackle this problem best. These patients often present with vague symptoms. They are not tumor specific, but location specific. And in the P. fossa, you know, most patients present with a mixture of nausea, vomiting, dizziness, mental status change, maybe from hydrocephalus, occasionally combined with visual compromise, tinnitus, and apraxia. But often patients come with rather little symptoms and rather large tumors. Symptoms are non-specific, which makes these tumors often a late diagnosis, especially during COVID. We have noticed that patients often show up months later than expected, and you often find syndrome of the fourth ventricle, which are symptoms of the cerebellum in combination with obstructive hydrocephalus. So for your infront-territorial axis, there's several routes to get in, and it all started with Dandy, as you know. There are two classic approaches. One would be the transvermium approach, coming from medial to lateral, splitting basically the inferior half of the vermis to gain access to the ventricle on top, or you come in from far lateral transcondylar. I think this works lateral to medially well for located lesions in the CP angle or extra-axial disease, such as aneurysms and sometimes meningiomas. For intraventricular lesions, I've largely abandoned this. I think the far lateral approach has a very small field of view and also significant postoperative morbidity, because you really peel down the muscles along the side of the neck, and the patient is in significantly more pain and contraction than with midline approaches. The midline transvermium approach are also not so hot, because a lot of patients ended up with speech trouble, aphonia, dysarthria, ataxia, some truncal hypotonia, and even memory and cognition problems from a violation of the fiber tracts to the dentate. So don't go just through the midline. Really think about how you can do this best. The last time I used the transvermium approach was this case. This was a 14-year-old boy that collapsed in a soccer field, came in with a GCS of 3 and pupils small, 3 millimeter, but essentially fixed in mid position. No signs of external trauma. So when we got the scan, we got a CTA right away, and you see a large intra-axial hematoma fed by an AVM below. So this is the last time I did a midline hemicraniectomy bilaterally. Oh, I said posterior craniectomy. And we just made a mini tunnel approach to basically suck out the clot, leave a small portion on the AVM to stop it from rebleeding, but decompress the P. fossa. But this is really the only emergent axis where I think transvermium approach is still suitable. The real answer for the problems in this locale are the cerebellomedullary fissure approach, as championed by Roton's group and especially Matsushima. This is a beautiful approach that avoids splitting of the vermis and allows best access to the fourth ventricle and the lateral recess versus natural planes. This is the original publication. What you want to achieve is basically access to the mid portion of the ventricle up to the aqueduct. You can go laterally into the lateral recess, and you can attack tumors of the lateral wall, and you can go as low as the foramen Luschke. In a cadaveric overview, this looks a bit overwhelming. Initially, it looks complicated, but honestly, it is not. If you first follow a simple scheme, you identify your cerebellomedullary fissure as the space between the uvula and the tonsil. And as you follow that space lower down laterally, it's the space between the medulla and the tonsil. So it's not very different from looking at a Chiari approach. On the boards, they sometimes ask you about the boundaries of the cerebellomedullary fissure. Think about it in simple terms. The roof is formed by the inferior vellum of the fourth ventricle. laterally from the foramen margin D, laterally you have the talar choroidea curving over the limbus down to the lateral recess of the foramen Luschke. What do you find in it? The pica branches and branches in the veins of the cerebellomedullary fissure. For surgery, positioning is key. I think prone position is best. I don't do this sitting. Flexion in the atlanto-occipital joint and flexion in the cervical spine will help you a ton, which means the chin should be really tucked in with only a finger breadth below. So military position. I always use intraoperative monitoring to avoid stretch and not compromise the flow of the fourth ventricle. And I also use monitor evoked potentials. Positioning allows you to decide between a unilateral approach, which can be done in Fukushima's 3/4 prone position, can also be done concord, head down first, and you operate upside down, or I operate mostly in a position where the patient is prone with the head up, just like a Chiari. And this is what you would see, rather similar to a Chiari in this case. You want to start with a panoramic overview. So let's break this down into step by step. There are 4 surgical steps. First one is identify your fissure. Just like in Chiari, you want to see the tonsils, peel off the arachnoid here, and then insert a little spatula and lift up the tonsil 45 degrees laterally. I use a Greenberg retractor with a Ruggles blade or Fukushima blade. You can use whatever you like. In the end, what you want to do is you want to identify the obex and the overlying talar. And by identifying the talar, you cut 45 degrees lateral and out after coagulating the little vessels in the cerebellomedullary fissure. And then you expose your choroid plexus and you just follow the path until you turn over the limbus and can go to the foramen Luschke. This is how it looks without vessels in a cadaveric special. First, find your obex and the foramen, identify the talar. So find the talar and identify how to go towards the uvula laterally and the talovelar junction. Then you cut the talar after coagulating this at 45 degrees, and you can basically look into the lateral recess, and then you turn a corner and go down to the foramen Luschke. Same steps with the vessels in. Again, find the obex, which is sometimes compressed by the tonsils. Second step, put in your retractors and elevate the tonsils. Now identify the talar choroidea, coagulate these vessels carefully. This is with the zoom magnification. You see how beautifully these little vessels splay out. Bipolar this carefully, go at 45 degrees until you hit the lateral recess, and orient yourself. Whenever you have a problem, just take a step back and think, what are my overall contributors to this locale, and you will definitely stay safe. Now you have to make a decision of the extent of your opening. If you have a large tumor, you can do bilateral openings of the 2 components of the cerebellomedullary fissure. But if you have a unilateral tumor just going into the lateral recess, you can as well do just unilateral exposures. And if you truly have a tumor only sitting into the foramen Luschke, there's no need to open the upper portion, which keeps you safe. There's a beautiful paper by Tomasello in World Neurosurgery in 2015 that I really recommend to all learners. It comes not only with a beautiful diagram how to do it, it comes with a small video clip that takes you through the case. This is how it looks in his exposure. You identify the obex, you see the flow of the fourth ventricle with the stria medullaris, you see the tumor hanging down, identify the talar laterally, cut it 45 degrees, and he shows you how to suck out this tumor. Now, a few examples. This was a meningioma WHO grade 2. You can see that the tumor was relatively high riding in the fourth ventricle, so we had to pick a very steep angle. But if you flex the head substantially and you do a bilateral wide approach, you can elevate the cerebellum very nicely and go through a natural cleft without sacrificing any of the vessels, and the patient had a perfect outcome. This is a young child with a larger tumor, solitary fibrous tumor, again reaching almost the aqueduct, approached through the same way, easily accessible. This was an ependymoma, unilaterally more on the right than the left, and you see how intimately the pica is involved in this case. The talovelar approach really allows you to follow your vessels, and we were able to chisel out the entire tumor, and you see the pica still hanging in the breeze, We didn't lose a single branch. There was no post-operative stroke. The patient could be discharged 2 days after surgery. Now, if you do unilateral exposure, there's a beautiful paper by Jean and colleagues in neurosurgery. It's the same idea from midline to lateral by just elevating one tonsil. So as you identify your obex, the talar choroidea, you may have to mobilize the pica to make that 45-degree cut. But if you do, you see the choroid plexus and the rhomboid lip, and you can really gain access right to the foramen Luschke. These are lesions that you can take out, either small ependymomas, meningiomas, or lesions in the fourth ventricle, quite successful. This is a cavernoma on the opposite side, equally accessible, and intra-axial disease, but was nicely accessible through this approach. Now I want to show you two pearls. This was a case that came to me, which I really didn't know what this could be. Ring-enhancing lesion in the fourth ventricle in a patient who just had nausea and swallowing difficulties. On the T2 images, you see it is intra-axial dinging into the floor of the fourth ventricle, so his nausea was well explained. There was a nerve emanating on the T2 images just lateral to the lesion from the brainstem. We got CTAs showing low vascularity of the lesion, so I felt the risk was not too high to go after this. I got DTIs showing beautifully displaced motor tracts, which you can see here in blue, running deep to the lesion and then displaced to the contralateral side. So there's a good access corridor on the ipsilateral side. And again, we wanted to pay attention to the nerve, so we monitored this case. As we came in from inferiorly talovelar approach, we're able to chisel out 90% of the tumor, except the lateral wall of this tumor that turned out to be a ganglioglioma WHO grade 1. Each time we try to peel off the last part of this tumor, his 10th nerve was activated on intraoperative monitoring. With benign disease, I really didn't want to give the guy a deficit, so I stopped at this point, and I'm observing him since. If the tumor ever progresses, I may give him radiosurgery to this location. Last case is this talovelar approach for a unilateral biaxial disease. So this is, as you can see, a hypointense tumor occupying the fourth ventricle, but also splaying the foramen Luschke and wrapping around the brainstem. On DWI, you can see this is an epidermoid that sort of has a star-shaped configuration and distorts the tissue quite a bit. Here again, we were able to just use a standard approach and follow each of the crevices around the brainstem. DWI post-op shows complete resection and no stroke, so very suitable for this type of disease if you get the viewing angles right. So my summary is intraventricular surgery is fun. Think inside the box and know your anatomy really well. Be safe and sometimes zoom in, zoom out to reorient yourself. It sounds complicated, but it's actually quite doable. Think outside the box and be versatile with your approaches. Sometimes just do a unilateral approach and use your common sense with your strategies. You will see it's rewarding. Thank you very much.
Okay. Thank you very much. Do you want to introduce, is there another speaker?
Hello, John, can you hear us?
Yes, go ahead.
Yeah, thank you. Thank you, Professor. And and with this talk, the panel discussion is postponed to the 2 weeks after this on the next Sunday. And so with this talk, we conclude this conference. Thank you everyone for this attending conference and making it a grand success. We'll see you soon. Thank you for joining us.
Okay, yeah, I'd like to say a few words too. Thank you very much. We look forward to Krishna becoming hopefully a center for online education. And thanks for all the panelists. Thanks for putting all this together. And thanks, Pablo, do you want to talk about that conference you have Tuesday? Are you there, Pablo? Perhaps there's a conference with the WFNS, the Neuroanatomy Conference, on both Tuesday and Wednesday, I believe. Victor's Tuesday and Wednesday, correct? Perhaps Victor, everyone bailed on me. Okay, then. Thank you very much. We'll see you soon. Okay.